Belum dimulai kah? Okay, Cek mic.
Kok enak aja deh, nggak? Ada konflik, coba tanya direktur kalau saat coba bisa dengar. Yang itu yang menjadi review. Ada 4 orang nggak? Ada 2 tadi.
Pada bulan Juli tahun 2019, SK Menteri Riset Teknologi dan Pendidikan Tinggi Republik Indonesia nomor 596/KPT-1/2019 mengubah nomenklatur program studi D3 Analis Kesehatan menjadi program studi D3 Teknologi Laboratorium Medis atau TLM. Seiring dengan beralihnya nomenklatur, gelar untuk lulusan prodi D3 Teknologi Laboratorium Medis juga beralih dari yang sebelumnya Ahli Madya Analis Kesehatan menjadi Ahli Madya Kesehatan atau AMDKes. Untuk menjamin mutu dan keberlangsungan pendidikan, Prodi D3 Teknologi Laboratorium Medis sudah terakreditasi A oleh Lembaga Akreditasi Mandiri Perguruan Tinggi Kesehatan atau LAMPTKes dengan nomor SK 1017 pada tanggal 24 Desember 2016. Selaras dengan visi untuk menjadikan Prodi D3 Teknologi Laboratorium Medis sebagai kampus yang mampu bersaing secara global pada tahun 2024, serta unggul, mandiri, dan berbudaya dalam pelayanan diagnostik tuberkulosis paru dan penyakit penyerta, para lulusan Prodi D3 Teknologi Laboratorium Medis Poltekkes Kemenkes Manado telah berhasil tersebar di wilayah Indonesia, diantaranya pada instansi dinas kesehatan, rumah sakit, puskesmas, laboratorium klinik, Badan Pengawas Obat dan Makanan atau Badan POM, Balai Teknik Kesehatan Lingkungan atau BTKL, Balai Penunjang Pelayanan Kesehatan atau BPPK, KKP Udara atau KKP Laut, Nusantara Sehat atau NS, serta di berbagai macam instansi pemerintah atau swasta lainnya. Jumlah mahasiswa yang menempuh studi pada Prodi D3 Teknologi Laboratorium Medis tercatat sebanyak 953 orang, dengan jumlah lulusan sebanyak 626 lulusan. Program studi D3 Teknologi Laboratorium Medis Politeknik Kesehatan Kemenkes Manado juga memiliki tenaga pengajar dengan kualifikasi pendidikan magister dan doktor yang merupakan lulusan dari berbagai universitas ternama di seluruh Indonesia. Kesempatan belajar pada Prodi D3 Teknologi Laboratorium Medis juga terbuka luas hingga skala internasional. Beberapa mahasiswa pernah mengikuti berbagai macam kegiatan bertaraf internasional, diantaranya mengikuti short course program di Dongseo University, Busan, Korea Selatan pada tahun 2017 dan menjadi tutor ASEAN Science Camp pada tahun 2019. Sesuai dengan Tridharma Perguruan Tinggi, melalui kegiatan pengabdian pada masyarakat, Prodi D3 Teknologi Laboratorium Medis Poltekkes Kemenkes Manado tak hanya mengabdi di beberapa daerah di Sulawesi Utara, tetapi juga berhasil dengan baik mengabdi di berbagai daerah di luar Sulawesi Utara. Dengan tujuan menghasilkan tenaga kerja yang kompeten, Prodi D3 Teknologi Laboratorium Medis menyediakan sarana dan prasarana berupa gedung 4 lantai dengan fasilitas diantaranya ruang kelas yang kondusif, laboratorium yang terdiri dari laboratorium bakteriologi virologi, laboratorium parasitologi mikologi, laboratorium imunoserologi sitohistologi biomo, laboratorium hematologi, laboratorium kimia klinik, laboratorium kimia terapan, laboratorium toksikologi, ruang lobi, ruang himaju, ruang meeting, ruang klinik P3K, serta berbagai macam fasilitas lainnya.
Program Studi Diploma 3 Teknologi Laboratorium Medis atau TLM Politeknik Kesehatan Kemenkes Manado secara resmi berdiri tahun 2010, sekaligus mulai menerima mahasiswa baru perdana tahun akademik 2010-2011. Teknologi Laboratorium Medis merupakan program studi satu-satunya di Provinsi Sulawesi Utara sampai dengan sekarang. Untuk sarana dan prasarana yang menunjang baik pembelajaran teori maupun praktikum di laboratorium, kami memiliki sarpras yang sangat baik dan sangat lengkap, dan itu sangat mendukung kegiatan PBM di jurusan Prodi TLM. Sejak angkatan pertama tahun 2010 sampai dengan tahun 2021 ini, kami telah mendidik mahasiswa sebanyak 953 orang dan telah meluluskan 626 mahasiswa yang saat ini sudah bekerja dan tersebar di wilayah Indonesia.
Mari bergabung bersama Prodi D3 Teknologi Laboratorium Medis Poltekkes Kemenkes Manado dan bersama wujudkan Poltekkes Kemenkes Manado sebagai institusi pendidikan kesehatan vokasi yang unggul, mandiri, dan berbudaya.
Kak Sir, cuma di nama kegiatan tema.
Pada bulan Juli tahun 2019, SK Menteri Riset Teknologi dan Pendidikan Tinggi Republik Indonesia nomor 596/KPT-1/2019 mengubah nomenklatur program studi D3 Analis Kesehatan menjadi program studi D3 Teknologi Laboratorium Medis atau TLM. Seiring dengan beralihnya nomenklatur, gelar untuk lulusan prodi D3 Teknologi Laboratorium Medis juga beralih dari yang sebelumnya ahli madya analis kesehatan menjadi ahli madya kesehatan atau AMDKes. Untuk menjamin mutu dan keberlangsungan pendidikan, prodi D3 Teknologi Laboratorium Medis sudah terakreditasi A oleh Lembaga Akreditasi Mandiri Perguruan Tinggi Kesehatan atau LAMPTKes dengan nomor SK 1017 pada tanggal 24 Desember 2016. Selaras dengan visi untuk menjadikan prodi D3 Teknologi Laboratorium Medis sebagai kampus yang mampu bersaing secara global pada tahun 2024, serta unggul, mandiri, dan berbudaya dalam pelayanan diagnostik tuberkulosis paru dan penyakit penyerta, para lulusan prodi D3 Teknologi Laboratorium Medis Poltekkes Kemenkes Manado telah berhasil tersebar di wilayah Indonesia, diantaranya pada instansi dinas kesehatan, rumah sakit, puskesmas, laboratorium klinik, Badan Pengawas Obat dan Makanan atau Badan POM, Balai Teknik Kesehatan Lingkungan atau BTKL, Balai Penunjang Pelayanan Kesehatan atau BPPK, KKP Udara atau KKP Laut, Nusantara Sehat atau NS, serta di berbagai macam instansi pemerintah atau swasta lainnya. Jumlah mahasiswa yang menempuh studi pada prodi D3 Teknologi Laboratorium Medis tercatat sebanyak 953 orang, dengan jumlah lulusan sebanyak 626 lulusan. Program studi D3 Teknologi Laboratorium Medis Politeknik Kesehatan Kemenkes Manado juga memiliki tenaga pengajar dengan kualifikasi pendidikan magister dan doktor yang merupakan lulusan dari berbagai universitas ternama di seluruh Indonesia. Kesempatan belajar pada prodi D3 Teknologi Laboratorium Medis juga terbuka luas hingga skala internasional. Beberapa mahasiswa pernah mengikuti berbagai macam kegiatan bertaraf internasional, diantaranya mengikuti Pada bulan Juli tahun 2019, SK Menteri Riset Teknologi dan Pendidikan Tinggi Republik Indonesia nomor 596/KPT-1/2019 mengubah nomenklatur program studi D3 Analis Kesehatan menjadi program studi D3 Teknologi Laboratorium Medis atau TLM. Seiring dengan beralihnya nomenklatur, gelar untuk lulusan prodi D3 Teknologi Laboratorium Medis juga beralih dari yang sebelumnya ahli madya analis kesehatan menjadi ahli madya kesehatan atau AMDKes. Untuk menjamin mutu dan keberlangsungan pendidikan, prodi D3 Teknologi Laboratorium Medis sudah terakreditasi A oleh Lembaga Akreditasi Mandiri Perguruan Tinggi Kesehatan atau LAMPTKes dengan nomor SK 1017 pada tanggal 24 Desember 2016. Selaras dengan visi untuk menjadikan prodi D3 Teknologi Laboratorium Medis sebagai kampus yang mampu bersaing secara global pada tahun 2024, serta unggul, mandiri, dan berbudaya dalam pelayanan diagnostik tuberkulosis paru dan penyakit penyerta, para lulusan prodi D3 Teknologi Laboratorium Medis Poltekkes Kemenkes Manado telah berhasil tersebar di wilayah Indonesia, diantaranya pada instansi dinas kesehatan, rumah sakit, puskesmas, laboratorium klinik, Badan Pengawas Obat dan Makanan atau Badan POM, Balai Teknik Kesehatan Lingkungan atau BTKL, Balai Penunjang Pelayanan Kesehatan atau BPPK, KKP Udara atau KKP Laut, Nusantara Sehat atau NS, serta di berbagai macam instansi pemerintah atau swasta lainnya. Jumlah mahasiswa yang menempuh studi pada prodi D3 Teknologi Laboratorium Medis tercatat sebanyak 953 orang, dengan jumlah lulusan sebanyak 626 lulusan. Program studi D3 Teknologi Laboratorium Medis Politeknik Kesehatan Kemenkes Manado juga memiliki tenaga pengajar dengan kualifikasi pendidikan magister dan doktor yang merupakan lulusan dari berbagai universitas ternama di seluruh Indonesia. Kesempatan belajar pada prodi D3 Teknologi Laboratorium Medis juga terbuka luas hingga skala internasional. Beberapa mahasiswa pernah mengikuti berbagai macam kegiatan bertaraf internasional, diantaranya mengikuti short course program di Dongseo University, Busan, Korea Selatan pada tahun 2017 dan menjadi tutor ASEAN Science Camp pada tahun 2019. Sesuai dengan Tridharma Perguruan Tinggi, melalui kegiatan pengabdian pada masyarakat, prodi D3 Teknologi Laboratorium Medis Poltekkes Kemenkes Manado tak hanya mengabdi di beberapa daerah di Sulawesi Utara, tetapi juga berhasil dengan baik mengabdi di berbagai daerah di luar Sulawesi Utara. Dengan tujuan menghasilkan tenaga kerja yang kompeten, prodi D3 Teknologi Laboratorium Medis menyediakan sarana dan prasarana berupa gedung 4 lantai dengan fasilitas diantaranya ruang kelas yang kondusif, laboratorium yang terdiri dari laboratorium bakteriologi virologi, laboratorium parasitologi mikologi, laboratorium imunoserologi sitohistologi biomo, laboratorium hematologi, laboratorium kimia klinik, laboratorium kimia terapan, laboratorium toksikologi, ruang lobi, ruang himaju, ruang meeting, ruang klinik P3K, serta berbagai macam fasilitas lainnya.
Program Studi Diploma 3 Teknologi Laboratorium Medis atau TLM Politeknik Kesehatan Kemenkes Manado secara resmi berdiri tahun 2010, sekaligus mulai menerima mahasiswa baru perdana tahun akademik 2010-2011. Teknologi Laboratorium Medis merupakan program studi satu-satunya di Provinsi Sulawesi Utara sampai dengan sekarang. Untuk sarana dan prasarana yang menunjang baik pembelajaran teori maupun praktikum di laboratorium, kami memiliki sarpras yang sangat baik dan sangat lengkap, dan itu sangat mendukung kegiatan PBM di jurusan prodi TLM. Sejak angkatan pertama tahun 2010 sampai dengan tahun 2021 ini, kami telah mendidik mahasiswa sebanyak 953 orang dan telah meluluskan 626 mahasiswa yang saat ini sudah bekerja dan tersebar di wilayah Indonesia.
Mari bergabung bersama Prodi D3 Teknologi Laboratorium Medis Poltekkes Kemenkes Manado dan bersama wujudkan Poltekkes Kemenkes Manado sebagai institusi pendidikan kesehatan vokasi yang unggul, mandiri, dan berbudaya. Pada bulan Juli tahun 2019, SK Menteri Riset Teknologi dan Pendidikan Tinggi Republik Indonesia nomor 596/KPT-1/2019 mengubah nomenklatur program studi D3 Analis Kesehatan menjadi program studi D3 Teknologi Laboratorium Medis atau TLM. Seiring dengan beralihnya nomenklatur, gelar untuk lulusan prodi D3 Teknologi Laboratorium Medis juga beralih dari yang sebelumnya ahli madya analis kesehatan menjadi ahli madya kesehatan atau AMDKes. Untuk menjamin mutu dan keberlangsungan pendidikan, prodi D3 Teknologi Laboratorium Medis sudah terakreditasi A oleh Lembaga Akreditasi Mandiri Perguruan Tinggi Kesehatan atau LAMPTKes dengan nomor SK 1017 pada tanggal 24 Desember 2016. Selaras dengan visi untuk menjadikan prodi D3 Teknologi Laboratorium Medis sebagai kampus yang mampu bersaing secara global pada tahun 2024, serta unggul, mandiri, dan berbudaya dalam pelayanan diagnostik tuberkulosis paru dan penyakit penyerta, para lulusan prodi D3 Teknologi Laboratorium Medis Poltekkes Kemenkes Manado telah berhasil tersebar di wilayah Indonesia, diantaranya pada instansi dinas kesehatan, rumah sakit, puskesmas, laboratorium klinik, Badan Pengawas Obat dan Makanan atau Badan POM, Balai Teknik Kesehatan Lingkungan atau BTKL, Balai Penunjang Pelayanan Kesehatan atau BPPK, KKP Udara atau KKP Laut, Nusantara Sehat atau NS, serta di berbagai macam instansi pemerintah atau swasta lainnya. Jumlah mahasiswa yang menempuh studi pada prodi D3 Teknologi Laboratorium Medis tercatat sebanyak 953 orang, dengan jumlah lulusan sebanyak 626 lulusan. Program studi D3 Teknologi Laboratorium Medis Politeknik Kesehatan Kemenkes Manado juga memiliki tenaga pengajar dengan kualifikasi pendidikan magister dan doktor yang merupakan lulusan dari berbagai universitas ternama di seluruh Indonesia. Kesempatan belajar pada prodi D3 Teknologi Laboratorium Medis juga terbuka luas hingga skala internasional. Beberapa mahasiswa pernah mengikuti berbagai macam kegiatan bertaraf internasional, diantaranya mengikuti short course program di Dongseo University, Busan, Korea Selatan pada tahun 2017 dan menjadi tutor ASEAN Science Camp pada tahun 2019. Sesuai dengan Tridharma Perguruan Tinggi, melalui kegiatan pengabdian pada masyarakat, prodi D3 Teknologi Laboratorium Medis Poltekkes Kemenkes Manado tak hanya mengabdi di beberapa daerah di Sulawesi Utara, tetapi juga berhasil dengan baik mengabdi di berbagai daerah di luar Sulawesi Utara. Dengan tujuan menghasilkan tenaga kerja yang kompeten, prodi D3 Teknologi Laboratorium Medis menyediakan sarana dan prasarana berupa gedung 4 lantai dengan fasilitas diantaranya ruang kelas yang kondusif, laboratorium yang terdiri dari laboratorium bakteriologi virologi, laboratorium parasitologi mikologi, laboratorium imunoserologi sitohistologi biomo, laboratorium hematologi, laboratorium kimia klinik, laboratorium kimia terapan, laboratorium toksikologi, ruang lobi, ruang himaju, ruang meeting, ruang klinik P3K, serta berbagai macam fasilitas lainnya.
Program Studi Diploma 3 Teknologi Laboratorium Medis atau TLM Politeknik Kesehatan Kemenkes Manado secara resmi berdiri tahun 2010, sekaligus mulai menerima mahasiswa baru perdana tahun akademik 2010-2011. Teknologi Laboratorium Medis merupakan program studi satu-satunya di Provinsi Sulawesi Utara sampai dengan sekarang. Untuk sarana dan prasarana yang menunjang baik pembelajaran teori maupun praktikum di laboratorium, kami memiliki sarpras yang sangat baik dan sangat lengkap, dan itu sangat mendukung kegiatan PBM di jurusan prodi TLM. Sejak angkatan pertama tahun 2010 sampai dengan tahun 2021 ini, kami telah mendidik mahasiswa sebanyak 953 orang dan telah meluluskan 626 mahasiswa yang saat ini sudah bekerja dan tersebar di wilayah Indonesia.
Mari bergabung bersama Prodi D3 Teknologi Laboratorium Medis Poltekkes Kemenkes Manado dan bersama wujudkan Poltekkes Kemenkes Manado sebagai institusi pendidikan kesehatan vokasi yang unggul, mandiri, dan berbudaya.
Swastiastu.
Nama budaya, salam kebajikan.
My name is Mikhail Mefikumyang.
And my name is Jennifer Margaret Pontolawakang.
We are here together as the Master of Ceremony for today, 2023 International Seminar. Praise and gratitude to Almighty God. Because of His blessing, we can attend the international conference held by Department of Medical Laboratory Technology of Mahasiswa Polytechnic. The theme for today's conference is Interprofessional Collaboration in the Management of MDR-TB through Strengthening of Healthy Living Community Movement Program. The Honorable Director Provision of Health Workers, Ministry of Health, Republic Indonesia, Mrs. Osfatima Rosyati, Master of Health, the Honorable Director General of Disease Prevention and Control, Mr. Dr. Maxi Rendrondonu, DHSM Mars, as our keynote speaker on this conference. Honorable Director of Manado Health Polytechnic, Mr. Syamsu Alam, Master of Epidemiology. Honorable Head of Medical Laboratory Technology Department, Mrs. Elna Fikarambi, Master of Science. Honorable all of the lecturers in Manado Health Polytechnic. The honorable speakers, Professor Dr. Chandra Yoga Aditama from Indonesia, Dr. Linda Agustin Makale from Indonesia, Dr. Muhammad Khairul Taufik bin Rosli from Malaysia, Professor Dr. Delphab Oshandi from England, Dr. Febi Dwi Rahamadi from Australia, and all the honorable attendees in this place and in Zoom meeting.
Without any further, now we would like to show you our agenda for today's conference. The agenda will be displayed on the screen. For the sake of our convention, we would like to announce the do's and don'ts for today's conference. First, all participants must be registered. Second, all the participants must follow the goal events. Third, participants must complete and submit the attendance link that will be shared. At this time, we will pray, and the prayer will be guided by Mr. Arlan Latif. Time and place are welcome.
Ladies and gentlemen, before we start the international conference today, we gonna begin with my Malaysia. Let's pray. God, thank you for your blessing this morning. Now we will start the international conference. Please bless our student, children, and everyone in this occasion. Only in the name of Jesus Christ, I pray. Amen.
Thank you to Mr. Alan Latif. And now we will listen the speech and report from the committee chairman, Ms. Stefania Salanti. Time and place are welcome.
Shalom, Assalamualaikum warahmatullahi wabarakatuh. Om Swastiastu, Namo Buddhaya, Salam Kebajikan. First of all, let us give thanks to God Almighty that today we can gather here to participate in international conference from Medical Laboratory Technology Department of Manado Health Polytechnic. The Honorable Director of Health Workers Profession, Ministry of Health, Mrs. Osfatima Roshati, the Honorable Director General of Disease Prevention and Control, Mr. Dr. Maxi Rain Rondonuwu, DSSM, marks as our keynote speaker on this conference. Honorable Director of Manado Health Polytechnic, Mr. Syams Alam, Master of Epidemiology, Honorable Head of Medical Laboratory Technology Department, Mrs. Elna Fikarambi, Master of Science, Honorable all of the lecturer in Manado Health Polytechnic, the honorable speakers, and all the honorable attendees in this place and its meeting. The theme for today conference is interprofessional collaboration in the management of MDR-TB through strengthening of healthy living community improvement program. With this theme, we hope to implement the interprofessional collaboration of health workers in controlling tuberculosis, which is part of the TLM department mission. This event was held for 2 days. The first day is a conference with speaker Dr. Maxi Rondonuwu as Director General of Disease Prevention and Control, Professor Dr. Chandra Yoga Aditama as Director Postgraduate School of Yasi University, Dr. Randa Linda Augustine Makalem as teacher at Medical Laboratory Technology Department of Manado Health Polytechnic, Dr. Muhammad Khairul Taufik bin Rosli as Internal Medicine Specialist and Respiratory Fellow, Professor Dr. Delva Kushani as Leader in Cardiovascular Biology, Division of Cardiovascular Science, School of Medical Science, University of Manchester, and Dr. Febi Dwi Rahmadi as Lecturer in Global Health at School of Medicine and the Indonesian Program Coordinator for the Center for Environment and Population Health, Griffith University, Australia. The second day was filled with oral presentation and poster contest, which were attended by students. From this event, we hope that students will be able to international stage. In this event, there was 1,750 participants from various regions and from various regions in Indonesia and even from other participants who attended include students, teachers, and health practitioners. This conference can be held with the help of various parties. For that, I would like to thank this community, thank you, Manado Health Polytechnic, for helping to fund this activity so that it can be carried out. As well, Multilab and Instalab, which have participated as sponsor institute, and other parties that we cannot mention. I also convey my highest appreciation of committee members who have worked hard in the science. We realize that organizing this conference still has many shortcomings. For this, we sincerely apologize finally. I hope that all of conference participants who attended will benefit greatly from this conference. That's all I can say. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much to Ms. Susan. Ladies and gentlemen, we kindly invite you to rise for the Indonesian national anthem.
Thank you, ladies and gentlemen. You may sit it. Now, I would like to invite Mrs. Osfatima Rosheti, Master of Health, Director Provision of Health Workers, Ministry of Health, Republic Indonesia, to give welcoming speech and to officially open the conference. Time and praise are welcome.
Okay, thank you. Assalamualaikum warahmatullahi wabarakatuh. Good morning, greeting to all of us. The Honorable Director of Health Polytechnic Manado and the faculty member, distinguished guest speakers, and ladies and gentlemen. Warm greeting to all of you. I am Os Fatima, the Director of Health Worker Profession, Ministry of Health of the Republic of Indonesia. I would like to express my sincere gratitude and welcome you all to the International Conference of Professional Collaboration in the Management of MDR-TB through strengthening of healthy living community action program held by Health Polytechnic Manado. I'm honored to welcome our keynote and invite speakers, Dr. Maxiren Rondonowu, the Director General of Disease Prevention and Control, Ministry of Health. Thank you, Dr. Maxi, for your presence. We will improve our understanding, motivate, and urge us to highly participate in government program for healthier community. Then, welcome to Professor Dr. Chandra Yoga Aditama, the Director of Postgraduate Program of ERC University Jakarta, which also the former Director General of Diseases Prevention and Control, Ministry of Health. We are really happy to have you here to share your remarkable expertise. It will encourage us to develop better interprofessional collaboration program. Additional gratitude to our international speakers, Professor Dr. Delphak Osyendi, PhD from University of Griffith, Australia, and Dr. Muhammad Taufik bin Rosli from University of Tendit, Punjab, Malaysia, and Febi Dwi Rahmadi, PhD from University of Manchester, England. I'm sure we can have your international knowledge and experience for a better program development. I would like also to kindly welcome our colleague from Health Polytechnic of Manado, Ibu Dr. Linda Makaleo, passionate and active lecturer and researcher from Medical Laboratory Technology Department. As we know, tuberculosis remains as an important health problem in Indonesia and poses complex problems, social and economic. Based on the WHO Global TB Report 2020, Indonesia is country with the second highest TB burden in the world. To accelerate progress toward ending TB by 2030, Ministry of Health commit to transform the health system with 6 pillars, which are a primary health service, a referral health service, and then health systems resilience, health financing, human resources for health, and health technology transformation. Increasing community participation is one of the targets of primary health service transformation, where medical laboratory personnel play an important role not only in examinator for TB diagnosis and antibiotic resistance, but also in community education for participating in TB screening tests. This scientific seminar will completely align you personally to the interprofessional collaboration through strengthening of healthy living community action program on MDR-TB. It is our hope that we would like, it is our hope that we would be able to achieve its objective in providing an effective forum for academicians, researchers, and practitioners to advancing knowledge, research, and technology for TB elimination. Last but not least, my deepest gratitude to the committee and all colleagues at Health Polytechnic of Manado who have supported to the success of this conference. For all participants, we look forward to your continuous contribution for the community and the national goal to improve health status of Indonesia and global society. And with Bismillahirrahmanirrahim, I am honorable to declare the International Conference and Interprofessional Collaboration in the Management of MDR-TB to Strengthening of Health Living Community Action Program officially open. We all have fruitful discussion and enjoyable conference. Thank you very much. Waalaikumsalam warahmatullahi wabarakatuh.
Thank you very much to Mrs. Osfatima Roshadi. Now we arrive to our main agenda of today's conference, the presentation by the speakers. The first speakers that talk about follow-up treatment for MDR-TB patient. It will be presented by Dr. Muhammad Khairul Taufik bin Rosli, and in this session will be guided by Wahyuni Ramadhani, the student of Kendari Health Polytechnic, as the moderator. Wahyuni Rahmawani, the session is yours.
Is my voice clear? Yes. Okay.
Yeah, clear.
Thank you, Michael and Jennifer, for the opportunity. Assalamualaikum warahmatullahi wabarakatuh. Hello, good morning, everyone. Thank you so much for coming to join our conference. The honorable, all speakers, and all the participants of our conference today. Ladies and gentlemen, I'm Wahyuni Ramadhani Said. It gives me a great pleasure to be a moderator for this presentation session. Our speaker, Dr. Muhammad Khairul Taufik bin Rosli, will be delivered the presentation regarding follow-up treatment for MDR-TB patient. Again, hello, Dr. Khairul. Are you here with us?
Yes.
Yeah. Okay, now I'd like to read your curriculum vitae first.
Yes.
Name Dr. Muhammad Khairul Taufik bin Rosli from Malaysia. He is an internal medicine specialist and respiratory fellow at the Respiratory Department, Queen Elizabeth Hospital, Siti Kinabalu, Sabah, Malaysia. Some of his experience you can see on the screen. And this is his education and leadership. Okay, so that was his curriculum vitae. Now we will hear the presentation from Dr. Khairul. Before it, allow me to inform the duration of the presentation is 45 minutes and the discussion session will be in 15 minutes after the presentation. For reminder, the participants are asked to turn on the camera and turn off the audio. Okay, the Honorable Dr. Khairul, please, the time is yours.
Okay. Assalamualaikum warahmatullahi wabarakatuh, and very good morning. Can you see my slide and hear me clearly?
Yes, it can be seen, sir.
Okay. Okay. I think it was a last minute change in the schedule here because I think the follow-up treatment for MDR-TB follow-up treatment should be after the definition, but I think there is something's going on there, and you know, I need to present this follow-up treatment earlier than expected, but it's okay. Nothing wrong with that. So as you know, thank you, moderator, for a very nice introduction. And also thank you for inviting me to this very prestigious event. So especially who are always keep in touch with me, Dr. Linda. So as you know, my name is Muhammad Khairul Taufik. I'm actually working under Ministry of Health Malaysia in Sabah. I think it's quite nearby with your center as well. So at the moment, actually, I'm doing my advanced tuberculosis training in Western Cape, University of Cape Town, South Africa. So we are live currently. I'm doing this presentation actually in South Africa. So for your information, it's very difficult for me to keep awake. Now it's 3 a.m. In the morning in Cape Town, South Africa. Please, you know, forgive me if I'm not fully awake because it's, you know, because of the time difference, but it's okay. So this is about myself that I mentioned to you. I'm still working under Ministry of Health Malaysia, but now doing this training for advanced tuberculosis and also antimicrobial resistant, which is MDR-TB itself, and also XDR drug-resistant tuberculosis in this University of Cape Town, South Africa. So I think everybody knows one of the top country for MDR-TB is actually South Africa itself, and in South Africa, Western Cape, or the part of where I'm training now, is actually the highest number of TB cases or MDR-TB cases in the whole South Africa. So if you read WHO guideline, most of the study actually came from South Africa. So that's why I decided to further my study to subspecialize specifically for MDR-TB in this part of the world. So what we're going to talk today is actually a little bit on overview of current recommended regime, how to follow up patient in MDR-TB itself, and you know, a bit on troubleshoot during the follow-up TB itself. But we are not going to cover everything because you know, we have 3 groups of drug in MDR-TB treatment. If you want to go through one by one every side effect, I think we will take the whole day to explain all the side effects. But I think we will go through the most important one. For me, the most common and also the most life-threatening. So, and also it's important when you recognize all those side effect or adverse drug reaction, we should know what to do next. That's the most important thing, rather than you get all these side effect, but you don't know how to manage it. So a little bit on what is the current recommendation on drug-resistant TB treatment. As we aware that end of last year, WHO released a new updated version on consolidated guideline on tuberculosis, especially on drug-resistant tuberculosis. So in this guideline, in this new guideline, WHO actually recommend whenever possible, whenever the drug is available, you should give BPAL or BPAL-M regime for MDR-TB and pre-XDR-TB. So BPAL is actually consists of bedaquiline, proteminate, and also linazolid. So an optional, you can add moxifloxacin, or you can continue with BPAL or BPAL only regime. So all the patients who are actually aged 14 years and above, no exposure of bedaquiline and linazolid for more than 1 month, and also it's optional whether you want to add on moxifloxacin or you just can continue with BPAL alone. It's okay. And also it can be used to a pre-XDR patient. So they said before starting this treatment, quinolone resistant, we should check for quinolone resistant, and also, but it's not compulsory. You can always start the treatment first and also trace the investigation result later, because we know second line line probe assay for this patient, for MDR, especially for second lines up, the result can be up to 1 month, 2 weeks to 1 month. So no strong evidence to use this regime during pregnancy. And if the patient already exposed to bedaquiline or linazolid for more than 1 month, but the drug sensitivity result show it's still sensitive organism, so you can use it, you still can use this regime for those type of patient. And this is the current recommendation. They only try for PTB only and not for disseminated or TB meningitis. So if BPAL or BPAL-M is not available in your country, you should use the shorter all-oral regime, which is bedaquiline shorter all-oral regime. So this regime usually takes about 9 months to complete. And again, no previous exposure, no quinolone resistant, and also if you don't want to use etonomide, because of most of the patient will develop side effects, especially gastric intolerance. So in this type of patient, usually you can replace with only 2 months of linazolid. And also, again, WHO emphasized on quinolone resistant checking in the SD. You can use it in all age group and regimen with linazolid as well. This regime is also suitable for pregnant patient. So let's say if the patient is not fit for short all-oral regime treatment, then you should switch to longer regime. So usually it's an individualized regime for XDR patient, and the WHO said that you only can use this 18 months regime as a last resort. So, or it's a salvage. Some of the place call it salvage regime. Some of the place call it rescue regime. So this is what is the recent WHO recommendation. So I think after this, the other speaker as well will explain a bit more about this new recommendation. So before we start further to follow up, I mean, we need to know what is the new definition of XDR TB or drug-resistant TB that been updated recently. So basically, pre-XDR, MDR TB patient, which is resistant to rifampicin and also sometimes resistant to isoniazid, and also resistant to at least one of quinolone, which is either levofloxacin or moxifloxacin. XDR mean that you have rifampicin resistant patient, is either resistant to isoniazid as well, and also need to have resistant to quinolone and another group A, which is either linezolid or bedaquiline. So MDR, as we know, the definition is actually it's either multi-drug resistant, which is isoniazid and also rifampicin resistant, or it can be RR-TB alone. But the treatment for RR and MDR are actually the same treatment. So a new case, like I mentioned to you just now, new case mean that patient is exposed less than 1 month. So whenever you talk about follow-up in MDR TB patient, two main pillars you need to consider. The first one is you need to look, during the follow-up, you need to look for treatment response, which is really important. So at any point of time, patient is not responding well to our treatment, we need to switch the treatment, or we need to think about maybe switching the regime. So if patient on short regime, maybe we need to consider of switching to long regime. Another important pillars in follow-up in MDR TB is actually drug safety, because you don't want to give a drug that causes more harm than benefit to a patient. So that's why we need to have a very systematic way of reviewing all of this adverse drug reaction, and we need to aware all of the drug reaction, for all the drugs that we will give to patient beforehand. And please ensure that whenever patient need to take the medication that will cause highly cause side effect, with high likely to cause side effect, you need to always inform the patient and ask the consent from patient. So especially, the new emergence of MDR TB with bedaquiline resistant. So from my experience here in South Africa, we see quite a number of patients that is starting to show that resistant to bedaquiline, which is it's not a good sign. So in this type of patient, usually they will give meropenem plus clavulanic acid, and some of the patient, depend on sensitivity, they will give kanamycin or streptomycin. So whenever you want to give this injectable drug, you need to always explain to patient, especially when you give amikacin, you need to explain about all this hearing loss, ototoxicity, and patient need to aware there's a chance of that they will develop all these side effects before before you give the medication, because then the patient will always alert when they have a problem, then will ring you a bell, give you a signal that, yeah, this patient, this drug is causing me trouble, probably please, you can consider changing the regime or switching the regime. So this is two main pillars that is you need to look into whenever you follow up patient in MDR TB patient. So a lot of guideline available globally, and this is, I label few of the guideline that is explaining about all oral regime. Then as we know that since 2018, WHO itself switching from injectable to all oral regime. So the guideline that is published before 2018, it's somehow outdated. and because they are still practicing injectable regime. So depending which guideline you want to follow, I think the most important thing, we should have our own local based guideline. So globally, you will have WHO guideline as our primary source of reference. And for me, I found that South Africa guideline, South Africa guidelines a bit advanced from WHO itself, because most of WHO guideline will use the reference from will refer to the South Africa guideline whenever they want to come with new guidelines. So South Africa guideline, I think there's a new one that will be released probably mid or end of this year. That's a new South African guideline that will explain clearly on follow-up on new regime, which is BPAL. So WHO already start, all oral regime at somewhere 2018, but surprisingly, South Africa already start 2014. So after South Africa started all oral, then WHO followed. They take the reference from that. So another big group that contribute a lot to TB globally is actually the Union. I always love to see the Union guideline, because they are somehow always give a different view from WHO guideline. And also, like I told you, we need to have our own local guideline. Don't afraid to release our own local guideline for our own healthcare worker benefit, especially. So on your right side, you can see that is actually our own Sabah handbook. That we strongly think that there is a urgency, or there is a need to develop our local guideline based on our local facilities available, our local resources, and our local manpower. So that's why this is our first tuberculosis. It's cover drug sensitive and also drug resistant tuberculosis. It's really local based. I mean, we talk about what is the facility available, how to follow up, within our state, within our compound in Sabah itself. So I'm so lucky that I was the chairman of this book, and we have very good dedicated team. So whenever you talk about patient monitoring, three main components that you need to see: clinical assessment. Basically, every time you follow up the patient, consultation need to be on board, the examination, X-ray, and also the rest of procedure depending on your resources. So most of the clinical assessment, you will assess both either treatment response. You will ask the patient, you will examine the patient, ask patient what is actually going on for the past probably for the past 1 month, because you need to ask whether the patient respond to treatment or not, how the patient clinically, is that the week improving, especially the week, and also because the week and also the symptom is a very good predictor or very good marker for TB itself. Very difficult to interpret chest X-ray, especially in TB patient, because towards the end of treatment, somehow some of the patient, we think that chest X-ray is actually worsened, but it's actually not. It's turning active tuberculosis into fibrosis changes. So it's a part of recovering process. So don't worry too much if the patient showing worsening chest X-ray. You just need to ensure that the changes is not an active changes, it's just a fibrotic changes. The second one is bacteriologic assessment. We know that we need to send the smear, the culture, and also drug sensitivity testing. You need to also send check for all the second line sensitivity. Then also current WHO recommendations say that you need to send this culture possibly if you have the resource available, there we strongly recommend sending monthly sputum culture and also smear. So the other tests, the laboratory assessment depend on which type of drug you are giving. So basically, you want to monitor the side effect. We want to monitor the patient tolerability towards all this medication, especially the renal, the liver itself, and also the bone marrow. So whenever we talk about all oral regime, we know that the most, the pillar, the backbone of ATT, second line ATT is actually in group A and group B, which is quinolone, is either levofloxacin or moxifloxacin, linezolid, and also bedaquiline for group A. Group B is clofazimine and also cycloserine. So this is the most common drug that we are using now. So whenever you talk about group A, adverse drug reaction, I always try to separate it between it is life-threatening, it is just part of the side effect, and the most important thing, you need to ask yourself whether this adverse drug reaction or side effect of this drug is reversible or not, because it can affect the patient morbidity itself. So the most important the most important and the most significant adverse drug reaction for bedaquiline, moxifloxacin, and clofazimine, usually they are talking about prolonged QT interval from the ECG. So this is a life-threatening condition because whenever you have a prolonged QT and something stimulate, the extension of prolonged QTC, we are worried that patient will develop tosa de pois, which will cause sudden deaths in patients. So last time when we don't have this much knowledge, I still remember maybe 6 years or 7 years along the line ago, patient we start on ATT, we are not monitoring ECG that frequent, then suddenly patient develops sudden deaths and we don't know what happened. And day by day we are learning something here. We need to monitor ECG quite frequent, especially patients who are at risk of developing this prolonged QTC. So liver function tests, yes, this is one of the most common thing that's happening whenever you give anti-TB, whether it's a drug-sensitive TB treatment or drug-resistant. Yeah, liver function abnormalities is one of the common adverse drug reaction that will occur in patient. Linezolid, we know, this is the favorite drug that cause myelosuppression. Almost everybody will have some sort of drug suppression, myelosuppression. It's either it will cause thrombocytopenia or low platelet, anemia or low HB, or total white cell or neutropenia itself. So linezolid also, as we know, can cause visual disturbance, specifically will cause optic neuritis in some of the patients, and they explain that some of the condition of this optic neuritis is not reversible. So always check for visual disturbance for patient. So and also we know cycloserine or terizidone can cause psychiatric disorder. So other type of adverse drug reactions really depend on what is the treatment that you are giving to patients. So electrolyte imbalance commonly occur whenever you give amikacin, any injectable, or ethambutol. GI symptom, if you give etonomide, basically all of the drug can cause this GI symptom. This lactic acidosis caused by linezolid or bedaquiline itself. Some say bedaquiline also can cause lactic acidosis, hypothyroidism, protonomide, acute kidney injury, patient who are, the drugs that have been excreted through kidney can cause all this acute kidney injury, and also ototoxicity usually occur with injectable. So and also for treatment monitoring or patient response to treatment, we need to know what is the new definition of outcome definition. So treatment fail is actually a patient whose treatment need to be terminated or permanently changed to a new regime or treatment strategy. So few reasons can occur. So somehow patient have no clinical response or because of the drug reaction. So we need to switch the regime, especially linezolid based regime, and also along the process or along the treatment of TB, we notice there is a new resistance. So we label as a treatment fail whenever you need to change a new regime. Cure is a patient confirm bacteriological TB at the beginning of the treatment, and also at the end of the treatment, it show bacterial conversion and also clinical response to the treatment itself. Treatment complete is all the patient who complete the treatment by your local or national policies, but the outcome does not meet the cure definition, where cure you need a bacteriological confirm after the treatment or even before starting the treatment. So some of the patient we treat empirically and or cannot produce sputum towards the end of treatment, so we cannot have the cure definition for this patient. So dye, we know whatever caused the treatment, but the new definition state that even though if patient before starting the treatment but bacteriological confirm TB, and also you are not you not managed to start the treatment, you need to consider TB deaths as well. Die definition you should put as a die. So loss of follow-up, treatment success, the sum of cure and completed treatment. So how to monitor patient with TB patient? So I will give you some of the summary of monitoring table. So this is the summary that is available from this South African guideline. So you can see that you need a baseline investigation, and also each month you need something depend on what is your regime. It's either longer or I love to to have this type of this is how we follow up in Sabah itself, in Malaysia itself. You need to have this graph and make sure you are not missing anything. So at the starting of treatment, you need to include counseling, substance abuse, clinical evaluation, adverse drug assessment, all this important thing you need to have. You need to send all these second line agent. So as time goes by, we don't need to do all those things every month, but possibly if you have a resource available, they recommend to do all these things every month. But if not available, the resource is very limited, maybe you can try to escape, depend on your resources at your center. So this is our our own follow-up schedule for Malaysia itself, for Sabah in Malaysia itself. So we know that we have the capability of checking all this blood investigation every month, or for the first 2 weeks, usually all the MDR patient will be admitted to ward, except some of the patient, because it's very easy to monitor the patient, because most of the patient will have this side effect during first month of the treatment. So and also most of the patient don't mind to be admitted for 2 weeks, or some of them up to 1 month, until they get a very stable stable blood reading. So before discharge, so we include as a baseline, you should check visual acuity. This is something that frequently we miss, because as time goes by, especially when the incidence of linezolid induced optic neuritis is quite high. If you have a baseline, that will be good. So ECG, please ensure that you also check pregnancy test before starting treatment, because it will include additional value during your counseling part. And also for our TB, all of our TB patients who are female and in childbearing age, all of them, we are referring this case to pre-pregnancy clinic. So for pregnancy counseling and also for contraception counseling for this patient. So regarding X-ray in MDR, usually we are not recommending monthly X-ray, but we do recommend whenever possible, because we don't have X-ray facilities in all of our district clinic, so rural clinic. So some of the patients need to come to hospital or come to the clinic in the city center, which is about 30 or 40 kilometers away. So very difficult for them to come every month for X-ray. So we just usually recommend X-ray whenever we want to switch from shorter to longer regime, or from intensive phase to maintenance phase. And also it's also important to do adverse drug reaction checklist every visit for this patient. So regarding our new regime, BPAL protocol, so most of the BPAL protocol worldwide is actually still under operational research condition, so OR. So they have a very strict checking on this. They still don't have a very concrete guideline on how to monitor or how to follow up the patient on BPAR regime. So that's why all of our follow-up that is available globally is only based on operational research. So we know that whenever patient on operational research, we need to do the checking quite frequent compared to the standard protocol. So because they want to monitor, they basically don't know, they don't have enough evidence to conclude what is the absolute adverse drug reaction for this patient. So whenever you follow up the patient and you see something is not right, so patient is not responding to treatment, or patient have adverse drug reaction, you want to switch the regime and label them as treatment failure. So for South Africa itself, they recommend switching from shorter to longer regime if you detect a resistance to quinolone, if you have delay conversion, usually the culture is still positive at 4th month. Usually most of the patient, because of high efficiency of bedaquiline and also linezolid, most of the patient will have sputum or culture converted at the month, at 2nd month. But whenever you have culture positive in 4th month, it's always trigger your mind, well, this patient is not responding to whatever treatment you give, so maybe we need a different regime. So that's why South African a bit early, whenever you have a culture positive at 4th month, you should consider switching from shorter to longer regime. So but WHO said, yeah, you can wait until 6 months at the end of intensive phase. Whenever you have positive culture at 4th month, you always can extend to 6 months. So depend on your local policies, because I think South Africa, they have a lot of MDR. They experience most of the patients who are not responding at 4th month, most likely not going to respond towards all the treatment. So, and also if patient develop side effect due to all this drug, all the adverse drug reaction from bedaquiline, linezolid, so most likely linezolid, and this medication need to be terminated, maybe you should consider the patient is not eligible for a shorter regime. So what is a little bit on the new definition, because the new guideline has been released, and we know when the new guideline released, there's something new that we can learn. So they redefine about bacterial conversion. Conversion mean that sorry, whenever you have a bacterial confirmed TB, at least 2 consecutive culture, take 2 different occasions, is negative, so they put the timeline is 7 days apart. So you need, sometimes you want to say conversion, you need you take today and also tomorrow. So but now the guideline say that at least you need the duration at least 7 days apart when you want to take the second culture. So if both are negative, then you can label the patient as bacteriological conversion. So the revision is actually the other way. So you need to have 2 consecutive culture and 7 days apart. So, and if one of the culture or both culture turn out to be positive and previously already negative, then you can say this is a bacterial revision. So during the follow-up, it is important for us to always screen the adverse drug reaction. So whenever possible, don't miss. That's why this is South African guideline that mentioned about this. It's also, we also re-amplify into our guideline saying that this is sometimes we have tendency, because we see a lot of patients, so we have tendency to miss all these side effects. So that's why we make a checklist, our own checklist, just to make sure we are not missing anything. So you just tick the procedure whenever you have the positive the positive symptom based on one of these. It should trigger your mind, and also you need to act on those things. So we go about the most common or life-threatening condition that that can occur during the treatment. So for me, the most worrying part is develop the cardiac toxicity. I think later on, surely someone will talk about in detail about cardiac toxicity in MDR-TB treatment. So multiple guidelines explain regarding this problem, long QTC, how to manage it. So usually, WHO also mentioned, but they don't, they don't put into detail how to exactly manage the problem. So I can summarize for you how to manage the long QTC. So basically, if you have the reading between 450 to 470 millisecond acuity, you can always continue the monitoring. Or whenever you still, you have a problem QTC, but still less than 500, you can, somehow repeat the same ECG. If the reading is still the same, you always can close monitoring and maybe repeat the ECG next week or a week after that, and see if it is crossed beyond 500. So if more than 500, usually what we'll do, we'll rest all the drug first, or some of the experts say that you just drop one of the cause, one of the drug that will cause long QTC. Usually will drop group B drug, which is clofazimine first. So, and also please ensure that whenever you have long QTC, before dropping any of the drug, because we know in our MDR-TB treatment, we don't have much option. And also, whatever mistake or whatever changes that you do now, you're not going to see immediate effect. So the impact usually will take after 12 months. So, after 6 months, the patient will develop resistance to whatever regime that we gave if we don't give appropriate regime. So that's why don't simply drop all these anti-TB, look for all the surrounding causes of long QTC or whatever causing this adverse drug reaction before you stop the treatment. So usually I will check whether the patient on any antihistamine. Some of the patient are on prolonged antihistamine such as loratadine or Piriton, and also check the electrolyte, especially potassium and also magnesium. So usually we will recommend potassium around 4 per day, 4 or above 4, and also ensure magnesium. If they have long QTC, we aim magnesium around 1 reading. So the second most common side effect is actually anemia. So what the only guideline that explain properly how to manage linezolid induced anemia or myeloseparation is South African guideline. They really give you an option how to go about it, because most of WHO guideline, WHO guideline usually say, yeah, linezolid can cause anemia, you can stop it or you can change it to 600 milligram. Last time they used to give linezolid for the dose of 1,200 milligram. Yeah, that's how WHO inform us about how to manage linezolid induced anemia. But the best thing about South African guideline, they give you the exact way. So they put cut-off point is actually 8 milligram for, from my experience here, a lot of patients will develop myeloseparation, and as long as inpatient, they will accept up to 7 gram per deciliter. So if you are managing patient outpatient, because we know, very difficult for patient to come to you every day, or whenever they have symptoms, they cannot. Some of the patient cannot come to you immediately, so that's why they put cut-off point 8 for outpatient. For inpatient, we are usually a bit not so strict. So some of the patient, if 7, we still continue the linezolid with weekly monitoring of hemoglobin in patient. So few options to consider whenever patient develop HB drop less than 8. In here, the most common option usually will stop the linezolid. So we are temporarily stop the linezolid and check back the HB. Some of the patient we transfuse and aim probably 8, 9, then we will re-challenge the linezolid with similar dose, which is 600 milligram. Here we are in South Africa itself, we are not recommending to give 300 milligram linezolid, because I think a lot of patient, one of the professor in pharmacology here did a very nice study explaining about MIC for those patients in South Africa. I think, but African is a different ethnic, and in Asia or in Indonesia itself and in Malaysia itself, we have our own different ethnic. So that's why we need to come out with our own study or our own cut-off point, whether we can give 300 milligrams. So yeah, if we don't do that, then we don't know what is the cut-off of our population. So we need to follow the others. So that's why you transfuse and you challenge with linezolid. If the HB drop for second time, usually we are not challenging for the second time. We just omit the linezolid and change to either delamanid or other group C drug. So for the second option, whenever patient have drop HB, some of the patient, you always discuss with patient whether they still want, because the advantages of linezolid in short regime, we only give for 2 months minimum. So that's why it's not that long. Most of the patient who develop linezolid toxicity already finished their linezolid for at least 1 month. So it's another few weeks to go. We always discuss with patient whether they are willing to continue the medication. If they are not willing to continue with linezolid, yeah, we can substitute, but the patient is not eligible for short regime anymore. So yeah, number 3, we are using, because in South Africa, we are using our short regime, we are not using etonomide, we are giving linezolid instead of etonomide. So yeah, you can always consider not giving linezolid and give etonomide to this patient following WHO guideline. So whenever you have anemia in patient who are not eligible for short regime, so maybe you can either start the medication without linezolid and top up the HB, and after the HB improve, then you can give back the re-challenge with linezolid. Or option number 2, you just start the treatment without linezolid itself. So it's either way depend on patient preferability and also depend on your resource itself, how to monitor and your capability to monitor the patient, to start with linezolid. So the other type of myelosuppression usually is thrombocytopenia. So usually for thrombocytopenia, we stop the linezolid at grade 3, which is less than 50. So whenever you have less than 50 platelet or less than 2 total white cell, this type of patient usually we will stop the linezolid. Yes, some of the center you can find in PubMed study. Some of the center they give EPO, they give new poison to stimulate the myelosuppression itself. Yeah, some of them working. So the evidence is still lacking. The evidence is not so strong. It depends on your center. If you have a good experience in reversing this myelosuppression with EPO, erythropoietin, or also new poison, I think it's depend on resource. You always can consider giving it. For peripheral neuropathy, this is not a condition that usually we will stop. We will stop the ATT. Some of them can have very bad grade 3 neuropathy, commonly linezolid induced and also isoniazid induced. So, and most of the patients we are not stopping the linezolid because most of the patient, this side effect is actually a reversible side effect. So some of the patient will give pregabalin, and also please ensure again all the other cause of peripheral neuropathy such as alcohol use or diabetes, poorly controlled diabetes. So you need to tackle everything before consider stopping linezolid or isoniazid. So we give pregabalin instead of amitriptyline. So whenever you look for guideline for peripheral neuropathy, some of them saying that you can give tricyclic antidepressant, which is amitriptyline. So, but the problem with amitriptyline, it will cause prolonged long QTC. So that's why we are not giving amitriptyline. So we give pregabalin instead for peripheral neuropathies. So this is our famous next TB trial. So they said the most common side effect that they are encountering is actually peripheral neuropathy, but it's reversible condition, which is good. Optic neuritis, only 2 patients, and most of the patients are resolved, but the other study said some of the patients are not, it's not a reversible side effect. Another common side effect is actually myelosuppression. Whenever you stop and you restart the linezolid, usually you will overcome this myelosuppression. And as I mentioned just now, another common side effect is actually abnormal liver function. Same with Zenith trial safety. They compare about 1,200 milligram of linezolid versus 600 milligrams. So they say almost the same, no significant difference among them. So that's why they said, and also the outcome also not much different among them. So that's why they say that in the end they make a recommendation of the dose of 600 milligram is enough rather than giving high dose of linezolid. So this is peripheral neuropathy. Again, the same thing. The higher doses you give, the risk of developing peripheral neuropathy is actually very high. That's why in the end they recommend 600 milligram is enough for linezolid dose. So I just want to share about the MDR-TB program in South Africa itself. They are quite advanced. So this is
the time presentation is up and 10 minutes left.
Okay. I will go this one very fast. Okay, so this is an example of follow-up in South Africa itself. So very nice and tidy. They have their own book, so very easy for the clinician to monitor the side effect and also the drug. So I think every country should have their own follow-up book for this one. So for summary, patient follow-up is not about treatment, and it's always you need to think about patient safety, and also we need to now towards patient-centered less pill burden, and we need to know how to manage all these side effects. So you need to have your own framework for your local, following your local resource and capability. So this is my place in South Africa at the moment. So thank you very much for your attention. Sorry for taking that time.
Okay, thank you very much, Dr. Khairul. That was a very comprehensive presentation. So, ladies and gentlemen, after we know about follow-up treatment for MDR-TB patient, now it's time to have discussion with our speaker. And so for all the participants who want to ask question, you can write the question in the link we has provided. For question and answer time is 15 minutes, start from now. There is a question coming in. And then question comes from Nikadex Rianti. She asks about among the MDR-TB patient monitoring methods, which is the most effective for following up MDR-TB treatment. For Dr. Khairul, are welcome to answer.
So there is basically no right or wrong. For now, for our experience that we're using, I mean, I show you the table of monitoring that we are using in Sabah in Malaysia itself. It's quite good. But the problem is whenever you want to implement something like that, you need to ensure that you have enough capability and enough manpower to monitor. There's no right or wrong. You can follow a South African way of doing things, but the problem is I noticed that South Africa when I work here in South Africa, I noticed that in terms of laboratory, they are a bit advanced. They do a lot of reflex testing very fast, so easier for them to monitor certain period of time because they have the facilities. I'm not sure about the facilities in your place, but I strongly recommend you need to do everything depend on your own local resource, but no harm doing following the follow-up schedule using our Sabah guideline or South African guideline.
Okay, thank you, Doctor, for the explanation about this question. So now we are going to the second question. Operator, maybe you can share the question on screen. Okay, the second question comes from Muhammad Syam. He asks about, according to what that has been explained before, what are the most common problems in follow-up MDR-TB treatment and how to prevent them? Dr. Khairul, the time is yours.
Okay, so I think the most common problem is patient not coming for follow-up. So that's the most common problem. So it's very difficult and very tough for us to convince the patient to come for follow-up, for long regime, it's up to 18 months. So very difficult. So because we know TB already been labeled as disease of poor. So most of the patient need to work. So whenever they need to come to follow up, they will have the problem. They are the sole breadwinner, so a problem with finance. So that's the most I think the most challenging thing, because I think the other problem during follow up, such as this myelosuppression, you always can detect earlier, you always can send all this blood and detect earlier, but the problem is to get the patient to come to follow up. So it will lead most of them will end up lost to treatment follow up, then default the treatment, and the biggest problem will have drug resistant thing. So the way to overcome this thing is actually to have a very comprehensive network change between all the stakeholder, the government, and also all the clinician need to know how to convince the patient to come to follow up. So in Sabah itself, we have our own foundation, which we call Sabata. They provide the fund, especially for those who are poor and develop TB, who lost their job due to MDR TB. So they will provide the fund. So probably about 300 Malaysia ringgit per month. So they will give the patient for especially to come to encourage, to motivate the patient to come to follow up. So maybe you need probably you have the same thing over there. So maybe we need to strengthen that thing to improve our service.
Okay, thank you very much, Doctor, about that answer. And this is the last question, comes from Resi Unita. She asks about the difference between MDR-TB and XDR-TB. Please, Doctor, to answer it.
Okay, so MDR-TB, the definition haven't changed since, maybe 20 years ago. So the definition remains the same. So you need to have resistance to rifampicin and also isoniazid. So if you have both resistant, we call it MDR-TB. But if you have resistant, not isoniazid and also rifampicin, we call it's either mono-resistant or poly-resistant TB. So what is XDR-TB? XDR-TB is extensive drug resistant. So mean that you have MDR-TB. So the patient will have resistance to isoniazid and also rifampicin. On top of that, they will have a resistance to quinolone, which is levofloxacin, or any other group A drug, which is linezolid or bedaquiline. So if you fulfill this criteria, then we call XDR. So if you not fulfill the criteria, we will call MDR itself. So remember, MDR, it's a rifampicin and also isoniazid resistant, but XDR is extended. So rifampicin, isoniazid plus quinolone and also bedaquiline or linezolid. So that is XDR-TB and MDR-TB definition.
Okay, thank you so much, Doctor. Apparently, we still have any more questions to be discussed. However, due to limited time, we need to end our discussion session. Before I close this session, we would like to give a certificate for Dr. Khairul. Please, team, can start. Okay. Okay. We would like to give a certificate for Dr. Khairul for the insightful presentation in our conference. Hopefully, we can see you again in another agenda. Thank you so much, Doctor. And now we are going to take a documentation. Please, team, maybe you can share the certificate for documentation. Okay. 1, 2, 3, cheese. Okay. The next slide. 1, 2, 3, cheese. Okay, thank you very much, Doctor. And thank you for all participants. So see you all later. I give this session back to the MC.
Thank you, Ayuni. And now we will proceed to the next topic about diagnosis and management of MDR-TB through interprofessional collaboration, which will be presented by Professor Chandra Yoga Aditama. And in this session, we'll be guided by Yabes Purba, the student of Health Academic John Paul II Pekanbaru as the moderator. And for the Yabes Purba, the session is yours.
Okay, so is my voice clear? Okay. So the professor, are you here with us? Okay, great. Okay, previously, thank you to Michael and Jennifer, the MC, that has given the opportunity to me. So, good morning, Shalom, Assalamualaikum warahmatullahi wabarakatuh, Om Swastiastu, Namo Buddhaya, Salam Kebajikan. The Honorable, our speaker today, is Professor Dr. Chandra Yoga Aditama, Specialist in Pulmonology, Master of Hospitality Administration, DTMNH, DTCE, and FISR. Big thank to the professor for the tremendous effort to be our speaker and do it with full of spirit. And welcome to all the participants that attend in our webinar today. Before that, let me introduce myself. So my name is Yabes Purba, and as the moderator in today's second material with the title Diagnosis and Management of MDR-TB through Interprofessional Collaborations, which is going to be delivered by the Honorable Professor Dr. Chandra Yoga Aditama. But before that, let me read the CV of our speaker now. So, current job is Professor Dr. Chandra Yoga Aditama is a graduate director of PRC University Jakarta. So, there's go the CV and other activities. So yeah, so that was the CV of the Professor Chandra Yoga Aditama. And before continuing, let me inform that the durations of the presentation was 45 minutes, and the question and answer session will be held 15 minutes after the presentation. And being reminded again that during the presentation, it is hoped that the participants to activate the camera and turn off the audio. Thank you. And now we will enter into the presentations. So Professor, you may take the time.
Thank you. Good morning, distinguished colleagues, ladies and gentlemen. How should I? You want to share the screen or me? Okay. So first of all, I would like to congratulate Poltekkes Manado for having this international seminar. Secondly, this morning I just realized that it should be in English. I'm sorry that some of my slides are in Bahasa, not in English, but hopefully, surely you can follow it. But some of it, even the first one, is not in English. So, and certainly, I just would like to talk in general about TB and MDR. Looks like the previous speaker already talked in detail about the MDR TB as well. So, since I know the variation of the audience, let me begin with the TB in general. So, I'm sorry, I'm not feeling well. So TB, of course, in Indonesia, we use like this. It is a directly communicated disease. Directly communicated means it transmitted from one person to the other. For communicable diseases, we have several types. One is a type of directly communicable, so transmitted from one person to the other. But there is also another one transmitted through vector, for instance. So malaria or dengue. Even if you sit near of a dengue patient, you will not be getting sick because it has to be a mosquito transmitted the disease of dengue from one person to the other. But that is not in the case of TB because TB is transmitted from one person to the other. That is one point that I would like to begin with. Number two, TB is caused by the bacteria. So I know now everybody is talking about COVID-19. So COVID-19 is a communicable disease as well. There's also directly communicable disease, but it is caused by virus. There is also communicable disease. At least there are four types of cause of communicable disease. One is bacteria, Second is bacteria. For instance, this is TB. Second is virus. Third is parasite. And fourth is fungus. So there are 4 types. But back to TB. So TB is about, caused by bacteria. And this is the name of the bacteria. And it was found in 1882 by this person. So this person is Dr. Robert Koch, who found Mycobacterium tuberculosis, the cause of TB, in 1882. Why I put this 1882? Because it's already more than 140 years ago. And up to now, more than 140 years, TB is still with us. TB is still with us after 140 years. And no country in the world, I can say, no country in the world is already free from TB at now, after 140 years old. If you compare it with COVID was discovered in 2019 or even 2020. Of course, it is still with us, but even this one, discovered in 1882, but TB is still with us. I will discuss MDR after this, but anyway, this is just in general. So this guy, Robert Koch, is the one who found Mycobacterium TB in 1882, and this is the one that he found. So this red one, here the red one, is the bacteria that was found by him. At that time, TB was a very #1 killer in Europe. So that's why he got Nobel Prize, because he found this Mycobacterium tuberculosis. So it is about bacteria. It's not about ethyl spirit or whatever. So this is about bacteria. But still, again, it is still with us. Can I have the next slide, please? Next slide, please. Operator. Okay. This is how TB is transmitted from one person to the other, because I said this is a directly transmitted disease. So if somebody cough, then what should I say? The bacteria going out from his cough to the others, like this. And then after other person, inhale the bacteria from this person, it will go to the lung. So that is how TB is transmitted. As I said, it is a directly transmitted disease. Next slide, please. Because it is inhaled, so most of the TB will go to the lung, because it's coughed by somebody and then inhaled and going to the lung. But the TB itself, it's not only possible in the lung, because from the lung it can go to other organ as well. Bone, it can go to brain, it can go to skin, it can go to many parts of the body. So TB is begin in the lung, but it can end up in any part of the body, not only in the lung. So it's not only a pulmonary disease; it can also become a skin disease. It can become other kind of diseases. That's the first issue. The second issue, this is very important. The TB can attack anybody. Anybody means any age, any social status. Poor people, undernourished people, but even rich people, even student, even professor can also get TB. So it can attack anybody. Of course, it depends on their immune status, but anyway, basically it can attack anybody. That's the second issue. But the third issue, what is important is it can be cured, totally cured, if the patient take the medication until completed. So if the patient take the medication completed, then the TB will be cured. But if it is not completed or it is not proper, so the disease will not be cured. Even it can worse or even death. And what we will discuss is it could be it could. So the drug cannot kill the bacteria again. So this is the issue that it is important for us in the topic of the MDR-TB. Next slide, please. I think the operator should be ready because looks like it's delayed. So these are the treatment. I will not go into the detail of how people get the treatment, but basically the primary treatment, I could say, is a 6 months of 2 months INH rifampicin pyrazinamide ethambutol, followed by 4 months of INH and rifampicin. If we are talking about health, of course we know that there is an evidence-based medicine. So this kind of treatment is a strong recommendation by WHO and based on high certainty of evidence. So these are the drugs usually to give TB. Then if TB patient receive this drug, he or she will be cured. But if he or she did not take the drug appropriately or not complete or not in line with the procedure, so he or she could be resistant to INH, to rifampicin, or to pyrazinamide, or to ethambutol. And that is problem because that create the multi-drug resistant or TB resistant. So that is the first issue of the medicine. So this is the medicine that is firstly given to patient. And the WHO recommendation is to give it daily, every day. The use of 3 times a week is not recommended. So the tablet should be taken daily, and then it is recommended to receive the tablet by fixed dose combination. So it's not loose drug. It's not one tablet INH. I mean, it's not INH and then rifampicin take one by one. Because if you take one by one, people might forget one or the other. So that's why in a combination of fixed dose combination, so one tablet or one pack, it will include all of this drug. So just taking one together, it is more easier for patient to take the medication. It could be one tablet, or it could be in one pack. So these are basically the treatment that given to patient. And of course, now there is new recommendation of this 4 months regimen. But as you can see here, here you can see strong recommendation, high certainty of evidence. Here, the new one is not strong recommendation; it is conditional recommendation, and then moderately certainty of evidence. So it's different. Oh, did you see my cursor here or not, moderator? Moderator, are you here with me?
Yes, Professor.
Did you see my cursor or not?
No, I didn't.
Oh, because the slide is given by the organizer, yeah.
Yes,
I
Prof.
think it is given. It is better if it is possible. It's better if I share my screen by myself. Is it possible? So I can use my cursor. Is it possible to I share my screen by myself? Okay, so I'll do that. Yeah. This is the one that I just talked. So for this kind of treatment, it is strong recommendation, high certainty of evidence. For this 4 months, it is conditional recommendation. So it's not as strong as this one. And the evidence, this is high certainty. This is moderately certainty of evidence. So again, the treatment is like this: 2 months rifampicin, INH, pyrazinamide, and ethambutol, followed by 4 months INH and rifampicin, and where it should be daily, 3 times a week is not recommended, and please use the fixed dose combination. So if this medicine is not taken care, taken by the patient appropriately, then the resistance will be appear. But before talking about the resistance, let me begin talking a little bit about the TB elimination. As I said in my first slide, so this disease was found in 1882, more than 140 years ago. And up to now, there is no country who has no TB whatsoever. So the issue of elimination of the TB is mentioning from year to year since 20, 30 years ago, but up to now, it is still not happening. So people are trying, not only in Indonesia, but globally, how to eliminate tuberculosis. So now not now, but in the SDG, I'm sure all of you know that now the global, we have Sustainable Development Goals, SDG. And in SDG, the target is in 2030, and of the epidemic of several diseases, including tuberculosis. So the global target that was made in 2015 is the end of the epidemic of TB in 2030. Yeah, this is my book so many years ago, but anyway, and how do we monitor what is the indicator of stop the epidemic of tuberculosis? These are the indicator. The percentage of reduction of TB death compared to 2015 on 2020 become 35%, and then the target is 90% in 2030. This is reduction of number of TB deaths. So reduction 35%, then reduction become bigger, and then on 2030 reduction of TB death compared to 2015 is 90%. Reduction of death. This is reduction of incidence. So hopefully in 2010, not hopefully, yeah, the target incidence going down 20% on 2020, going down 50% in 2025, and going down 80% in 2030 to be able to reach the target of end of epidemic. And then percentage of TB affected household facing catastrophic costs due to TB is, yeah, this is difficult because there's no basic data on 2015. Anyway, so these are the target on 2020, 2025, and 2030 to be able to reach the SDG in 2030. Basically, after the SDG was announced, there are progress quite good. So notification is increased. Notifications means number of patients that can be found and then notified. Success rate is also increased. Sorry, where is my cursor? Success rate is also increased. There is also steady decline in TB death. So it looks like everything. See, the death is going down. The notification is going up. So it looks like it's good from time to time. And then on 2020, people say, okay, so it is good. Everything is going down from 2015, and there are several targets then that were mixed by United Nations high-level meeting to detect and treat 40 million people, to give preventive treatment for 30 million people, to increase budget, and then, as I said, there is an NTB strategy like this. So people are very optimistic that the plane of TB elimination is going up. Is going to take off on 2020, and hopefully the target 2030 will be reached. But then COVID is there. So we know COVID, has impact all aspect of not only of health but all aspect of humanity. But in case of TB, of course, it is also have a big impact for TB control globally. So TB and COVID become then another important issue for these last 2 years, for the last 2 or 3 years. And because of COVID, there is a setback of TB, setback going back, mundur ke belakang, 5 to 8 years because of COVID. So what the progress that we have reached, then going back 5 to 8 years. There is another additional death occurred because of TB during COVID era. This is not because the COVID disease influenced the TB disease itself, but because all of the priority of everybody, of the health personnel, is going to taking care of COVID. So the TB is neglected. It's not getting enough priority any longer. So because of TB is not getting enough priority any longer, then it is a setback. Number of deaths increasing. Of course, you know that this is not only TB. Because of everybody give a priority to COVID, then any other diseases now increase, and not any other. Some other diseases are increased. For instance, we have an outbreak of polio in Aceh. There is now number of morbidity cases increase. That is all because of people are giving most of the priority, or even only priority, to COVID only. So other diseases was neglected and is still neglected as of now. So this is example for TB. This is globally. I'm not talking about Indonesia. A setback in a national TB death. It was mentioned firstly that for instance, 2018, when there was no TB, there was no COVID. I'm sorry. There's about 1.49 million deaths because of COVID, because of TB. Sorry, I'm so sorry. 1 of 49 million deaths because of TB in 2018. In 2020, during the COVID time, and that's because of TB is going down from time to time, always going down. But in 2020, it's not going down; it's going up from 149 to 185. Why? Because people are, as I said earlier, people are taking care of COVID in their priority globally. So TB is neglected in a sense. So this is talking about what? See, this is saying 100. This is on January, I think, if I'm not mistaken. January 2020, the prediction additional 190,000 deaths. Then later on, it became 1.85 million. And then later on 2021, it said there is an additional 500,000 of TB deaths. So in this, you can see the number of deaths is increased because of COVID-19. And now, since COVID-19 is more or less is more controllable, even though pandemic is still with us, we do hope that priority to TB is become better in the coming time. So that's why, again, I would like to congratulate the Poltekkes for having this international seminar for TB to wake up all of us that TB is an important public health problem to be taken care globally as well as in Indonesia. So in Global TB Report on 2021, it is mentioned because of COVID, the global TB targets are mostly off track. It was on track before, but because of COVID, it became off track. There are increase of tuberculosis deaths because of COVID. There are a number of people in treatment of TB is going down. Reduction of people receive treatment because of TB treatment on 2019 2020 compared to 2019. Why? Because people are afraid going to the puskesmas, because again priority is given for COVID, etc. So it gave really an impact on tuberculosis situation. This is the global TB report in 2021, and this is the latest one, global TB report in 2022. It was published in October last year, so it's just several months ago. It mentioned the impact of COVID. It is mentioned also here the 3 countries. So number of TB, newly diagnosis is going down, not because of there is no TB, but because it cannot be found because everybody is taking care of COVID only. So. And this is dangerous because if you cannot find TB patient, that means he or she is still having the disease, he or she is still sick, and he or she is still transmitted to other people. So there are 3 countries that reduction is not good. Again, reduction means bad because people cannot find the patient in the community. So 3 countries with the most reduction were India, Indonesia, and the Philippines. So we are one of them, because we cannot find the TB patient who are on the field. So that means the patient is still there in Manado, in Jakarta, in Bandung, in Surabaya, and still sick and still transmitted to other people. So that's why, once again, I would like to congratulate this international seminar because using the topic of TB, and hopefully next year in Global TB Report 2023, we are not again mentioned as the one of the 3 countries that most reduction. This is not good at all. Now, coming to this topic of the discussion, in the Global TB Report on 2023, it's also mentioned that other negative impact of TB during COVID include fall number of people receive treatment for rifampicin resistant and MDR resistant. So not only ordinary TB, but TB with resistant, also number of people who receive treatment is going down. Number of people receive treatment is going down, not because the patient is going down, but because we cannot find the patient. So the patient is sick not only with TB, but also resistant TB, and we cannot find them, and we cannot treat them. So that means he or she is still sick, and he or she is still transmitted the disease to other people. So this is the last report on 2022. And then I just heard that there was a question to the previous speaker regarding the definition of TB. This is Indonesian terminology for it, isn't it? So this is TB resistant obat. So drug resistant TB. Resistant happen because some mutation. If treat TB patient. So some are the sensitive will be killed, but some mutant will be reproduced and then become resistant. And there are two types of resistant. That is the primary resistant, secondary resistant. Primary resistant in the happening in the human or people who never received any TB treatment before. So fresh case in a sense. Secondary resistant is resistant in a person who received TB treatment before. So maybe he or she didn't take the drug regularly or appropriately, so this become resistant. But primary resistant, he or she never take any medication. So he or she get the resistant transmitted from other people. So why resistance happen? It could be because of the provider, health personnel. It could be because of the patient. It could be because of the national TB program itself. What is the role of provider? Maybe provider did not give a proper diagnosis. Maybe the treatment is not in line with the national standard. Maybe the doses, the type of medicine, the number of medicine on duration of treatment is not adequate. Maybe the provider did not give a good education to the patient. So if this one happening because of the lack of the provider, resistance could happen. On the patient itself, on the patient part, maybe the patient do not or did not take the TB medication appropriately or regularly. Maybe the patient stopped the medication before the recommended time. Maybe some difficulty in absorption, and maybe some comorbid happening. For the third possible of resistance happening in Manado, in Jakarta, in Surabaya, because if the medication, the TB treatment is not available, but I'm sure this is not the case for Indonesia. I know after this, the Dirjen or Ministry of Health will inform you that there is no problem of medication whatsoever. And also, if the quality is not good, again, these two are not a problem for us in Indonesia, but this one and this one is still a problem. So that's why resistance is happening from time to time. There are two risks also. I mean, there are two possible risks why people get drug-resistant tuberculosis. There is a high risk and there is a low risk. High risk is in line with the nine criteria, and low risk is, for instance, TB in children, TB and HIV, etc. So these are the 9 category that consider to be a high risk tuberculosis, a high risk to get resistant, to become resistant tuberculosis or to get resistant tuberculosis. I will not go into the detail, but you can just read it. Failure of the category 2, not confession in 3 months in the category 2, has a history of TB treatment not standardized using quinolone, etc. Failure on category 1, not confession as well, relapse, loss to follow up, having a contact with the resistant tuberculosis, and then it's a several criteria that is mentioned here. So WHO on the global TB report 2022 have 5 categories of drug-resistant TB. First one is the isoniazid resistant TB, so only resistant to isoniazid. Number 2 is RR, that means rifampicin resistant TB. So this is only resistant to rifampicin. This is the one just I heard it was asked to the previous speaker. What is MDR-TB? Multi-drug resistant. Multi-drug resistant is defined as resistant to rifampicin and isoniazid. So this is only one. Isoniazid, this is only one. Rifampicin and MDR is resistant to both of it together at once. So that is MDR-TB. Then after MDR-TB, there is also an XDR, but even before XDR, there are pre-XDR. So X could be extensive, X could be expanded. So this is multi-drug resistant. This is expanded or extensive drug resistant. So pre-XDR TB is TB that is resistant to rifampicin and any of the fluoroquinolone. That is the definition on the on that book. And the XDR TB that is resistant to rifampicin plus fluoroquinolone plus bedaquiline and linezolide. So these are the definition. There's another definition saying that pre-XDR is the MDR with resistant also to fluoroquinolone, and the XDR TB is the MDR and also resistant to fluoroquinolone, and then resistant also to one of the drug of bedaquiline and linezolide, which is now used for the MDR TB treatment. So there are 5 types of drug resistance. Again, this is from the Global TB Report 2022. The problem now is this is global data, not only Indonesian data. I'm sure Pa Dirjen or whoever from the Ministry of Health will share with you the Indonesian data, which is almost the same, I could say. So this one is now, this is number of people. This one is estimate number of MDR and rifampicin resistant TB. This one, and this one. So it's about 1/3 of it. The blue one is people diagnosed. I mean, found to be MDR or rifampicin resistant TB. The blue one. So you can see, we globally can only find these people out of this number. So it should be this number. But we can only find this number. Sorry?
Pardon me, the time is 10 minutes left.
Okay. How many time? Because I'm just beginning. Is it already 45 minutes?
It's 10 minutes left. 10 minutes left, sir.
Is it already 35 minutes? I'm not so sure. I just want to ask, to clarify.
Yes, sir.
Okay. But I'm just beginning. Difficult to say. Anyway, so these are the number of MDR TB globally, and we can only find this number. So you can just tell me if it is finished, and then I will just stop. Okay? Please tell me if it is finished. I will not speed up the presentation because if I speed up the presentation, I cannot give the content. So I will just speak slowly. But if you said finish, I will stop. Okay? You got it, moderator?
Yes, sir.
Okay. So these are of number of MDR TB globally, and people can only find this one, this number. So about 1/3, and out of the cases founded, only this one be treated. So that means that this is another saying that globally we cannot treat the MDR TB properly. See here, the target is this one, and we can only get it 43%, all ages. For children, we can only get 15% of the total. So the one treated is only 40% of the total. So the remaining 57% is not founded, is not treated, is still having the disease and still transmitted to the other. If this is continued from time to time, the number of MDR problem is not going to decrease. It is even going to increase. So that's why we need to know this situation. We have to found the MDR TB cases and to treat them properly for them not to become the source of infection, to make the problem more difficult in the future time. So in the global TB report, there is a list of countries of high burden TB countries. Basically, there are 3 types of high burden TB countries with a big problem of TB. Basically, there are three types of TB problem. One, TB in general, that is the red one. So the country in this red one, in this red blocks, is country with problem with TB in general. So we can see Indonesia is here in this red one. In this yellow one is a country with problem on TB and HIV. That is in this one. This is problem TB and SIP. So for instance, Sierra Leone, even though here in this TB one, but it has no problem in TB and SIP because TB and SIP is the yellow one like this. But Indonesia here, it is in the red box as well as in the yellow box. And for MDR-TB, it is the blue box. So this is the blue box. You can see here, for instance, Russian Federation, it's a problem in TB SIP, but not in the MDR-TB. But Indonesia is in the blue box as well. So in this case, Indonesia globally is a problem for TB. It's a global burden for TB in general. It is a global problem for TB and SIP in general. It is one of the high burden of TB and SIP, as well as a high burden of MDR and RDR, rifampicin resistant TB. So this is our problem up to now. This is the latest data, as I said, published in October 22. So I do hope that after this international seminar, it could increase our TB control, so we could be, see the situation better next year. This is just again the map will show how many countries it is mentioned here. 7 countries with the highest burden of MDR and RRTB. So here, Pakistan, India, Indonesia, Philippines, China, and Russian Federation. So for MDR-TB, Indonesia is one of the 7 countries with highest burden of MDR and rifampicin resistant tuberculosis. Here it is mentioned again, 10 countries that account about 70% of the global gap. Global gap means gap between incidence of MDR-TB and number can be treated into a treatment. So the gap is happening mostly in the 7 countries. That is 70% of the global gap. 7 countries means it is China and again Indonesia again. So we are having problem with this TB in general, and we are having problem in a TB for MDR and rifampicin resistant. Oops. That is this. I will not. The detection will be detection of MDR-TB will be happening by rapid molecular test. I'm sure Pak Dirjen will talk about this one. What is the Indonesian procedure for TCM? We call it here, and culture as a sequential technologies. And the treatment, it is already mentioned. Basically, is the all oral regimen, which is only 6 months. That is much better compared to the older regimen, which is 20 months. That's already, I think it's already explained earlier. So the WHO recommend to access all oral regimen, which is only 6 months. I'm talking about for MDR-TB, yeah. But the treatment is for MDR-TB is more difficult compared to ordinary TB, because treatment for people diagnosed with rifampicin resistant and multi-drug resistant is more difficult and require drugs that cost more side effects, because already mentioned by the previous speaker. So the national success rate is about 50 to 75%. So number of people is like this, and the coverage, I mean the one can be found is only this, and the one is treated only this, and even if it is treated, only 50 or 75% will be cured. So that means again, there are still a lot of MDR and rifampicin resistant patients out there, not cured and transmitted to other people. That is for MDR. And if it is for XDR or pre-XDR, it's even more difficult, and treatment success are typically much lower than 50 to 70%. So that means we have to prevent MDR to be happen, because if it is happen, it is more difficult. Its success rate is very low, and it is more side effect. So these are the treatment. I'm not going into the detail. So these are the treatment for drug-resistant TB. Short regimen, it is mentioned. This is the longer regimen. and then this is for pulmonary resistance. This is still under operational research. This is the way that given to patient. I will not go into this there because I was mentioned it's still only 1 or 2 minutes, but I hope that Pak Adjudan will mention because this is Indonesian procedure what to give, and this is several criteria when to give the long-term treatment. This is the duration of the long-term treatment, and this is several side effects that could happen if patient receive this treatment for MDR and condition. So at the end, I will just say 1-2 minutes about the Indonesian target. So our President Jokowi already mentioned that, already stated that let's do something to eliminate TB on 2030. And he also already declared a presidential decree to the targeted TB elimination on 2030, and these are the target that the president have in his instruction. So we do hope that 2030 bye-bye epidemic tuberculosis. Maybe this is too optimistic to say, but it is what the president said. And of course, we have to do our very best that reduce the incidence and reduce the death of TB from this number to this number by 2030. Even though now we are still high compared to other countries. And then for MDR-TB, I already mentioned 70% are in this country, including Indonesia. And what is good that during the G20, TB was also taken care. TB was also become one of the agenda of the G20, and it was mentioned not only about how to treat, but also the importance of investment, because investment to TB is a very good investment. Every dollar, every rupiah count, it gives you a very good impact. So, terima kasih, thank you, Pak Moderator, colleagues, ladies and gentlemen.
Thank you very much to Professor Dr. Chandra Yoga Aditama, who has brought very interesting material about diagnosis and treatment.
I'm sorry, I cannot hear you. Moderator, looks like your voice is breaking.
Is it clear now, sir?
Yes.
Okay. Thank you very much to Professor Dr. Chandra Yoga Aditama, who has brought very interesting material about diagnosis and management of MDR-TB to the professional collaboration. Now we are entering the question and answer session. So for all the participants who want to ask questions, you can write down the questions on link to a form below the comment section with the format, name, country, region, institution, and questions. For question and answer session, time is 15 minutes start from now. Okay, there is a question from Michael P.L. Tumbo. When viewed from the development of antibiotics such as cephalosporins and others that have been developed up to the third generations, why are there not so many new types of antibiotic for MTB being found? So that from the past until now, MTB drugs are just that.
So, you know, if we discuss not about TB, but about antimicrobial resistance. Antimicrobial resistance is another important problem globally. So even people say that antimicrobial resistance is a silent pandemic. So the antimicrobial resistance happening when people do not take antibiotics. This is not about TB. Do not take antibiotic properly and then become resistant to that antibiotic. One of the problem of antibiotic, one of the problem of taking AMR is basically, even though you said that there are new cephalosporin or other, but basically the new antibiotic found is not as fast as the AMR is increased. So that's why AMR become a problem for us. Even though there are new antibiotic, it's not as fast as the increasing of the AMR. This is also the same for TB. Even worse, because AMR, antibiotic in general, it has a good market. It has a good financially market. So people are making that new antibiotic more easily. Even though again, it's not reaching the fast increasing issue of AMR. For TB, is something like that, but even worse. TB is not as quote unquote as sexy as an antibiotic. So people are not very eager to make a new antibiotic. I mean anti-TB treatment. Even though now there are several new treatment, it was already mentioned. There are Delamani, there are several linezolide, etc. So there are happening. There are several new antibiotic anti-TB treatment now available. That's why there are new guidelines for MDR and rifampicin resistant TB. So agree with you. What should I say? Attention to TB is not as good as an infection in general.
Okay, so we go to the second question.
Okay, so about treatment of TB in COVID-19, TB or MDR or not MDR, basically it is the same. I mean, you have to treat the COVID and you have to treat the TB patient itself. But of course, for MDR, there is another issue. There are some drug interaction, but it's not that important. There are some drug interaction happening. There are some consideration to be taken care of. But now we can just say that COVID treatment is a short. It's only 4 days or 5 days or even 7 days. That is only the COVID treatment. And the treatment of TB, MDR TB, it is 6 months or even longer period is 8 months. So there's no problem in a sense. So you can get the COVID treatment and you can get the TB treatment, including the MDR TB treatment.
Thank you for the answer. Now we're going to the third question. How does TB attack other organs of the body?
Yeah, because if the TB bacilli comes into into the lung, then it become make some kind of what should I say, primary focus there, and from there transmitted by bloodstream to other part of the body. So transmitted from other person is I'm sorry, from other person is by inhale going to the lung and then transmitted to by blood in that patient to bones, to glands, etc.
Okay, thank you, sir, for the answer. But there is no other questions. So thank you for Professor Dr. Chandra Yoga Aditama. That answer marks the end of the session. After the end of this conference, the committee will share the handout for all topic in the conference. And now we will give an appreciation in the form of an online certificate to our honorable speaker. Now counting backwards from 5, 4, 3, 2, 1. Keep, please share the screen. So there is an appreciation certificate for our honorable speaker. Now we will take the documentation before the end of the session. So for all the participants, please turn on the camera. So I will take a documentation for us. From the slide 1. 1, 2, 3, 5. Next slide. 1, 2, 3, 5. Next slide. 1, 2, 3, 5. So with the end of the question and answer session of the material that was presented, I hope all questions can represent the audience. I also hope this material can be useful for all of us. And once again, thank you very much to the professor for bringing in a very interesting material. Good morning. I'm going to give it back to the master of ceremony.
Thank you, Abis. And thank you for Professor Dr. Chandra Yoga Aditama. But before we continue, we remind you to fill the attendance link in the comment section. Now we will proceed to the next topic about controlling MDR-TB through strengthening of healthy living community movement program, which will be presented by Dr. Imran Pambudi, MPHM, as our keynote speaker. And in this session, we will be guided by Nofri Nonta, the student of Manado Health Polytechnic, as the moderators. For Nofri Nonta, the session is yours.
Okay, thank you, Michael and Jennifer. Shalom and good morning, the honorable speakers and all the participants of this conference. I am Nofri Nonta, the moderator in this session. The speaker in this session actually is Dr. Maxi Rondonu, the SEM, Mars. However, Dr. Maxi is unable to join with us right now. For that reason, the topic will be presented by Dr. Imran Pambudi, MPHM. Dr. Imran will present a topic about controlling MDR-TB through strengthening of GERMAS. It is now my pleasure to introduce Dr. Imran. Dr. Imran is the Director of Prevention and Control Disease of Communicable Disease Ministry of Health, Republic Indonesia. Okay, now we will hear the presentation from Dr. Imran, and the duration is 45 minutes. It is hoped that all participants will follow the presentation carefully, because at the end of the session, there is a quiz about the topic. And if you already have a question, please write down in Q&A link in the Zoom chat. Okay, Dr. Imran, welcome to present the topic.
Yeah, thank you, the moderators. Good morning, everybody. So in this moment, I will present how we can handle MDR-TB patient through the GERMAS. So let me share my screen. It is shown now. Okay. Yeah. So maybe this is already explained by Prof. Chandra Yoga, the presenter before me. So, and I think I want to highlight that nowadays Indonesia has 969,000 new cases per year for the TB, and the incidence rate is around 354 per 100,000 population. So this is the timeline. So in 2030, we have target to decrease by 80% of the incidence. And it means that we should have the incidence around 65 per 100,000 population. And also the death rate decreased by 6 per 100,000. And since the incidence cannot be calculated every year, so we have outcome indicators. So the first indicators is about treatment coverage, second is success rate, and the third is tuberculosis prevention treatment, or TPT. Which are, if we look for this one, so the TPT indicators is still lagging behind if we compare to the treatment coverage and also success rate. So this is the achievement of the treatment coverage. So nowadays we can notify around 74% of estimated TB burden in Indonesia. So this is the best achievement of Indonesia in 5 years in a row. So nowadays we have notified around 720 thousand cases until December 2022, and it's still increasing. The number, because we know that the delay of the entrance of the input of the data still occurs in the tuberculosis. So in our dashboard, we monitor that the delay time is around between 1 week until 3 months. So that's why even though we are stopped in December, but still the number is still increasing, maybe after March usually, until March. And if we look here, we can see that several provinces already reached the target. Jakarta, Gorontalo, Banten, and also Jawa Barat, West Java. West Java has very good achievement, around 120%. And if we look here, which is the Sulawesi Utara, it's not in the best provinces. Oh, this one. Yes, okay. It's more than 80%. So it means that in Manado and North Sulawesi, the effort to notify cases is quite good. It's around 80%. So this is the treatment coverage. If you're finding the cohort in 2022. And we also knew that our president, Joko Widodo, has very good concern to tuberculosis. That's why in 2021, he declared a presidential decree number 67 regarding of tuberculosis control. And in this presidential decree, there is the guideline for implementing tuberculosis control for all ministries, provincial, regional, agency, village, healthcare association, and professional organization, also all of the stakeholders. It means that tuberculosis is not the health sector issue anymore. So every sector should be hand in hand with the health sector to eliminate tuberculosis in Indonesia. So we already identified that at least 15 ministries or agencies in TB elimination by 2030. So, for example, in the Ministry of Manpower, they declare the regulation of the Minister of Manpower number 13 in 2022 about tuberculosis control in workplace. And in the mid-January, they have the week of what we call K3, the occupational health week, and the theme of the occupational week is about TB. So I think this is a very important moment that not only health that care about TB, and the other sectors, we call it the Ministry of Villages. They also declare the regulation number 8 in 2022 about the prioritization of village funds And one of the prioritization to use village funds is about how to use the fund to tuberculosis activity. And I want to glance also about the health transformation, health system transformation in Indonesia. So we have 5 pillars. Yeah, one of them is about the healthy movement culture, or we call it Germas. And in the health system transformation, we have 6 pillars. One is the primary care transformation, secondary care transformation, health system resilience, health financing transformation, health talent transformation, and also health technology transformation. And especially for the TB, we will put in the health system resilience transformations about the strengthening emergency response resilience, and also how we can use health technology transformation. And of course, we also support or include in the improvement of the primary and secondary care for these pillars. Yeah. And I want also explain to you, all of you, about how we will accelerate TB elimination program. So the main program for the acceleration of the TB elimination is we want to notify or detect all of the TB cases in Indonesia. So how we can improve the TB case detection? We have the several program, and we will focus on the effort in TB screening in risk population, and also investigation of household contacts, increase access to TB diagnostic services, optimization of TB recording and reporting, and also the expansion of TB prevention therapy. So for active and passive case finding, we have investigation of household contact, symptomatic screening and X-ray on inmates in prison, symptom screening and X-ray in diabetic patient, symptom screening and X-ray for household contacts in 25 priority districts, which are, we identified that 25 districts is the high burden for the TB cases. And the other is we want to expand the laboratorium examination network, especially to make a networking to all of the puskesmas and the health facilities, including how to transport the sputum for the specimen. And the other is we want to endorse, how all of the specimen can be tested by the molecular rapid test. Because until now, we distribute more than 1,800 gene expert machine throughout Indonesia. And we also identified we have around more than 500 districts that has minimum 1 machine in 1 district. So this is the access of TB services. So you can see here that this is the map of distribution of gene expert. That the total number is around 1,800 machine. And also we have also the map of the culture laboratory here. And also one of the our main purpose is we want also to expand the MDR TB treatment referral services. And if we're talking about MDR TB treatment referral services, we know that during COVID-19, most of the hospitals in Indonesia, they develop or they build the isolation room. So it means in time being, the COVID cases decrease. Yeah. So we can use, I think we can use this investment of the isolation room for the COVID. We can convert to MDR TB treatment site, because the hardest or the biggest part of this MDR TB treatment is how we can develop the isolation room. So it means that if the isolation room is already there, so we can use it. And the other points, the other effort is we want to expand of tuberculosis preventive therapy. Since we already have the modeling, and based on the model, even though we can find or we can notify all of the TB cases, and treat them all, but based on the model, still Indonesia cannot reach the target of elimination TB in 2030 if we don't treat the latent TB. So that's why we should expand the tuberculosis prevention therapy to the household contact, since they are already infected but not manifest. So we have to treat them with the TPT. So if we're talking about the role of civil society organization in the presidential decree about tuberculosis control, we have several points that they need to be taken. One, or first, they have to support the effort of national TB program in identify service quality challenges by providing feedback on the patient-centered service quality. The second, they should provide data on barriers to access TB services that will be used by stakeholders to improve the quality and also improve the way to make a solutions of this one. The third, we need them to strengthen response to health and community services to eliminate stigma and discrimination. Because one of the challenges, the biggest challenges of TB program is the stigma. People who diagnose tuberculosis usually they got like not confidence enough to show to the public, and sometimes they are also bullied by others. So we have to protect them also. The other point is we need them to create a supportive environment for TB patient to achieve successful treatment, because if they don't get the support from the community, from the family, it's very hard for them to continue the treatment, because the treatment is quite long, minimum 6 months. And the other things that we need them to help public education campaign to increase knowledge about tuberculosis. And the last is to mobilize resources to strengthen community activities, as well as having a TB task force to create an environment without stigma and discrimination against TB patient and also family. So yeah, if we group for how the community, especially the TB survivors, to support TB program, we have 3 indicators. First, how they can support the TB case finding. Second, how they can support the treatment of TB patient. And the third, how can they support for the TB prevention therapy program. So I think that's all from my presentation. I hope it helps all of you to get more knowledge about the program in Indonesia and how we can hand in hand together health sectors like us, Ministry of Health, provincial health office, district health office, and also the education like polytechnic, to with strengthen our collaboration. I believe that we can eliminate tuberculosis from Indonesia. So thank you. Back to you, to the moderator.
Okay, thank you very much, Dr. Imran, who has delivered a very interesting presentation. Now we enter into this presentation. For 30 minutes, we will answer the questions that come into the Q&A link in the Zoom chat. For participant who wants to ask, please write your question on Q&A link. Okay, I get the first question. The first question is, what are the factors that cause high TB cases in Indonesia? Is it clear, the question, doctor? Excuse me, doctor.
Okay. So thank you for your questions. So the factors that TB is still high in Indonesia. First factor is we cannot find all of the TB cases. So it means that we cannot stop the source of infection. So soon, if we can find all of the TB cases, I believe that the numbers will decrease. The second, our success rate is not good enough. It means that even though we found the cases and we start to treat them, but they are not finished for the treatment. It means that they still contain, or they still have the possibility or probability to spread the disease to others. And the third, our nutritional status is diverse. For example, for the poor people, the nutritional status is not good enough. And this nutritional status that not good enough will lead to people to infected TB. And the fourth is also our housing is not good enough, especially for the poor population and also the one who live in the very dense population, especially in the urban. Yeah. So the ventilation is not good enough, and if one of them are TB and are not treated well, so they can spread the infection to others. So I think that's some factors that why Indonesia is still high, the population. This the what we call the incidence of TB in Indonesia is still high. I hope it clarifies.
Okay, thank you, Dr. Imran, for the answer. Now we move to the next question. The second question is, what are the biggest challenges faced in controlling MDR-TB in Indonesia? Dr. Imran,
I'm sorry, can you repeat once more time the questions?
What are the biggest challenges faced in controlling MDR-TB in Indonesia?
Oh, controlling. Okay. Yeah. So if we know that maybe Prof. Chandra Yoga already explained that to treat MDR-TB patient need around at least 1 year to treat. So maybe you can imagine how you can consume the medication for the one year uninterrupted. And if you know, the drugs for the MDR-TB is not only one capsules, it's quite amount of the capsules or tablets. Yeah. So it means that how we can to keep the patient still have the spirit to consume the treatment, it's very crucial. So the support from the family or the neighborhood of this patient should be very strong enough to keep them consume the treatment. Second, usually the one who has MDR-TB usually cannot have the job because they are very weak, and also usually if they are work, the company usually or sometimes they expel them, so they don't have any money to live. So this also the problem. Sometimes they should choose. They should have to work every day, or they should treat every day, because the treatment of the MDR-TB in previous, maybe 2 years ago, they still need to be injected every day. So it means that they should go to the health facility every day. So they cannot, cannot go to work. So this is also the challenge. And the third challenge is about the stigma. Like I mentioned you before, TB patient, especially MDR-TB patient, usually not get along with the community. They are what we call isolated. And this isolated usually leads to demotivation, leads to unmotivated. So I think there is 3 big challenges of how we can treat MDR-TB in Indonesia. Thank you.
Thank you, Dr. Imran, for the answer. And the next question is from Resi Unita. What is the relationship between community stigma and patient medication adherence? Is it clear the question, doctor?
No. Can you repeat one more?
What is the relationship between community stigma and patient medication adherence?
What is the relationship between community stigma and patient medication adherence? What I informed you before that, if someone get stigma from the others, from the community, usually they are not motivated, and then they don't want to be treated or continue the treatment anymore. So it's strong relation between community stigma and also patient adherence. So I think it's very clear. So one of our what we call our program with the community is we want the community organization to support, hand in hand with their family to support the patient. So we should protect the patient to continue the medication, because once they lost to follow up, once they not treat well, they will lead to the worst stage of tuberculosis, because there is several stages of tuberculosis. First is sensitive tuberculosis and resistant tuberculosis, and in this resistant tuberculosis they have another level. So one what we call single resistance, and then dual resistance, and the others is multi-resistance. What we call multi-resistance drugs resistance. So if the patient get to the multi-drug resistant level, it's very worse, and usually the treatment will reach around 2 years for the treatment.
Okay, thank you, doctor. Now we move to the next question. Question from Ray. The obstacle that being commonly present on public health care would be the limited infrastructure and tools to manage the tuberculosis test. What could be the intervention of health ministry on this case? Thank you. The doctor are welcome to answer.
Yeah, so for the TB, I think I agree that not all of the puskesmas cannot treat tuberculosis, since the what we call the tools, the infrastructure is not sufficient, especially for the laboratory. So it means that we prepare for the referral microscopic diagnostic. So we have the ratio that maybe 1 per 5 puskesmas will be the TB referral therapy control. And in that puskesmas, we distribute or we put the gene expert machine. And we also treat, or not treat, the what we call the, we also equip them, the puskesmas, with not only gene expert, but also we provide the internet system, yeah, to support the information system, yeah, with the SITB, and also we provide the health provider with the training, yeah, for the TB treatment. So yes, that not all of the puskesmas can treat TB properly. Yeah. So we divide, yeah, in several puskesmas to be the referral center for the TB diagnosis, and then we put the gene expert machine in that health center. And the other is also the what we call the hospitals. Yeah, we also we hope that all of the district hospitals can be referral for the TB patient, yeah, to be treated.
Okay, thank you, doctor. Now we move to the next question. The question is for Linda Bacaleu. Has Indonesia been affected by TB treatment with reduced funding from GF?
Yeah, I think nowadays, yeah, our funding from APBN, from the government, is quite big enough. Yeah, and if we can maintain the amount of this fund from the APBN, I think we can replace, yeah, the funding from Global Fund. Of course, yeah, nowadays still the Global Fund money for the TB program is around 30%. So if we can maintain, yeah, and increase the budget from the APBN, I think we can cover all of the expenses for the TB treatment. Like now, for the cartridges, for the drug, yeah, we can procure, yeah, from our budget from the APBN. So the Global Fund money we use for the enabler, yeah, and to support the community organization to support the TB patient, and for the some of the money is for to procure the gene expert machine. But yeah, around 70% of the TB program already funded by APBN.
Okay, doctor. That answer marks the end of this session. We apologize for those questions which could not be answered due to the limited time. But after the end of this conference, the committee will share the handout for all topics in this conference. Last but not least, we will give an appreciation to Dr. Imran in form of e-certificate. So for IT team, please arrange the screen for documentation. Okay, thank you. Now we will take a document for all. The participants who will be able to turn on the camera, please activate your camera. Okay. Slide 1. 3, 2, 1. Slide 2. Slide 3. And slide 4. Okay, once again, I would like to say thank you for Dr. Imran and the participants. I apologize for the mistakes and I give this conference back to the Mikhail and Jennifer. Thank you.
Thank you, Nofri and Dr. Imran Pambudi. Now, ladies and gentlemen, before continuing to the fourth topic, we will have a break. And we'll see you again after the 30 minutes break time.
Pada bulan Juli tahun 2019, SK Menteri Riset Teknologi dan Pendidikan Tinggi Republik Indonesia nomor 596/KPT/1/2019 mengubah nomenklatur program studi D3 Analis Kesehatan menjadi program studi D3 Teknologi Laboratorium Medis atau TLM. Seiring dengan beralihnya nomenklatur, gelar untuk lulusan prodi D3 Teknologi Laboratorium Medis juga beralih dari yang sebelumnya Ahli Madya Analis Kesehatan menjadi Ahli Madya Kesehatan atau AMDKes. Untuk menjamin mutu dan keberlangsungan pendidikan, Prodi D3 Teknologi Laboratorium Medis sudah terakreditasi A oleh Lembaga Akreditasi Mandiri Perguruan Tinggi Kesehatan atau LAMPTKes dengan nomor SK 1017 pada tanggal 24 Desember 2016. Selaras dengan visi untuk menjadikan Prodi D3 Teknologi Laboratorium Medis sebagai kampus yang mampu bersaing secara global pada tahun 2024, serta unggul, mandiri, dan berbudaya dalam pelayanan diagnostik tuberkulosis paru dan penyakit penyerta, para lulusan Prodi D3 Teknologi Laboratorium Medis Poltekkes Kemenkes Manado telah berhasil tersebar di wilayah Indonesia, diantaranya pada instansi Dinas Kesehatan, rumah sakit, puskesmas, laboratorium klinik, Badan Pengawas Obat dan Makanan atau Badan POM, Balai Teknik Kesehatan Lingkungan atau BTKL, Balai Penunjang Pelayanan Kesehatan atau BPPK, KKP Udara atau KKP Laut, Nusantara Sehat atau NS, serta di berbagai macam instansi pemerintah atau swasta lainnya. Jumlah mahasiswa yang menempuh studi pada Prodi D3 Teknologi Laboratorium Medis tercatat sebanyak 953 orang, dengan jumlah lulusan sebanyak 626 lulusan. Program studi D3 Teknologi Laboratorium Medis Politeknik Kesehatan Kemenkes Manado juga memiliki tenaga pengajar dengan kualifikasi pendidikan magister dan doktor yang merupakan lulusan dari berbagai universitas ternama di seluruh Indonesia. Kesempatan belajar pada Prodi D3 Teknologi Laboratorium Medis juga terbuka luas hingga skala internasional. Beberapa mahasiswa pernah mengikuti berbagai macam kegiatan bertaraf internasional, diantaranya mengikuti short course program di Dongseo University, Busan, Korea Selatan pada tahun 2017 dan menjadi tutor ASEAN Science Camp pada tahun 2019. Sesuai dengan Tridharma Perguruan Tinggi, melalui kegiatan pengabdian pada masyarakat, Prodi D3 Teknologi Laboratorium Medis Poltekkes Kemenkes Manado tak hanya mengabdi di beberapa daerah di Sulawesi Utara, tetapi juga berhasil dengan baik mengabdi di berbagai daerah di luar Sulawesi Utara. Dengan tujuan menghasilkan tenaga kerja yang kompeten, Prodi D3 Teknologi Laboratorium Medis menyediakan sarana dan prasarana berupa gedung 4 lantai dengan fasilitas diantaranya ruang kelas yang kondusif, laboratorium yang terdiri dari laboratorium bakteriologi virologi, laboratorium parasitologi mikologi, laboratorium imunoserologi sitohistologi biomo, laboratorium hematologi, laboratorium kimia klinik, laboratorium kimia terapan, laboratorium toksikologi, ruang lobi, ruang himaju, ruang meeting, ruang klinik P3K, serta berbagai macam fasilitas lainnya.
Program Studi Diploma 3 Teknologi Laboratorium Medis atau TLM Politeknik Kesehatan Kemenkes Manado secara resmi berdiri tahun 2010. Sekaligus mulai menerima mahasiswa baru perdana tahun akademik 2010-2011. Teknologi Laboratorium Medis merupakan program studi satu-satunya di Provinsi Sulawesi Utara sampai dengan sekarang. Untuk sarana dan prasarana yang menunjang baik pembelajaran teori maupun praktikum di laboratorium, kami memiliki sarpras yang sangat baik dan sangat lengkap, dan itu sangat mendukung kegiatan PBM di jurusan Prodi TLM. Sejak angkatan pertama tahun 2010 sampai dengan tahun 2021 ini, kami telah mendidik mahasiswa sebanyak 953 orang dan telah meluluskan 626 mahasiswa yang saat ini sudah bekerja dan tersebar di wilayah Indonesia.
Mari bergabung bersama Prodi D3 Teknologi Laboratorium Medis Poltekkes Kemenkes Manado dan bersama wujudkan Poltekkes Kemenkes Manado sebagai institusi pendidikan kesehatan vokasi yang unggul, mandiri, dan berbudaya. Pada Medis atau TLM, seiring dengan Pada bulan Juli tahun 2019, SK Menteri Riset Teknologi dan Pendidikan Tinggi Republik Indonesia nomor 596/KPT/1/2019 mengubah nomenklatur program studi D3 Analis Kesehatan menjadi program studi D3 Teknologi Laboratorium Medis atau TLM. Seiring dengan beralihnya nomenklatur, gelar untuk lulusan prodi D3 Teknologi Laboratorium Medis juga beralih dari yang sebelumnya ahli madya analis kesehatan menjadi ahli madya kesehatan atau AMDKes. Untuk menjamin mutu dan keberlangsungan pendidikan, prodi D3 Teknologi Laboratorium Medis sudah terakreditasi unggul oleh Lembaga Akreditasi Mandiri Perguruan Tinggi Kesehatan atau LAM-PTKes dengan nomor SK 0350 tanggal 27 Agustus 2021. Selaras dengan visi untuk menjadikan prodi D3 Teknologi Laboratorium Medis sebagai kampus yang mampu bersaing secara global pada tahun 2024 serta unggul, mandiri dan berbudaya dalam pelayanan diagnostik tuberkulosis paru dan penyakit penyerta, para lulusan prodi D3 Teknologi Laboratorium Medis Poltekkes Kemenkes Manado telah berhasil tersebar di wilayah Indonesia, diantaranya pada instansi dinas kesehatan, rumah sakit, puskesmas, laboratorium klinik, Badan Pengawas Obat dan Makanan atau Badan POM, Balai Teknik Kesehatan Lingkungan atau BTKL, Balai Penunjang Pelayanan Kesehatan atau BPPK, KKP Udara atau KKP Laut, Nusantara Sehat atau NS, serta di berbagai macam instansi pemerintah atau swasta lainnya. Jumlah mahasiswa yang menempuh studi pada prodi D3 Teknologi Laboratorium Medis tercatat sebanyak 953 orang, dengan jumlah lulusan sebanyak 626 lulusan. Program studi D3 Teknologi Laboratorium Medis Politeknik Kesehatan Kemenkes Manado juga memiliki tenaga pengajar dengan kualifikasi pendidikan magister dan doktor yang merupakan lulusan dari berbagai universitas ternama di seluruh Indonesia. Kesempatan belajar pada prodi D3 Teknologi Laboratorium Medis juga terbuka luas hingga skala internasional. Beberapa mahasiswa pernah mengikuti berbagai macam kegiatan bertaraf internasional, diantaranya mengikuti short course program di Dongseo University, Busan, Korea Selatan pada tahun 2017 dan menjadi tutor ASEAN Science Camp pada tahun 2019. Sesuai dengan Tridharma Perguruan Tinggi, melalui kegiatan pengabdian pada masyarakat, prodi D3 Teknologi Laboratorium Medis Poltekkes Kemenkes Manado tak hanya mengabdi di beberapa daerah di Sulawesi Utara, tetapi juga berhasil dengan baik mengabdi di berbagai daerah di luar Sulawesi Utara. Dengan tujuan menghasilkan tenaga kerja yang kompeten, prodi D3 Teknologi Laboratorium Medis menyediakan sarana dan prasarana berupa gedung 4 lantai dengan fasilitas diantaranya ruang kelas yang kondusif, laboratorium yang terdiri dari laboratorium bakteriologi virologi, laboratorium parasitologi mikologi, laboratorium imunoserologi sitohistologi biomo, laboratorium hematologi, laboratorium kimia klinik, laboratorium kimia terapan, laboratorium toksikologi, ruang lobi, ruang himaju, ruang meeting, ruang klinik P3K, serta berbagai macam fasilitas lainnya.
Program Studi Diploma 3 Teknologi Laboratorium Medis atau TLM Politeknik Kesehatan Kemenkes Manado secara resmi berdiri tahun 2010, sekaligus mulai menerima mahasiswa baru perdana tahun akademik 2010-2011. Teknologi Laboratorium Medis merupakan program studi satu-satunya di Provinsi Sulawesi Utara sampai dengan sekarang.
Mari bergabung bersama Prodi D3 Teknologi Laboratorium Medis Poltekkes Kemenkes Manado dan bersama wujudkan Poltekkes Kemenkes Manado sebagai institusi pendidikan kesehatan vokasi yang unggul, mandiri, dan berbudaya. Health Polytechnic Manado is being presented as professional medical personnel education institution, which formed based on Ministry of Health and Social Welfare, Decree number 290, 8 from April 16, 2001. Based on the assessment of National Accreditation Body for Higher Education or BANBT, Health Polytechnic Manado has Health Polytechnic Manado is being presented as professional medical personnel education institutions, which form based on Ministry of Health and Social Welfare, Decree number 290, 8 from April 16, 2001. Based on the assessment of National Accreditation Body for Higher Education or BANBT, Health Polytechnic Manado has successfully achieved B accreditation according to Decree number 206 of 2020. The assignation of Health Polytechnic Manado by Ministry of Health as the government agency that applies the Public Service Agency's financial management pattern has been registered according to Ministry of Finance's Decree number 399 of 2019. At this time, Health Polytechnic Manado has 7 majors, consists of 13 study programs that have been accredited by Indonesian Accreditation Agency for Higher Education in Health or LAMPTKS, such as Nursing Department, Environmental Health Department, Nutritional Science Department, Midwifery Department, Pharmacy Department, Dental Health Department, and Medical Laboratory Technology Department. Nursing Department consists of 4 study programs that has been accredited by LAMPTKS, such as Nurse Study Program, a 4-year Diploma Nursing Study Program, 3-year Diploma Nursing Study Program, and a 4-year Diploma Health Promotion Study Program. 4 study programs in Nursing Department excel in their own respective field. Nurse Study Program and a 4-year Diploma Nursing Study Program excel in Emergency Unit Nursing. A 3-year Diploma Nursing Study Program excels in Cardiovascular Emergency Unit Nursing, and a 4-year Diploma Health Promotion Study Program excels in Health Behavior and Promotion. Environmental Health Department consists of 2 study programs that has been accredited by LAMPTKS, such as a 4-year Diploma Environmental Sanitation Study Program and a 3-year Diploma Sanitation Study Program. 2 study programs in Environmental Health Department excel in their own respective field. A 4-year Diploma Environmental Sanitation Study Program excels in Vector Control and Waste Management. The 3-year Diploma Sanitation Study Program excels in Vector Control and Liquid Waste Management. Nutritional Science Department consists of 2 study programs that has been accredited by LAMPTKS, such as a 4-year Diploma Nutrition and Dietetics Study Program and a 3-year Diploma Nutrition Study Program. 2 study programs in Nutritional Science Department excel in their own respective field. A 4-year Diploma Nutrition and Dietetics Study Program excels in Utilization of Local Food and Nutrition Intervention Management, and a 3-year Diploma Nutrition Study Program excels in Food Science Technology. Midwifery Department consists of 2 study programs that has been accredited by LAMPTKS, such as a 4-year Diploma Midwifery Study Program and a 3-year Diploma Midwifery Study Program. 2 study programs in Midwifery Department excel in their own respective field. A 4-year Diploma Midwifery Study Program excels in Quality Midwifery Care in the midst of crisis and emergency management. A 3-year Diploma Midwifery Study Program excels in Local Culture Innovation in Midwifery Services. Pharmacy Department has 1 study program, which is a 3-year Diploma Pharmacy Study Program that excels in Traditional Medicine and Pharmaceutical Service. Dental Health Department has 1 study program, which is a 3-year Diploma Dental Health Study Program that excels in Preventive Oral Health Care and Health Promotion. Medical Laboratory Technology Department has 1 study program, which excels in Lung Tuberculosis Diagnostic and Comorbidities. All those 3 study programs also have been accredited by LAMPTKS. Based on data from the last 3 years, the total of students applying for Health Polytechnic Manado is 11,463 students, consists of 9,155 applicants for a 3-year diploma study program and 2,308 applicants for a 4-year diploma study program. Now, the total number of students since 2018 until 2020 is 7,341, which consists of Nursing Department 1,763 students, Environmental Health Department 1,231 students, Nutritional Science Department 1,179 students, Midwifery Department 1,148 students, Pharmacy Department 653 students, Dental Health Department 568 students, and Medical Laboratory Technology Department 773. Number of lecturers at Health Polytechnic Manado is 109 people with master and doctoral degree from well-known universities both in country and abroad. Furthermore, the human resources of Health Polytechnic Manado is powered by instructor, librarian, and administration staff. In providing education with good quality, Health Polytechnic Manado is located in 3 strategic locations, which Campus A located at Jalan RW Monginsidi, Malalayang 2, Manado, Campus B located at Jalan Parigi 7, nomor 22, Malalayang 1, and Campus C located at Jalan Manguni 20, Kelurahan Malende. Health Polytechnic Manado is being presented as professional medical personnel education institutions, which form based on Ministry of Health and Social Welfare, Decree number 290, 8 from April 16, 2001. Based on the assessment of National Accreditation Body for Higher Education or BANPT, Health Polytechnic Manado has successfully achieved B accreditation according to Decree number 206 of 2020. The assignation of Health Polytechnic Manado by Ministry of Health as the government agency that applies the Public Service Agency's financial management pattern has been registered according to Ministry of Finance's Decree number 399 of 2019. At this time, Health Polytechnic Manado has 7 majors, consists of 13 study programs that have been accredited by Indonesian Accreditation Agency for Higher Education in Health or LAMPTKS, such as Nursing Department, Environmental Health Department, Nutritional Science Department, Midwifery Department, Pharmacy Department, Dental Health Department, and Medical Laboratory Technology Department. Nursing Department consists of 4 study programs that has been accredited by LAMPTKS, such as Nurse Study Program, a 4-year Diploma Nursing Study Program, 3-year Diploma Nursing Study Program, and a 4-year Diploma Health Promotion Study Program. 4 study programs in Nursing Department excel in their own respective field. Nurse Study Program and a 4-year Diploma Nursing Study Program excel in Emergency Unit Nursing. A 3-year Diploma Nursing Study Program excels in Cardiovascular Emergency Unit Nursing, and a 4-year Diploma Health Promotion Study Program excels in Health Behavior and Promotion. Environmental Health Department consists of 2 study programs that has been accredited by LAMPTKS, such as a 4-year Diploma Environmental Sanitation Study Program and a 3-year Diploma Sanitation Study Program. 2 study programs in Environmental Health Department excel in their own respective field. A 4-year Diploma Environmental Sanitation Study Program excels in Vector Control and Waste Management. The 3-year Diploma Sanitation Study Program excels in Vector Control and Liquid Waste Management. Nutritional Science Department consists of 2 study programs that that has been accredited by LAMPTKS, such as a 4-year Diploma Nutrition and Dietetics Study Program and a 3-year Diploma Nutrition Study Program. 2 study programs in Nutritional Science Department excel in their own respective field. A 4-year Diploma Nutrition and Dietetics Study Program excels in utilization of local food and nutrition intervention management, and a 3-year Diploma Nutrition Study Program excels in food science technology. Midwifery department consists of 2 study programs that has been accredited by LAMPTKS, such as a 4-year Diploma Midwifery Study Program and a 3-year Diploma Midwifery Study Program. 2 study programs in Midwifery department excel in their own respective field. A 4-year Diploma Midwifery Study Program excels in quality midwifery care in the midst of crisis and emergency management. A 3-year Diploma Midwifery Study Program excels in local culture innovation in midwifery services. Pharmacy department has 1 study program, which is a 3-year Diploma Pharmacy Study Program that excels in traditional medicine and pharmaceutical service. Dental Health department has 1 study program, which is a 3-year Diploma Dental Health Study Program that excels in preventive oral health care and health promotion. Medical Laboratory Technology department has 1 study program, which excels in lung tuberculosis diagnostic and comorbidities. All those 3 study programs also have been accredited by LAMPTKS. Based on data from the last 3 years, the total of students applying for Health Polytechnic Manado is 11,463 students, consists of 9,155 applicants for a 3-year diploma study program and 2,308 applicants for a 4-year diploma study program. Now, the total number of students since 2018 until 2020 is 7,341, which consists of Nursing Department 1,763 students, Environmental Health Department 1,231 students, Nutritional Science Department 1,179 students, Midwifery Department 1,148 students, Pharmacy Department 653 students, Dental Health Department 568 students, and Medical Laboratory Technology Department 773. Number of lecturers at Health Polytechnic Manado is 109 people with master and doctoral degree from well-known universities both in country and abroad. Furthermore, the human resources of Health Polytechnic Manado is powered by instructor, librarian, and administration staff. In providing education with good quality, Health Polytechnic Manado is located in 3 strategic locations, which Campus A located at Jalan RW Monginsidi, Malalayang 2, Manado, Campus B located at Jalan Parigi 7, Nomor 22, Malalayang 1, and Campus C located at Jalan Manguni 20, Kelurahan Malende. Implementing its activities, the departments are managed by Directorate Management, which led collectively by Director, Director of Academics, Director of Finance, General Staff and Administration, and Director of Students Affairs and Cooperation. For the sake of convenience and continuity of teaching and learning process, Health Polytechnic Manado provides representative facilities and infrastructures. The supporting facilities provided are classes, laboratory, workshop, technical implementers unit of health services, discussion room, library, auditorium, and an information system, Siakat Cloud, which integrated with MLS Adlink, journal portal that has been accredited by DICTI. Let's join Health Polytechnic Manado, and together we make Health Polytechnic Manado as an excellent, independent, and cultural vocational health education institution. Health Polytechnic Manado is being presented as professional medical personnel education institutions, which form based on Ministry of Health and Social Welfare, Decree number 290, 8 from April 16, 2001. Based on the assessment of National Accreditation Body for Higher Education or BANPT, Health Polytechnic Manado has successfully achieved B accreditation according to Decree number 206 of 2020. The assignation of Health Polytechnic Manado by Ministry of Health as the government agency that applies the Public Service Agency's financial management pattern has been registered according to Ministry of Finance's Decree number 399 of 2019. At this time, Health Polytechnic Manado has 7 majors, consists of 13 study programs that have been accredited by Indonesian Accreditation Agency for Higher Education in Health or LAMPTKS, such as Nursing Department, Environmental Health Department, Nutritional Science Department, Midwifery Department, Pharmacy Department, Dental Health Department, and Medical Laboratory Technology Department. Nursing Department consists of 4 study programs that has been accredited by LAMPTKS, such as Nurse Study Program, a 4-year Diploma Nursing Study Program, 3-year Diploma Nursing Study Program, and a 4-year Diploma Health Promotion Study Program. 4 study programs in Nursing Department excel in their own respective field. Nurse Study Program and a 4-year Diploma Nursing Study Program excel in Emergency Unit Nursing. A 3-year Diploma Nursing Study Program excels in Cardiovascular Emergency Unit Nursing, and a 4-year Diploma Health Promotion Study Program excels in Health Behavior and Promotion. Environmental Health Department consists of 2 study programs that has been accredited by LAMPTKS, such as a 4-year Diploma Environmental Sanitation Study Program and a 3-year Diploma Sanitation Study Program. 2 study programs in Environmental Health Department excel in their own respective field. A 4-year Diploma Environmental Sanitation Study Program excels in Vector Control and Waste Management. The 3-year Diploma Sanitation Study Program excels in Vector Control and Liquid Waste Management. Nutritional Science Department consists of 2 study programs that has been accredited by LAMPTKS, such as a 4-year Diploma Nutrition and Dietetics Study Program and a 3-year Diploma Nutrition Study Program. 2 study programs in Nutritional Science Department excel in their own respective field. A 4-year Diploma Nutrition and Dietetics Study Program excels in Utilization of Local Food and Nutrition Intervention Management, and a 3-year Diploma Nutrition Study Program excels in Food Science Technology. Midwifery Department consists of 2 study programs that has been accredited by LAMPTKS, such as a 4-year Diploma Midwifery Study Program and a 3-year Diploma Midwifery Study Program. 2 study programs in Midwifery Department excel in their own respective field. A 4-year Diploma Midwifery Study Program excels in Quality Midwifery Care in the midst of crisis and emergency management. A 3-year Diploma Midwifery Study Program excels in Local Culture Innovation in Midwifery Services. Pharmacy Department has 1 study program, which is a 3-year Diploma Pharmacy Study Program that excels in Traditional Medicine and Pharmaceutical Service. Dental Health Department has 1 study program, which is a 3-year Diploma Dental Health Study Program that excels in Preventive Oral Health Care and Health Promotion. Medical Laboratory Technology Department has 1 study program, which excels in lung tuberculosis diagnostic and comorbidities. All those 3 study programs also have been accredited by LAMPTKS. Based on data from the last 3 years, the total of students applying for Health Polytechnic Manado is 11,463 students, consists of 9,155 applicants for a 3-year diploma study program and 2,308 applicants for a 4-year diploma study program. Now, the total number of students since 2018 until 2020 is 7,341, which consists of Nursing Department 1,763 students, Environmental Health Department 1,231 students, Nutritional Science Department 1,179 students, Midwifery Department 1,148 students, Pharmacy Department 653 students, Dental Health Department 568 students, and Medical Laboratory Technology Department 773. Number of lecturers at Health Polytechnic Manado is 109 people with master and doctoral degree from well-known universities both in country and abroad. Furthermore, the human resources of Health Polytechnic Manado is powered by instructor, librarian, and administration staff. In providing education with good quality, Health Polytechnic Manado is located in 3 strategic locations, which Campus A located at Jalan RW Monginsidi, Malalayang 2, Manado, Campus B located at Jalan Parigi 7, Nomor 22, Malalayang 1, and Campus C located at Jalan Manguni 20, Kelurahan Malende. Implementing its activities, the departments are managed by Directorate Management, which led collectively by Director, Director of Academics, Director of Finance, General Staff and Administration, and Director of Students Affairs and Cooperation. For the sake of convenience and continuity of teaching and learning process, Health Polytechnic Manado provides representative facilities and infrastructures. The supporting facilities provided are classes, laboratory, workshop, technical implementers unit of health services, discussion room, library, auditorium, and an information system, CICAT Cloud, which integrated with MLS Adlink, journal portal that has been accredited by Dikti. Let's join Health Polytechnic Manado, and together we make Health Polytechnic Manado as an excellent, independent, and cultural vocational health education institution. Health Polytechnic Manado is being presented as professional medical personnel education institution, which formed based on Ministry of Health and Social Welfare, Decree number 290, 8 from April 16, 2001. Based on the assessment of National Accreditation Body for Higher Education or BANPT, Health Polytechnic Manado has successfully achieved B accreditation according to Decree number 206 of 2020. The assignation of Health Polytechnic Manado by Ministry of Health as the government agency that applies the Public Service Agency's financial management pattern has been registered according to Ministry of Finance's Decree number 399 of 2019. At this time, Health Polytechnic Manado has 7 majors, consists of 13 study programs that have been accredited by Indonesian Accreditation Agency for Higher Education in Health or LAMPTKS, such as Nursing Department, Environmental Health Department, Nutritional Science Department, Midwifery Department, Pharmacy Department, Dental Health Department, and Medical Laboratory Technology Department. Nursing Department consists of 4 study programs that has been accredited by LAMPTKS, such as Nurse Study Program, a 4-year Diploma Nursing Study Program, 3-year Diploma Nursing Study Program, and a 4-year Diploma Health Promotion Study Program. 4 study programs in Nursing Department excel in their own respective field. Nurse Study Program and a 4-year Diploma Nursing Study Program excel in Emergency Unit Nursing. A 3-year Diploma Nursing Study Program excels in Cardiovascular Emergency Unit Nursing, and a 4-year Diploma Health Promotion Study Program excels in Health Behavior and Promotion. Environmental Health Department consists of 2 study programs that has been accredited by LAMPTKS, such as a 4-year Diploma Environmental Sanitation Study Program and a 3-year Diploma Sanitation Study Program. 2 study programs in Environmental Health Department excel in their own respective field. A 4-year Diploma Environmental Sanitation Study Program excels in Vector Control and Waste Management. The 3-year Diploma Sanitation Study Program excels in Vector Control and Liquid Waste Management. Nutritional Science Department consists of 2 study programs that has been accredited by LAMPTKS, such as a 4-year Diploma Nutrition and Dietetics Study Program and a 3-year Diploma Nutrition Study Program. 2 study programs in Nutritional Science Department excel in their own respective field. A 4-year Diploma Nutrition and Dietetics Study Program excels in utilization of local food and nutrition intervention management, and a 3-year Diploma Nutrition Study Program excels in food science technology. Midwifery Department consists of 2 study programs that has been accredited by LAMPTKS, such as a 4-year Diploma Midwifery Study Program and a 3-year Diploma Midwifery Study Program. 2 study programs in Midwifery Department excel in their own respective field. A 4-year Diploma Midwifery Study Program excels in quality midwifery care in the midst of crisis and emergency management. A 3-year Diploma Midwifery Study Program excels in local culture innovation in midwifery services. Pharmacy Department has 1 study program, which is a 3-year Diploma Pharmacy Study Program that excels in traditional medicine and pharmaceutical service. Dental Health Department has 1 study program, which is a 3-year Diploma Dental Health Study Program that excels in preventive oral health care and health promotion. Medical Laboratory Technology Department has 1 study program, which excels in lung tuberculosis diagnostic and comorbidities. All those 3 study programs also have been accredited by LAMPTKS. Based on data from the last 3 years, the total of students applying for Health Polytechnic Manado is 11,463 students, consists of 9,155 applicants for a 3-year diploma study program and 2,308 applicants for a 4-year diploma study program. Now, the total number of students since 2018 until 2020 is 7,341, which consists of Nursing Department 1,763 students, Environmental Health Department 1,231 students, Nutritional Science Department 1,179 students, Midwifery Department 1,148 students, Pharmacy Department 653 students, Dental Health Department 568 students, and Medical Laboratory Technology Department 773. Number of lecturers at Health Polytechnic Manado is 109 people with master and doctoral degree from well-known universities both in country and abroad. Furthermore, the human resources of Health Polytechnic Manado is powered by instructor, librarian, and administration staff. In providing education with good quality, Health Polytechnic Manado is located in 3 strategic locations, which Campus A located at Jalan RW Monginsidi, Malalayang 2, Manado. Campus B located at Jalan Parigi 7 nomor 22 Malalayang 1 and Campus C located at Jalan Manguni 20 Kelurahan Malende. Implementing its activities, the departments are managed by Directorate Management, which led collectively by Director, Director of Academics, Director of Finance, General Staff and Administration, and Director of Students Affairs and Cooperation.
For the break time is 10 minutes remain. Once again, for the break time is 10 minutes remain. Thank you. Because the break time is already finished, we kindly invite you to back to your seat and we will continue to the next agenda. That is the fourth topic about community engagement principle and MDR-TB prevention control. And in the session, we'll be guided by Jurmaliala Amu, the student of Manado Health Polytechnic, as the moderator. For Jurmaliala Amu, the session is yours.
Thank you, Michael and Jennifer. Shalom. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone, the honorable speakers, and all the participants of our conference today. I am Jurmalila Amu, the moderator for this fourth presentation session. And with our speaker, Dr. Febi Dwi Rahmadi, Bachelor of Science, Master of Science, PhD. But first, I would like to read the CV of our fourth speaker. Dr. Febi is a lecturer in global health at School of Medicine and the Indonesian program coordinator for the Center Environment and Population Health at Griffith University, Queensland, Australia. That's the CV of Dr. Febi. Pleased to be informed that Dr. Febi, due to some reason, can do live presentation, but he has sent his video presentation before it. For the presentation will shown by video. With any further ado, please watch the video presentation about community engagement principles and MDR TB prevention and control.
Hello everyone, Assalamualaikum warahmatullahi wabarakatuh. First of all, I would like to express my sincere gratitude to Poltekkes Manado for inviting me to present in this international conference. And secondly, I would like to express my apology for not being able to present these presentations live. I have something else to do on this day. I'm currently still in Brisbane. I'll be traveling to Indonesia tomorrow to Lombok, and we are going to have a DFAT project in Lombok. So on Friday, 27th of January, I'll be traveling with Griffith University teams to visit some villages in Lombok. So it is not possible for me to present this online on live. Okay, so I'm not actually a big fan of pre-recording presentations, but I'll try my best to pre-record my presentations, and hopefully you can get benefit from my presentations. Okay, so the topic that I would like to share with you all is community engagement principles and MDR-TB, multi-drug resistant TB prevention and control. Okay. First of all, it is important for us to understand the background. All right, so it is important to understand what is actually the problem. And of course, now we are talking about TB in the context of Indonesia. So TB is one of the top 4 causes of death in Indonesia. So about 100,000 people dead each year. So the country has the second highest burden of the disease in the world, and new strains have emerged in recent years that are resistant to existing treatment. So which is what we are currently talking about, which is MDR-TB. So drug-resistant TB causes immense hardship for the patients and poses a significant challenge to health workers. And also, of course, not to mention the financial burden of the government as well. Indonesia, our country, has made great progress actually in expanding TB services over the last few years. However, the decline in TB incidence has been slow, and the country still ranks the second in terms of the incidence of TB globally. So as you can see here, So Indonesia is the world's second largest TB country after India, which is about 354 per 100,000 people. So of course, it is important for us to acknowledge what has been achieved, because little progress is still a progress. However, it is important for us to understand what has been the gap, why there has been some delay in terms of reducing the incidence of TB in our country. So as we all know that drug-resistant TB is a public health crisis. And if you look at this poster, in 2020, only about 1 in 3 of those in it received treatment for drug-resistant TB. Okay, so only 1 in 3. And 150,000 people were started on treatment for drug-resistant TB, so which is down 15% from 177,000 in 2019. So of those treated, so this is something that it is important, only 59% were treated successfully. So TB medicines have been used for decades, and strains that are resistant to one or more of the medicines have been documented, okay, have been reported. So drug resistance emerge when TB medicines are used inappropriately, through incorrect prescriptions by healthcare providers, poor quality drugs, and patients stopping treatment prematurely. So it is important as public health professionals from my because my background is public health, so we need to understand why patients stopping treatment prematurely. Okay, so I'm not going to talk about the definition of MDR-TB. Other speakers have more background about it, so they have more knowledge about it, so I will let them explain about the MDR-TB from the medical point of view. Okay, it is important for us to understand why people stopping treatment prematurely. Okay, so this is something that I would like to also discuss in my presentations. Okay, now WHO engaged with 8 TB priority countries, and Indonesia is one of them. So these are the countries with high prevalence of TB and a very high number of missed or unreported cases. So the other 7 are, if I'm not mistaken, Democratic Republic of Congo, we have Kenya, Mozambique, Myanmar, Nigeria, Pakistan, and Tanzania. So if you look at this figure, TB burden and missed cases. So TB incidence in 2017 was estimated at 319 per 100,000 populations, with 842,000 cases in 2017. And the number of TB cases detected but not notified was estimated at 303,000. So while the number of missed cases was estimated at 165,000. Okay, so if you look at this figure, so the 2013, so if you look at 2013 prevalence survey suggested that large numbers of missing TB patients may already be receiving care from public and private providers, not reporting to the National TB Program or NTP. Mandatory notifications came into effect in 2016, so that's why we have increasing cases of TB because of mandatory notifications came into effect in 2016. The estimated number of multi-drug resistance TB in 2017 was about 12,000. Only 16% of them being notified and tested for rifampicin resistance. So only 16% of them being notified and tested. Okay, so it is something that is very low, so that's why WHO engaged with these countries, including our country. There has been actually a lot of progress in the context of like commitment of the national government, especially in terms of eliminating TB by 2030. And the president has already launched Press 67 year 2021 concerning about TB elimination program. So there are at least six key strategies that will be implemented by the government, or being implemented, because it has been launched 2 years ago. The first one is strengthen the central, provincial, and district city government's commitment and leadership, improve the access to quality and patient-centered TB services, intensify health measures for TB prevention and control, expand research, development, innovations, enhance contributions from the community, stakeholders, professionals, and other partners in TB control. So in these presentations, I'll be more talking about number 5, and the last one is strengthening TB program management. So based on this decree, Indonesia established a multi-sectoral coordinating team, which is led by Coordinating Ministry of Human Development and Cultural Affairs. So it is also important that early diagnosis and prompt treatment are the core objectives of an effective national TB control program. So persons who experience signs and symptoms of TB should report promptly for diagnosis and should, if found to have TB, commence treatment immediately. So that is actually the core. Unfortunately, this process can be disrupted by delay in deciding to visit a TB treatment facility, delay in obtaining diagnosis, and delay in receiving treatment. So 3 delays. So the first one is delay in deciding to visit a TB treatment facility, delay in obtaining diagnosis, and delay in receiving treatment. So it is important for us to see what is actually inside this purpose. So this purpose or this presidential regulation would like to reduce the incidence rate of TB up to 65 per 100,000 in 2030, and also the fatality rate due to TB to 6 per 100,000 in 2030. However, if there is still factors that might disrupt this process, it is important for us to then look at what can be done. Why there are some delays in for people to visit TB treatment facility, why there is a delay in obtaining diagnosis, why there is a delay in receiving treatment. The big question is actually why community participation is still relatively low. So now by 2030, we are trying to reduce as many as possible the incidence of TB. So that is the goal. The question is now, how can we achieve that goal? As we all know, and as I have mentioned earlier, so the core principles or the core activities of NTB by 2030 is early detections, diagnosis, and notifications of TB. So that is the global priority of TB control efforts, and which is also endorsed by the WHO and TB strategy. Now here I would like to introduce a framework that has been actually promoted since long time ago, since 1986, or even before that, since Alma Ata declarations, which is Health Promotion Action Framework. So this framework is not actually a new framework. The question is now whether we have implemented this action framework comprehensively or not. As we can see here, it always starts with need assessment. Okay, so action planning is a form of learning. Although we are a professional, public health professionals, medical doctor, researcher, academia, it is important for us to understand what is actually the underlying factors, what has been the root causes of the problem, what are the needs of the community. All right, so it is always a bottom-up approach. All right, so if you look at this one here, it is a method of identifying needs, establishing goals, and developing strategies to reach the goal that we want to achieve, which is to eliminate TB by 2030. So during implementation of the strategies, we monitor and, if necessary, modify the plan and take time to explore and reflect what we are doing and why. And this planning framework emphasizes a social determinants of health approach at every step. It also highlights the hierarchy of process, impact, and outcome evaluations at the different elements that can be measured at each stage of evaluations. If you look at this one here, we are going to use Ottawa Charter framework to analyze determinants. As we all already aware that Ottawa Charter consists of 5 different elements, looking at from the structural elements, looking at the environmental elements, cultural, individual, and also reorient health services. Okay, so in order for us to be able to achieve the goal that we want, it is important for us to understand this whole process. Okay, now community need assessment fits with the fundamental purpose of health promotion itself, which is to enable people to increase control over and improve their health determinant. And it is also important for us to always understand that the relationship between health practitioner and community is based on working with rather than working on. So community net assessment provides community leaders with a snapshot of local policy, systems, and environmental change strategies currently in place and helps to identify areas for improvement. So we can then answer the questions that we have been asking before. Why there has been factors or why there are barriers that cause delays in making decisions, in delays in getting help from the healthcare if somebody got TB. So CNA is an important element of a program. So with this data, communities can map out a course for health improvement, including how can we deal with TB by creating strategies to make positive and sustainable changes in their communities. So the project or the program to eliminate TB, it is something that community is really, involved in the process, involved in the planning phase, and also involved in implementation and also in the monitoring process of it as well. So the community is not only seen as target beneficiaries, is not only seen as a targeted populations, but they are also the key stakeholders as well. And this is also since Declaration of Alma Ata. So the people have the right and duty to participate individually and collectively in the planning and implementation of their healthcare. So it is important for us then to see how what strategy that we have been implemented to engage our community in implementing this program. Okay, now we have Charles Edward Winslow in 2020. So he said public health is the science and art of preventing disease, prolonging life, and promoting health and efficiency through, so this is something that I would like to underline, organized community effort for sanitations of the environment, the control of communicable disease, the educations of the individual in personal hygiene. So this is something that is actually still relevant to what we are talking about. Okay. Okay, after Winslow, we have Ilona Kickbus. I believe most of you, you know who is Ilona Kickbus. Ilona Kickbus has been active in the field of health in all policies since the Ottawa Charter for Health Promotions in 1986, which called for healthy public policy. She was the initiator for the Healthy Setting for Health projects, such as Healthy Cities, which aim to put health on the political agenda. It is therefore important for us to see ecological as the main entry point of public health approach. And it is also important to see multisectoral as the foundations of our program and collaborations in every strategy that we implement in our program. So ecological in perspective, multisectoral in scope, and collaborative in strategy. All right, now we have a different core idea of public health. So there are at least 5 of them. So we have sanitary, environmental, we have biomedical, we have social, behavioral, we have techno-economic, we have ecological public health. Here I'm not trying to say ecological public health is the most comprehensive approach among other public health approach. However, if you look at the problem that you're talking now, which is elimination of MDR-TB or dealing with MDR-TB, then ecological public health is the most relevant approach, because health depends on successful coexistence of the natural world and social relationship. The key methods that will be promoted within ecological public health, such as system analysis in order to manage social transitions and create healthy habitats. As we all know that there are different levels of within us human that will influence our health status. At the individual level, we have personal history, biological factors. So all this will influence how individuals behave and increase their likelihood to get infected by disease. In this context, let's say TB. We also have personal relationships, such as family, friends, intimate partners, and peers may influence the risks of getting illness. Community contexts in which social relationship occurs, such as schools, neighborhoods, and workplace, this will also influence the likelihood, the possibility of somebody to get TB. And getting bigger, we also have societal factors influence whether disease or TB is something that is might happen to this particular person. Okay, such as this includes socio-economic, social policies, inequality. What else? Environmental conditions, living in an urban poor area, for instance. So this is something that will influence or increase or decrease the likelihood of somebody getting TB. So individual, personal relationship, community, and societal factors. So ecological public health will look at the interactions between all these different elements. Okay, so and also the strength of ecological public health model. So this approach integrates different parts of the other ideology within public health. There is a research that is published by within American Journal of Public Health, and this is very interesting. Okay, as we all know, DOTS or directly observed therapy short course means a trained healthcare worker or other designated individual that will provide the prescribed TB drugs and watch the patients swallow every dose. Okay, so this is a DOTS. However, according to this research, TB incidence rates appear more closely correlated with social and economic determinants, such as the Human Development Index, access to water sanitations, and child mortality than the success of DOTS. All right, so this is very interesting because all these are, something that is not only relevant to TB elimination program. We have Human Development Index, we have access to water sanitations, child mortality. So these three factors are more correlated with TB incidence rather than the successfulness of DOTS. Okay. So it is important for us to, for those who like archery, so maybe you understand this, and this is something that I would like to always use this as an analogy. So how far arrow can shoot is depending how we pull back the arrow. So how we pull back the arrow. So in this context will be the upstream thinking of health intervention. So we need to understand, we need to go back and see what has been happening, what has been the root causes, so then we can then understand what need to be done. Okay, so how to solve a problem before they happen. So this is also a nice illustration. So we have a drowning person or people. So we have ambulance, waiting at downstream. So if there is any, people drowning, they will come and help them. Okay. So if you're trapped in downstream thinking, we only thinking about how we can save people from the water. Okay, so the ambulance will focus on the downstream level. Okay, however, if we want to, improve our, program, and then we want to see what has been happening in the upstream level. So why people are jumping to the river, okay, at first place. So this is something that we can, prevent, so how we can prevent disease from it become disease, So moving healthcare upstream is something that need to be done in the context of elimination of TB or MDR TB. Okay, social determinants and social needs moving beyond midstream. So we have downstream, midstream, and also community impact. Okay, improve community conditions, addressing individual social needs, and also providing clinical care. All right, so all these levels need to be addressed comprehensively. I don't have to explain this in detail because I believe you understand what I'm trying to say with this one here. So this is us here in the middle. Okay, so and we are influenced by, we have lifestyle, diets, physical activities, work-life balance, and which is also influenced by community. Okay, here in Australia, where we don't have TB, so I've been hearing quite sometimes, if there is any, Indonesian students whose visa has been delayed because of TB. So last year we got a couple of them. I think previous year we got a couple of them as well. So here in Australia, we don't have TB. So potentially we have some patients coming from developing countries, including Indonesia. So we have lifestyle, we have community, and this will be influenced by local economy. This will be then influence our activities, built environment, natural environment, global ecosystem. And also if you look at the outer layers, so we have climate change, biodiversity, and etc. So all these are interrelated. Okay, so it is important for us to then to see which layers within our social determinants are relevant to the disease that we are talking now. MDR-TB. Okay, there is also an interesting articles which was published in 2021, and this is about TB and COVID-19. So in that paper, they said TB and COVID-19 are two different diseases that has similar social determinants or underlying factors. So we have TB and also COVID-19 relevant to socioeconomic status, housing and environmental conditions. Okay, those who live in crowded area or more than like 5 people living in one small small house, for instance, overcrowding. So how can they do social distancing? Okay, if one of their family member got COVID-19. Okay, other social determinant factors, we have physical environment and safety, food insecurity and malnutrition. It is something that is so much relevant to even MDR-TB that we are talking about as well. Cost and distance, social protections, cultural and language, access to healthcare, social isolation. So all these are the social determinants of TB. So when we say, okay, so the program is to do early detections, early diagnosis, okay, and also treatment, right? So it is also important for us to include strategy to address these social determinants as well. I believe you have seen this epidemiological triad or pyramid epidemiology. Yeah, we have agent, host, environment. So we have agent or microbe that causes the disease, or the what of the triangle. Yeah, and the host, which is an organisms harboring the disease, or the who of the triangle. And then the environment, or those external factors that cause or allow disease transmissions, or the where of the triangle. So the what, the who, and the where. So the picture can be also drawn like this: environment as the foundation. So we have agent, host on the top, and environment as the foundations. So the environment is the favorable surroundings and conditions external to the host that cause or allow the disease to be transmitted. Environment is very, very crucial, especially in the context of our MDR-TB. So next we have, and this is, previously I mentioned about foundation as the environment as the foundations. And if you look at this one, this is the picture of in Duren Sawit. Yeah, this is a picture of Jakarta Timur in Jakarta. I think it was taken, I took this from the WHO website, and I think this was maybe 5 or 6, 7 years ago. Okay, hopefully it's not like this anymore in 2023. So we have issue in terms of low income, food insecurity, okay, poor housings, overcrowding, and unhealthy environment. So TB is also recognized as a socially stratified disease that clusters among disadvantaged group. Okay, low income people, those who have issue in terms of food accessibility, those who live in poor housings, overcrowding, and those who live in unhealthy environment, like the picture that we are seeing at the moment. Living conditions that fosters TB, like this picture, can be found in numerous communities across Indonesia, particularly in urban areas with growing populations like Jakarta, Surabaya, where else? Yeah, so urban environment. And this is in Duren Sawit sub-district in East Jakarta, is one such community with a population just over 300,000. Close to 1,000 cases of TB were confirmed in 2016. Okay, you can imagine. So not to mention the deficient infrastructure, the long distance people have to travel to health facilities in some least developed provinces or districts in Indonesia. So in addition to the bullet points I put there, we also have issue in terms of deficient infrastructure and potentially long distance. People have to travel long distance. So by doing community need assessment, health promotion action framework, the one that was presented in few slides before. So it is important for us to understand the views of community. So here we have Pak Junaidi. Okay, this was also taken from UNDP in Asia and the Pacific. So a very nice article is what I would like to share with you now. So views of communities, which is understanding the need, you know, the perspective of the patients. Okay, not only from the medical doctor, not only from the public health professionals, but looking at from the community. Okay, so he is a Bajaj driver, yeah, and he has two childrens. Okay, and he is a person living with drug-resistant TB. So he was first diagnosed with TB in 2011 and was placed on the standard treatment regimen. He felt much better after the first month, but then stopped his daily medicines dose because of the severe side effects and the inconvenience of the compulsory daily visit to the TB clinic. When he started treatment again after several months, the bacteria did not respond. Okay, did not respond well to the medicines, and he was later diagnosed with DRTB. Okay, so because he stopped his daily medications because of severe side effects and the inconvenience of compulsory daily visit to the TB clinic, so he decided to stop, and then several months later, he did the treatment again, but the bacteria did not respond. Okay, and then so he experienced multi-drug resistant TB or drug-resistant TB. So Junaidi visits the TB clinics at one of the hospital in Jakarta, and then he follows the dots, you know, or the directly observed treatment short course provided by the of course Minister of Health, and he was then follow another, you know, like treatment program. Okay, and so he enrolled in a new treatment regimen which lasts for around 9 to 11 months, which is specifically for DRTB, and has a high likelihood of a complete cure. It is much shorter and more effective than the conventional DRTB treatment, which can last up to 24 months and requires painful daily injections. However, while it offers many advantages over the conventional treatment, the new treatment regimen is still quite challenging. Okay, so now I would like to read this part. So sometimes I feel tired of going to hospital every day to take my TB medicines. Okay, so that is what he felt. Okay, he felt tired of going to hospital every day to take my TB medicines. Sometimes when I am taking a day off from driving Bajaj, I just want to rest at home, but I can't because I have to go to the hospital every day. So I feel nauseous and drowsy for a few hours after each time I take my medicines. And he normally spend about 2 hours in the hospital. Okay, and other side effect that he need to also experience, including depressions, psychosis, kidney impairment, and also even hearing loss as well. So it is something that needs to be understood by public health professionals or key decision-making people, like people like Junaidi. Okay, so there are thousands of them, not only in Jakarta but across Indonesia, where they have to struggle with daily life, struggle with, you know, like improper living conditions, not enough education system, unsustainable livelihood mechanisms, no insurance, and etc. Okay. So views of community need to be also addressed comprehensively. So we need to understand what are the needs of the community, including financial and emotional impact of MDR TB patients. Because of I'd like to put the picture there. So potential out-of-pocket like travel, follow-up visits, hospitalizations, food supplements. So these are potential out-of-pocket. So they have to use their own money. So the loss of income, this is very, very serious. Okay. For TB, about 469 US, and MDR TB is 14 times higher, which is around 2,340 to each patient a year. So this is the loss of income. So very, very serious economic impact. So the cumulative financial and emotional impact of the daily commute to the clinic, the side effect of the treatment, and the time commitment every day can be draining for DRTB patients, negatively affecting their work and family life, such as hardship may contribute to patient dropouts and low treatment success rates for DRTB, leading to devastating outcomes. Okay, so but UNID, which is the budget driver from the previous slide, so he also mentioned that at the beginning of his treatment, I had to stay in bed for 2 months. I couldn't get up at all, so he couldn't get any money for his family. That's why he need to sell his motorbike to meet their daily needs. Okay, so TB can leave patients and their families in catastrophic financial hardship, even though the government provides free TB tests and medications at public facilities. Okay, however, there are some potential out-of-pocket, which I have mentioned earlier. So these are the factors contributing to the diagnostic delays, limited knowledge about signs and symptoms of TB, poor healthy seeking behavior, and poor diagnosis and disease management in health facilities results in delay in TB diagnosis and treatment, which in turn increase the risks of TB transmissions and the development of MDR TB. Okay, so therefore it is important for us to engage with the community. So community engagement is the strategy process with the specific purpose of working with identified group of people, whether they are connected by geographic locations, spatial interests, or evaluations to identify and address issues affecting their well-being. So it is very powerful vehicle for bringing about environmental and behavioral changes that will improve the health of the community and its member, and it is often involves partnership and coalitions that help mobilize resources and influence system. And this is something that need to be implemented in every level of our TB elimination program. So educations, consultations, extension of program, communications, building partnership is all about engagement. So it is actually science and art. It is science, including science of public health. Yeah, the science comes from sociology, public policy, political science, cultural anthropology, organizational development, and etc. As I mentioned earlier, so it is multi-sectoral in scope. So we need to include all these people, including anthropology and those people who understand culture, people who understand human behavior. Okay, it is also an art, understanding the skills. Okay, and how we can also try to apply the science that we have into something that is implementable at the community level. So community engagement is a blend of science and art. The science comes from sociology and etc. And if you look at this one here, it also comes from organizing concept drawn from the literature on community participations, community development, constituency building, and also community psychology. So it is something that need to be implemented in all levels of our program. And in the context of disease control, in this context, MDR-TB prevention and control, it will increase the likelihood that projects or solutions will be widely accepted by the community. So hopefully this will then reduce the people who doesn't want to participate in the program. So citizens who participate in these processes show significant commitment to help make the projects happen. So the second one is create more effective solutions. Drawing on local knowledge from a diverse group creates solutions that are practical and effective. The third one, improve citizens' knowledge and skills in problem solving. Participants learn about the issues in depth. Greater knowledge allows them to see multiple sides of the problem. Citizens can practice communications and decision-making skills. Empower and integrate people from different backgrounds. Groups that feel ignored can gain greater control over their lives and their community. When people from different areas of the community work together, they often find they have much in common. It is also important for us to say that the benefit of community engagement in disease control, it will allow us to create local network. The more people who know what is going on and who are willing to work toward a goal, the more likely a community is to be successful in reaching its goal. Okay, so create several opportunities for discussing concern. Regular ongoing discussions allow people to express concern before problems become too big or out of control. And last but not least, it will also increase trust in community organization and governance. Working together improves communications and understanding. Knowing what government, community, citizens, and leaders and organizations can and cannot do may reduce future conflicts as well. So it is also important for us to see what government can do, what civil society can do, what citizens need to be done in the context of elimination of TB. So roles and responsibility is very important, and this has to be something that is distributed to our people. This is also another important thing that need to be embedded in our community engagement programs, which is 6C, the capability. So the members are capable of dialogue. So we need to also provide opportunity for people or community members to dialogue. Okay, so they need to have this capability to dialogue. We need to have commitment, mutual benefit beyond self-interest. Okay, previously I mentioned about bottom up. It is actually more than just bottom up. It is bottom up and top down
Okay, that's the video presentation from Dr. Feby. Now we are entering the discussion session. So for all the participants who want to ask questions, you can write the questions in the link. For the questions from Pravita Anggraini, how to become a professional worker by being able to divide time for family and office work. For the second questions is from Resi Unita. How about the impact of psychosocial influences and risk factor on the incidence of MDR-TB? So that's all the questions. And for your information, all questions will be sent to Dr. Phoebe, and for the answer will be sent to the participants' email. After the end of this conference, the committee will share the handout for all topic in the conference. Big thank you for all the participants, and I give back this session to the MC. Sorry, and this is the certificate to appreciate Dr. Phoebe. Big thank you for all the participants, and I give the session back to the MC.
Thank you, Jurmali and Dr. Febi Dwi Rahamadi. And now we continue to the next topic, that is the fifth topic about community-based approach to control cardiovascular risk in rural area Indonesia. Can we apply this to tackle MDR-TB problem, which will be brought by Professor Dr. Delfak Osyandi and will be guided by Muhammad Zuirai. Is Dr. Delfak Osyandi already in Zoom? Once again, is Professor Dr. Delfak Osyandi already joined the Zoom? Okay, now we're gonna continue to the next topic.
So we continue the next topic. But before we continue, we remind you to the field attendance link in the comment section. And it is the last topic about projection of patient characteristic related to MDR-TB and comorbidities, which will be presented by Dr. Linda Agustin Macaleo. And in this session, will be guided by Gracia Pontolawaka, the student of Manado Health Polytechnic, as the moderators. For Gracia Pontolawaka, the session is yours.
Thank you, Michael and Jennifer, for the opportunity. Shalom. Assalamualaikum warahmatullahi wabarakatuh. Good morning, the honorable speakers and all the participants of our conference today. I am Gracia Pontolawaka, the moderator for this 5th presentation session. Our speaker, Dr. Linda Agustin Macaleo, Magister Kesehatan, will deliver the presentation regarding projection of patient characteristic related to MDR-TB and comorbidities. So, Dr. Linda, are you with us in this Zoom room?
Okay, I'm here.
Okay, so let's see the CV of our speaker in this session. Dr. Linda Agustin Macaleo, Magister Kesehatan, is a lecturer at Manado Health Polytechnic. Okay. Now we will hear the presentation from Dr. Linda. Before it, allow me to inform the duration of the presentation is 45 minutes and the discussion session will be in 15 minutes after the presentation. Reminder, for the participants, please use your time to follow this presentation. So, Dr. Linda, please, the time is yours.
Okay, thank you for the opportunity. Shalom, Assalamualaikum warahmatullahi wabarakatuh. Good afternoon to all of us. Dear all participants of this seminar, the Honorable Director of Manado Polytechnic, Samsu Alam SKMMKes, as well as the resource person at this seminar who are also my seniors and teachers. The material that I will present is related to applied data. I hope this material can be useful for tuberculosis observers, especially MDR, to achieve an TB 2050. Next. I will present material projection of patient characteristics related to MDR, TB, and its comorbidity. About projections or predictions. Prediction is an approximate activity. According to Wikipedia, prediction are attempts to gain knowledge of question or situation based on logic and or knowledge of the result of predicting or estimating values in the future using past data. Based on data that occurred in previous years, it can predict events that will occur in the following years. Data on super of multi-drug resistant in a place or location and the date determined as MDR, and with all their status such as gender, age, occupation, and comorbids, can be used as data to seek grouping and predicting characteristics with comorbidities who are at risk of becoming contagious and or severe MDR. Next.
application can be used for forecasting, ISO GWR4, geographically weighted regression version 4, as well as doubling the GIS, Geographic Information System. Data with this application requires data with a Gaussian distribution, such as the address and time of positive TB subers. Next. Okay. By using the GWR4 application and map with the help of the GIS application, I try to present the data I got in the form of one. What are the characteristics of a regular TB patient who becomes a carrier? 2. What are the characteristics of people who become infected with regular? For regular TB patient become transmission. Sorry, I got complete data about regular TB in 2015. East Java province. Therefore, I will present this data using the pen variable data in the form of pulmonary TB patient in the form of addresses and dates, data with a patient distribution in 38 districts in East Java province and in 2015. With conceptual spatial statistical analysis like this, with 6 independent variables, which in fact are data that are suspect of having an effect on tuberculosis transmission, as well as predictor variable is on state, percentage of pure families, 2 acid resistant basal positive, 3 incident HIV/AIDS, 4 incident for diabetes mellitus, 5 population density percentage, and health worker ratio. Next.
Respecting the form of address and time there are pulmonary complication as with the condition conceptual spatial statistical analysis and like
With predictor variable, 1 is percentage healthy home, 2 ratio basic health facilities, 3 is percentage of household with PSPS, perilaku hidup bersih dan sehat, ratio 4
and 5 percentage of slow patient. Overall, it can be
from the image below. Conceptual spatial geographically weighted Poisson regression in patient with pulmonary tuberculosis. So sorry, the picture is small. I hope it can be read. Patient with pulmonary tuberculosis, by looking at the percentage of pure families, the number of ALB positive, the incidence of HIV/AIDS, the incidence of diabetes mellitus, the percentage of population density, and the ratio of health workers are understood to be a source of infection at a certain time in their area. The community around the pulmonary tuberculosis suffered by looking at the percentage of healthy homes, the ratio of basic health facilities, the percentage of household with PHPS, perilaku hidup bersih dan sehat, and the percentage of the school population has the possibility of become infected with pulmonary tuberculosis. Okay, next. Yeah, complete patient with statistic mapping using GIS between dates and address of infection, TB suffers and infect TB suffers. Patient regression of special TB transmission with its predictor variables, also TB infect with predictor variable. Finally, with the GWF application to see the relationship between the response variable, both transmitter and infect, and their predictive variable index. Okay. Data with a patient distribution are widely found in the health sector, such as the number of patients with pulmonary tuberculosis, so that the usual spatial mapping or classical regression, such as geographically weighted regression, cannot be carried out. In order to map geographical data with a spatial Bayesian distribution in order to facilitate interpretation, mapping is needed using geographically weighted Bayesian regression. Latitude longitude measurement (GPS) at each address of pulmonary tuberculosis sufferers, inadequate case management, such as non-standard diagnosis and combination of drug, failure to cure case that have been diagnosed, also called with the presence of pure families, the number of ARP positive, the incidence of HIV/AIDS, the incidence of diabetes mellitus, the percentage of population density, the ratio of health workers, based on the above background, can make pulmonary tuberculosis sufferers become a source of transmission. The percentage of health homes, the ratio of basic work facilities, the percentage of households with PHBS, the percentage of school population, which based on the background above, can make someone suffer from pulmonary tuberculosis in an effort to prevent and control tuberculosis infection, (PPI). Is the area and time of transmission of pulmonary TB patient the cause of transmission of a person become pulmonary TB patient? Next. The result of completing the statistic option function for the of the transmission of Mycobacterium tuberculosis this year, data on tuberculosis sufferers by looking at the percent of pure families, the number of ARP positive, the incidence of HIV/AIDS, the incidence of diabetes mellitus, the percentage of population density, and ratio of health workers. And tuberculosis sufferers is set at 3 months then in the surrounding area by looking at the variable predictor. It is hoped that this can cut the beginning of the threshold cycle of Mycobacterium tuberculosis transmission in the following years. Next. Okay. Relationship patterns between variable infection pulmonary TB with suspect infection factor. For GWR4, we must look this picture for the first. The result option from the entire sequence of statistical tests, the following results are option. 21 sections the relationship between predictor variables and response variables. 83%. 83% of the observation points follow a linear straight line. So that one of the requirements for a linear relationship is met so that the next stage can be carried out, namely multi-collinearity detection. Next. Okay. Then section the relationship between variables is also the relation between the predictor variable and the response variable. 100% of the observation points follow a linear straight, so that one of the requirements for a linear relationship is met, so that the next step can be carried out, namely multi-collinearity detection. Further test result, namely the multi-collinearity test, found that all predictor variables have a variance inflation factor VIF value of less than 10. So that it can be said that there is no multi-collinearity. Next. The result of the next test are modeling the number of transmitted pulmonary TB patients using GWPR, like this, the map. Yeah. Spatio-geographically weighted patient regression modeling in areas with infection pulmonary tuberculosis patient option grouping of 7 regions with colors, different colors. Is green with 6 variables. There are 27 districts or cities. For yellow, that is Kabupaten Lumajang dan Kabupaten Tulungagung, the yellow, with 5 variables, 1, 2, 3, 4, 5 variables. There are 3 districts in this city. There is Kota Kediri. Yeah, there one. Light blue, 5 variables predictors, 1, predictors 2, 3, 5, and 6. There are 2 district cities. For dark blue, 5 variables is 1, 7, 1, 2, 4, 7, 5, and 6 variable 6. There is 1 district. Dark blue is Banyuwangi. Yeah. The purple, 5 variables, 1, 3, 4, 5, and 6. There are 2 districts and cities. Orange, 5 variables, 2, 3, 4, 5, and 6. There are 2 districts. And red, 4 variables, 1, 2, 3, and 4. There is 1 district. Is Kabupaten Tuban. The order of factor affecting pulmonary TB sufferers is a source of transmission is the percentage of population density, the percentage of pure families, the ratio of health workers, the number of ARB positive, the incidence of HIV/AIDS followed by the incidence of diabetes mellitus. Next. Okay, sorry. Map of spread of infected tuberculosis patient based on significant predicted variables by spatiographically weighted regression modeling in areas with infected pulmonary tuberculosis patients. obtain groups of four regions. For one, green. Region 1 is green. For variable predictor 1, 2, 3, and 4, there are 31 districts or cities. For light blue, there are 3 variables, 1 predictor variable 2 and 3. There is 1 district. Light blue is Kabupaten Pacitan. Next. Region yellow, 3 variables, 1, 3, and 4. There are 5 districts or cities. And region red, no variable, 0 variable. There is 1 district. The order of factors that influence contracting to become pulmonary TB sufferers is the percentage of households with the HBS, the percentage of school population, the percentage of healthy homes, followed by the ratio of basic health facilities. Next. Third map is of split of infected tuberculosis patient based on prediction of by one as well as the same significant predictor variables. Special geographically weighted patient regression modeling in areas with infected pulmonary tuberculosis with prediction of infection tuberculosis sufferers is grouped into 5 regions. Region 1 is green. There are 5 variables, 1, 2, 3, 4, and predictor from first map. There are 28 districts or cities. Region light blue, there are 4 variables. Variable predictor 1, 2, 3, and 4. There are 3 regencies and cities or cities. Region 3 is yellow for variables. 4 variables, 3, 2, 4, and red. There are 2 districts or cities. Region purple is 4 variables, 2, 3, and 4. And red, there are 4 district cities. And region red, 2 variables is significant. Variable predictor 4 and red. There is 1 district is Kabupaten Trenggalek. Yeah. With the order of factors that influence pulmonary TB sufferers and as a source of transmission are the percentage of healthy homes, the ratio of basic health facilities, the percentage of households with PHPAs, the percentage of school population, followed by prediction by 1. Next. Finally, the 3 models obtained we as health observers can become workers who carry out health promotion as a preventive measures and namely 1, prevent TB suffers from become infection by grouping 7 areas and paying attention to percentage of population density that says top of predictor variables. Second predictor variable is percentage of poor families, ratio of health workers, number of ARP positive. So sorry, that's ARP. HIV/AIDS incident rate, DM incidence rate. Second, prevent people from contracting TB by grouping 4 areas and paying attention to percentage of household with PHPS, percentage of school population, percentage of healthy homes, and ratio of basic health facilities. Third, prevent TB survivors from becoming infected with TB carriers by grouping 5 areas and paying attention to percentage of healthy homes, ratio of basic health facilities, percentage of household with PHPS, percentage of school population, and predictor by month. Next. Okay. How about MDR-TB? Data on MDR-TB in North Sulawesi, North Sulawesi in 2015 were 30 patients with various patient characteristics, both age, education, sex, occupation, and activities, DM, HIV/AIDS. GWL4 and GIS require a lot of data like regular TB events or TB sensitivity, but with the same principle of solution. Does my material hope to be useful? Back to moderator.
Yes. Okay. Thank you very much to Dr. Linda, who has delivered a very interesting presentation about projection of patient characteristic related to MDR, TB, and comorbidities. Now we are entering a discussion session. So for all the participants who want to ask question, you can write the question in the link. And okay. There is a question coming in. The first question is, how about relationship between the nutritional status of MDR-TB patients with comorbidity? Okay. We apologize, but this question sorry. This topic does not match the material presented. Remove to the next questions. Only one question. Okay. Okay, I think there is no question coming in.
So thank you to Dr. Linda Augustine Macaleo, Magister Kesehatan. We apologize for the question that cannot be answered due to the limited time. After the end of this conference, the committee will share the handout for all topic in the conference. And now we will give an appreciation in the form of an online certificate. Before we end this session, we will take a documentation. So please, for all the participants, turn on the camera. Okay, slide 1. Cheese. Slide 2. Slide 3. Slide 4. Okay, thank you. Big thank you for all the participants, and I give this session back to the MC.
Thank you, Gracia and Dr. Linda. And because Professor Dr. Delphak Oceandi already joined the Zoom, so the last topic will be community-based approach to control cardiovascular risk in rural area Indonesia. Can we apply this to tackle MDR-TB problem? That will be brought by Professor Dr. Delphak Oceandi and will be delivered by Muhammad Suirat. For Muhammad Suirat, session shows.
Okay, thank you for the occasion, Michael and Jennifer. Good afternoon. Assalamualaikum warahmatullahi wabarakatuh. Shalom. The Honorable, our speakers today, and all the participants of our conference today. I'm Muhammad Zirat, the moderator for this 6th presentation session. And our speaker, Professor Dr. Delphak Oceandi, MD, PhD, will deliver the presentation regarding community-based approach to control cardiovascular risk in rural area Indonesia. Can we apply this to tackle MDR-TB problem? But first, I would like to read the curriculum vitae from our 6th speaker. Dr. Delphak, Professor Dr. Delphak Oceandi, MD, PhD, as a reader in Cardiovascular Biology, Division of Cardiovascular Sciences in University of Manchester, England. And for all the curriculum vitae, you can see on the screen. And now, we will hear the presentation from Professor Dr. Delphak, but before it, allow me to inform the duration of the presentation is 35 minutes, and the discussion session will be in 15 minutes after the presentation. And reminder for the participants, please use your time to follow this presentation. For Professor Delphac, please, time is yours.
Okay, thank you very much. Can you hear my voice? Is it clear?
Yes.
Okay. Okay, that's good. Okay, so good afternoon, everybody. My name is Delphac Osyandi. First of all, I would like to thank the committee, Ibu Linda, and everybody else to invite me to give some presentation in this conference. So I would like to share my screen. Okay, so I hope everything is clear. So just let me know via chat or just tell me if there is something happening in the presentation. So basically, I'm working in the Division of Cardiovascular Science, and I'm a molecular biologist. So it's a bit surprised when I've been invited to talk in a meeting or conference talking about tuberculosis or TB, and specifically the drug resistant, the MDR-TB. So I think about that, and I think it's good to share a little bit of data and a little bit of experience from our research in Indonesia to see whether what we have done in our community-based intervention in Indonesia, whether this in the cardiovascular area, that something can be learned from this study and can be applied in the area of MDR-TB. Sorry about this. So I would like to start. The talk is divided into sections. So the first is just a little bit background of because I'm not expert in this area. It's probably better to go through first and then move to the second part of our cardiovascular study in Indonesia. So talking about antibiotic resistance in general, I think people will think about two factors mostly. Most of the people in this area thinks about there are two main things happening during antibiotic resistance. Factors inside the pathogens, in this case, the bacteria or virus or whatever it is, and then the factors in the host, in the human, in the patients. But I think there is another factor that's probably a little bit forgotten. It's the community factors, people around the patients that's involved that may influence the behavior, and also the social factors, information, facilities, access, and so on. So I would like to touch on these things in this talk by learning something that we have done in intervention, a community intervention that we've done in the area of cardiovascular disease. But before that, we just go back to the two factors that normally people think about, the scientists think. So why the bacteria, or in this case, if we talk about TB, develop the antibiotic resistance. But before that, we need to think about how the antibiotics normally works in killing the bacteria. So there are a lot of antibiotics available, and most of them working by this, summarized in this slides. So bacteria, antibiotics like ampicillin, penicillin, and so on, normally works by inhibiting the cell wall synthesis. Other antibiotics working on inhibiting enzymes, protein synthesis, for example, here erythromycin, chloramphenicol, tetracycline, and so on. And then others working by inhibiting enzymes within the bacteria to inhibit the metabolism. So then the bacteria can respond to that by developing some defense mechanism so that they can survive from the antibiotics. For example, if this in this diagram, if the antibiotic is the green dots, so the bacteria can change their mechanism to pump out the antibiotic out. They can alter the drug target. So some bacteria may change, or this is a process from mutation and so on, so that the drug target is mutated and is not sensitive anymore. And then other mechanisms include developing of some mechanism to inactivate the drug, and also make the cell impermeable to the antibiotics, like this one. So there's a lot of mechanistic action of the bacteria, how they evade, how they avoid the antibiotics. So the process is not easy, it's not quick. So this is something that I read in a journal in Lancet, and that's an example how an antibiotic is developed. Antibiotic resistance is developed. For example, in TB. So this is coming. The principle is a selection process. It's not natural selection, but it's probably close to the natural selection. So within the population, if you look at this on the top left-hand side, in the population of bacteria in 1% that infected, for example, in TB, there is always 1 or 2 or small percentage of bacteria that can develop or mutate to develop a resistance towards one of antibiotics. That's why in TB there are multiple antibiotics used. And then if you use, for example, here isoniazid, then all of the bacteria will kill, but only one, the green one, still survive. And then if you use only one TB drug, then this bacteria clone will proliferate, and then it will become the dominant strain in this patient. So then the patient will develop infection with isoniazid resistant bacteria. And then if you by the time there will be some other small proportion of the bacteria that develop the second mutation, and then it will resistant to the second antibiotic, rifampicin, for example. So that's the process, the long process, but can results in the development of multi-drug resistant bacteria. That's the bacterial factor, but also the other important part is the host factors, and that's involve the pharmacokinetics variability, absorption of the drug. So the host factor is how the patient reacts to the drug. So there are different kind of response. Pharmacokinetics means how the body reacts to the drug. They destroy it or they absorb it or whatever it is. And that's difference between one person to the other. So because TB is deep in the lung, in the alveolus, then if you have difficulties in absorption and distribution of the drug, so that the bacteria can survive because the concentration of antibiotic will be reduced at the remote area, at the area where the bacteria live. So this is a theory that I think this is my friend in UK, Indonesian doctor that's working in the UK, Dr. Satria Prabowo. So he's did his PhD in TB. So one theory of why Mycobacterium TB is really easy to develop a drug-resistant strain is because they have some ability in the stress condition. So for example, here the bacteria is red. Red means active. proliferating and causing disease, causing symptoms. Once they got the stress, and the stress can be hypoxia, physiological stress, host immunity, and then drug treatment. So if they got the drug, they become stressed. They can activate a system inside the bacteria. For example, this is the genes, the molecules that activate it. They change from the active form to become a metabolically inactive and not replicating, or a dormant or persister. In this condition, the bacteria still alive, but they don't replicate. They are not metabolically active, and they don't cause symptoms. They are not causing symptoms, and they are difficult to kill. And then if the stress gone, they can come back active again and causing symptoms. So that's the theory. So that means therapy against TB should be a long time. For example, if a patient get the antibiotic treatment, the first month, it's working all right. Then it causing some of the bacteria died, but some of them goes to dormant, persistent. Then the patients start to get better because the bacteria stop replicating, stop to get active. And then that's the point. If the patient's not taking the therapy because they feel everything is okay, I feel better. But the problem is the bacteria is still there. And if the therapy is not continued, then it goes back to the active condition. So that's why therapy for TB, antibiotic therapy need to be conducted long term, and the patient's adherence to drug is really important. If the patient's not taking the drug, or is not disciplined in taking the drug, that's the problem because of this mechanism. So now, because of that, the community support is really important. So this is one of the example why the factors outside the host and the bacteria is also very important. There are behavioral and social aspects that's involved in the development of MDR. It's not only the bacteria, it's not only the patient, but also the people around the patients, because the patients need support, patients need information, and all of these things, poorly trained healthcare workers that supporting the patient, or if there is no healthcare worker support, that will may lead to the interruptions of drug supply, interruptions of the patient taking the drug, or because of the poor information, poor support, there is a poor adherence. The patients forget to take the drug. And then there's another things related to the social economics, and also the poor facility of healthcare. If we talk about TB, we talk about people in the remote area, in the villages, not in the big city with big or good healthcare facilities. So this is the factor that need to be also to be think about. So how to address these problems? So I would like, in the next part of the talk, of my talk, I would like to introduce a system that we developed in empowering healthcare workers, but it's not in the context of TB, but in the context of cardiovascular disease. So this is the introduction, the first part of my talks. So now let's move to the case study. So we have a really good population research study, intervention or implementation of smart health cardiovascular in rural population in Indonesia, in particular in East Java, in Malang district, Kabupaten Malang in East Java. And this is a collaborative study between team in Manchester, me and Dr. Kindo Tampubolon, team in Sydney, Australia, Professor Anushka Patel, Dr. Pravin, and he's now in India, and team in Universitas Brawijaya in Malang. So before we move to that in detail, just a little bit background. Cardiovascular disease is, and also ischemic heart disease, stroke is a disease in the top rank that causes the most death in Indonesia. This is the data from, I think, from WHO. And TB is number 3. So heart disease is higher in terms of causing death in Indonesia. So what is the problem? So the problem is that the process of developing heart disease until death is quite a long process. So if a healthy heart, before it goes to failing heart, there is a lot of process, and it's initially caused by several primary disease like myocardial infarction or heart attack, hypertension, valve disease. And after that, if the patient survive, then the heart undergoes remodeling or change in morphology, become bigger and large and reduce the contractility function. And then if it is not treated well, it comes to death. So at the moment, if patients come to this stage, then the important things to do is early diagnosis, early treatment, and then long-term management, reduce the regression, and so on. But of course, we start to think, and these two, sorry, I'm back to that, need a therapeutic target, new therapeutic, good and effective therapy, and regeneration. But one important things before that happen, before the initial disease happen, is prevention of the primary disease, prevent the heart attack, prevent hypertension, and so on. So early detection and promotion of healthy lifestyle and so on is really important before somebody fall to this condition, heart failure, ischemic heart disease, and so on. So this is really important. So although I'm working on this part at the moment in my laboratory in Manchester, but I think that it's really important to go to the prevention thing. So I'm not a population scientist by training, but at one stage I moved with Professor Anushka Patel during one of the workshop in Indonesia, and she's the one that invented or developed the smart health technology. So the smart health is combination of empowering community health workers and developing a mobile health technology to improve the community support to us for a particular disease. So it can be applied to any disease, whatever disease, but in this case, she's developing for cardiovascular disease. So basically, there are two aspects: community empowerment of the community health workers and the mobile health. So this has been developed in Australia and then trialed in India and Bangladesh and some other countries. And then when she met me, she said that she wanted to try this in Indonesia because the result is not very good in India. So then I said, okay, that's a very good idea. So in terms of the community health workers, non-medically trained, we have a really good system in Indonesia, because I know when I was a medical student in Indonesia that in the Puskesmas, there's a lot of community health worker non-medically trained. That's the Kader Posyandu. So we think about doing a collaborative study. Then the two things here combined together and designed to do the early detection of cardiovascular risk, do the referral, prevention, and monitoring. And then the mobile health, the technology help us in monitoring, securing the data from apps from mobile health can go to the server and we can monitor it from everywhere. Every time the community health workers going around doing the work, then we can have the data and see it from Manchester, from Sydney, from everywhere else because it's stored in the server. So we've formed a collaboration, as I said before, from Manchester, George Institute, India, Brawijaya University, and Sydney. And the research question is very simple. Can this smart health system can control the cardiovascular risk and reduce the mortality or all the cardiovascular disease risk in the Indonesian rural, in the villages? And we take the location in Malang. We start doing the research in 4 villages or 4 kecamatan and desa in Malang. So, sorry, 8 for control and 4 intervention villages. So this is the design. So before the intervention started, we selected 4 villages, 8 villages for intervention and for control. And then we did a baseline survey to know the baseline population cardiovascular risk status, how to know what is the problem in this area. Then we recruit and train the community health worker or kader posyandu to run the smart health intervention by, it's not 6 months, it's more than that, 6 to 9 months in the 4 intervention only. The control is not intervene. And then we, after 2 years, we did final survey to compare between the CV risk, cardiovascular risk before and after the implementation of the smart health. So this is what we did. So this is the start of the study. We recruited surveyor, professional data collector. So they are very experienced, but we do some workshop to introduce the smart health and so on. And they did the survey house to house in the 4 village, in the 8 villages. Then all this is all the data that we collected, all the history of CV disease, smoking, blood pressure, and so on. So all people with the age more than 40 years were included in the study at that time. So then the software, the smart health, will automatically calculate the cardiovascular risk based on the WHO criteria. Then this is the initial survey. So we, so there are 4 villages control, 4 villages intervention, and around 11,000 people included in the study in the control, and more than 11,000 individuals or participants in the intervention villages. And from there, as you can see here, there's around 3,000 or more than 3,000 people have categorized or classified to have high risk to get cardiovascular disease. So 30%, more than 30%, and that's quite high. So what's the main problem? And we found that the main problem is hypertension, and then followed by obesity and diabetes. So if we calculate there, so the hypertension is more than 50% people, but not all will calculate at high risk because of the algorithm. But that means that hypertension is the biggest contributor. It's the problem, the biggest variable that determine the high cardiovascular disease risk. in this population. So this is published in this paper. You can have a look if you want to see the detail of the data. So this is some of the important point in the baseline characteristic. So as you can see here, the blood pressure is basically sky high. So 167 more in both in control and in the intervention. And then diabetes and so on is also 8%, 9%. That's probably similar to the national prevalence number that I'm aware. But importantly, if you see the low in the bottom here, only around 10% to 13% individuals that got a high blood pressure, they take the blood pressure lowering drug. Okay, so only small proportion of them that taking the anti-hypertension. That means this is the problem. So either they don't know that they have hypertension, or they know but they don't adhere to the drug prescription, or they are not aware, or they don't care about consuming or taking the drug. And that's probably, if I back to the first topic of the discussion of the presentation, probably that's the same problem as in the development of MDR-TB. A lot of people's not aware, or a lot of people's not adhere to take the drug. So we know this is the problem, and we then in the smart health intervention, we focus on the hypertension and focusing on making people taking the drug. So that's the focus of the 6 to 9 months intervention. So we recruited the cadres, 42 cadres. This is the characterization, as you know, cadre posyandu, mostly females, and good education background, at least high school. Then we train them to do some very basic analysis of how to measure blood pressure, measuring blood glucose, and so on. And then we give them a smart health pack, including tablet, computer, and all of this equipment, and how to operate the apps and so on. And so this is the apps. It's very simple apps. Basically, that's just to help us to monitor all the patients and all the intervention, because the apps, when they enter the data, it goes to the server straight away, so we can monitor it from everywhere else. And then they do the intervention. They go to the population, repeat the screening, and particularly focusing on people that's already identified as high risk. And we focusing on people with high blood pressure. Then what they do is they need to give support, so community support, social support, information support, and so on. So they send the people with high risk to the doctor, to puskesmas, or to the hospital. Then they need to make sure, so the bottom right here, in the follow-up, they need to monitor and to make sure that the patient or the individual with high risk take the drug, consume the drug. And that's need to be monitored. And we can also monitor how they're doing, because using the apps, we know what is the follow-up visit, how many visits during 6 or 9 months. So here we have 2,300 subjects that assigned the high-risk cardiovascular. And you can see here how many times got the visit. Only 32 got 5 visits, but that's okay during 6 months. But most of them at least got more than 600 or 800, 2 visits at least, or 3 visits. And that's very good, because after that, we do the post-intervention survey at the end. And what we've got is, you can see here, a reduction of the average blood pressure. So in the control, there is a reduction as well. So I can explain it why in the control without intervention is also reduced for 167 to 158. But as you can see, in the intervention villages, we got more significant decrease of blood pressure from 165 to 147. And the difference between intervention and control, if we do the statistic, is really strong, completely significant, and diastolic blood pressure as well. And then here, the second part here is really increase in the adherence to take the blood pressure antihypertensive drug. So in the control, there is an increase from 10% to 15%. That's because maybe when the surveyors came to visit them, they are aware of that they are got the disease and they just take the drug. But then in the intervention, because of the community support, the increase is really, really significant from 13% or 14 to 57, almost 60%. And that's probably the main driver of the reduction of blood pressure here. And if you can see here, this is just to sum up. In the control village, we got 9 points reduction of blood pressure from 167 to 158. And in the intervention village, we've got -18 reduction. So twice as strong. And the use of antihypertension is really increased from 14 to 59%. Individuals that adhere taking the drug. And that's, if we compare that, this will prevent 1 in 3 people with CV high risk to get the cardiovascular event, stroke or heart attack in 5 years. So if you remember, the risk to get the 5 years in the population is around 30%, the baseline. But then after smart health in the prevention, the intervention villages, it's down from 30 probably to 20. So 1 in 3, the 10% is gone, not gone dead, but it's gone become non-high CV risk. So that's a really success story, I think, just only less than 1 year intervention. Then if there's our collaborator in Australia that can do the health economics, and that's costing this money to prevent the CVD event or prevent the disability adjusted life years. I don't know about the detail, but basically a lot of money. Maybe if it is covered by BPJS, that's a lot of money saved because of the avoidance or prevention of the cardiovascular event, heart attack, stroke, and so on. And that's really interesting again, after 5 years. So this is, the intervention is between 2016 and 2018. Then our colleagues in Malang, they'll monitor the mortality in these 8 villages from 2018, yes, before about 17, 18 until 2021 or 22. And if you can see here, this is the mortality due to cardiovascular disease. It's significantly lower in the intervention villages up to 5 years, 60 months. This is months after the intervention. So the long-term effect is really, really significant. So this is the end of my story. So I hope I can give you a good example of how a community-based approach can tackle a problem in the cardiovascular risk. And in our setting in Malang villages there in Malang district, the main problem of hypertension, and the problem is one main problem, or among all of the important thing, is they don't know and they don't take the antihypertensive drugs. And then we intervene this by using smart health combination of empowering non-medically trained health workers, cadre, plus mobile health information system, and doing these 4 things: early detection, drug supply, improve adherence, and so on. And we've got really successful outcomes. Question is, the MDR-TB, back to the MDR-TB, the problem is about the same. Poorly trained health worker. Because of that, people's not taking the drug appropriately, poor adherence, and so on. Question is, can we use the same system to tackle the MDR-TB? I don't know, and it's up to people that's working on MDR-TB to prove that. So with that, I would like to stop, and I would like to thank the team in the Smart Health study for making this happening. So with that, I will stop here and hand it over to the moderator, and happy to take a question. Thank you very much.
Okay. Thank you very much to Professor Dr. Delphic, who has delivered a very interesting presentation about community-based approach to control cardiovascular risk in rural area Indonesia. So now we are entering the discussion session. So for all the participants who want to ask question, you can write the question in the link that we have provided. And for question and answer session, time is 15 minutes, start from now. Okay, there is question coming in. The first is from Mr. Alan. The question is, if a patient with MDR-TB has recovered from congenital heart disease, however, when the patient has recovered, he still suffers from heart disease. Is this patient at risk of getting MDR-TB again? And for Professor, time is yours.
Yes, very interesting question, but unfortunately, I'm not a clinician and I'm not the specialist of pulmonology. So I probably can only answer generally. So I know about heart disease a little bit, and the congenital heart disease will, of course, will be a factors in this condition. Congenital heart disease means that the heart's not very good in performing their work, so that blood supply and so on. So basically, the general health, including the immunity, including all the system in the body, is not perfect. So if they got TB, that's a double burden, double diseases. So of course, that's not good for the patients. So even if the patient recovered from the TB because of the congenital heart disease or the underlying heart disease, I'm very sure they are very susceptible to get another infection and so on. And as I said before, when in the theory of development of MDR-TB, the Mycobacterium TB have a specific characteristic to go dormant when they under stress. So if the therapy is successful, doesn't mean that they are already eliminated, but they may be there because they go to the dormant condition, and maybe with the weakened immune system in the patient with heart disease, then it is really easy for the bacteria to reactivate again, to become active and causing the disease again. I hope that answered the question.
Thank you for the answer, Professor. And their second question now, if from Mr. Suarja, SPDMKes, what is the death rate caused by pulmonary TB disease in Indonesia for a year? And for the professor, please welcome to answer.
Yes, I don't know exactly. You can see in my slide, this is rank number 3 after heart disease. But you can easily Google it. I don't know why you answered asking this. Just Google it and you can see the number. I don't know outside my head. Yes, I can Google it for you if you want.
Okay, so we move to the next question. The question from Ms. Nikadek Ayuputri.
Okay.
And the question is, what are the factors of difficulty that often occur in the field of when conduction? A basic survey of health workers regarding MDR-TB in the community. And for the professor, please
Yes,
answer.
thank you very much. Finally got a question that related to the talk. Right. So this is really important question, and it is important because first of all, I would like to say that this is the first success of smart health study, because as I said before, this is developed by people in Australia, and they said that the smart health system has been implemented in India and Bangladesh with not a very good success, but in Indonesia is success, very successful, in particular in Malang. So we try to evaluate this, and that's, of course, the question that your question is really important aspect here, because I think in Malang we are very successful because communication is really happening really well. So first, communication between us and the cadre, and also the health surveyor, and then from there, the cadre can communicate with the people in a really good manner, and that's the first key of the success. So it is really important. First, we have the cadre and all the people in the area is with us, in the same page with us, same idea with us, and then we work together to the community. And then number 2, the key of the success is monitoring. If we don't monitor it, then I don't think it will be successful. So we need to monitor whether the cadre really do their job. If the cadre really visit the community, their community. So one cadre is probably responsible for one RT or RW, 100 people to 200 maybe. No, probably just 100. That's really important. So we have people in Malang that's really dedicated to do that when this study happening. So they have some a base camp, like a postco there, and then they go around and monitor the cadre. And because this study is really funded by Pfizer Foundation and then from Australian government and so on, we got really good funding. So we hire or we pay people to do this, and we also pay the cadre when they perform really well. So there is a contract, something working contract. So that's some aspect. So I think that's, I hope, can answer the question. So the difficulty is how to communicate the idea first to the cadre, and second to the whole community, the villagers. And number two is how to monitor it. And if we can overcome these two, then all the intervention will, will happen and will be successful.
Okay, thank you for the answer, Professor. It will be the last question. Question from Mr. Seni Randonduwu. And the question is, permission to ask, Prof, cardiovascular disease, pharmacological and non-pharmacological treatment in Indonesia society is widely known for pharmacological treatment can prevent cardiovascular disease. Thank you. And for Professor.
So what is the question here? I don't see the question. Is it a statement or a question? Can you help me? What is the question here?
End of the question, Professor.
Yeah. Can you explain to me what is being asked? I don't. Yeah, it's pharmacological treatment is widely known for non-pharmacological treatment can prevent. What do you mean? Can you just say in Indonesia? In Indonesian? Saya bisa bahasa Indonesia kok. Yang bertanya langsung aja, tanya apa? Angkat tangan langsung bicara bahasa Indonesia aja.
Question is cardiovascular disease, pharmacological and non-pharmacological treatment in the Indonesia society, widely known for
Ya, ini siapa? Ibu Seni Rondonwu. Silakan langsung ditanyakan aja langsung, nggak usah pakai tulisan-tulisan. Kalau ada di itu langsung angkat tangan, langsung bicara aja. Gitu lebih enak sekali. Saya nggak ngerti soalnya yang dimaksud apa itu. Bisa nggak? Can you do that? Just open the unmute and then just ask the question directly.
For Mr. Seni. Wait for a minute, Professor.
Yeah.
Okay, sorry before Professor. Mr. Seni, can I join with us to explain the question? And I think that it's not question.
Halo, sudah jalan halo. Maaf jaringan, halo,
Okay,
halo.
please, Miss
Ya,
Seni.
silakan. Please.
Terima kasih Prof atas kesempatan yang diberikan. Yang ingin saya tanyakan, bertanya, penyakit kardiovaskular ini kan pengobatannya mungkin kita kenal ada yang farmakologi dan non farmakologi.
Ya.
Jadi di Indonesia kan sekarang lagi dikenal banyak masyarakat tentang penyakit tentang pengobatan secara non farmakologi.
Contohnya?
Mengkonsumsi ramuan-ramuan, mengkonsumsi ramuan yang mencegah kardiovaskular, misalnya hipertensi, apakah itu aman untuk dikonsumsi, dan juga bagaimana treatment yang non farmakologi yang bisa aman kita lakukan untuk mencegah terjadinya kasus kardiovaskular. Terima kasih, Prof.
Ya, terima kasih. Okay, so I know what you mean now. Saya sekarang mengerti pertanyaannya. Maaf tadi kurang jelas kalau dengan dengan di slides tadi ya. Jadi maksudnya itu yang non medical yang pakai tradisional gitu ya, with traditional medicine and so on. I think, atau saya pakai bahasa Indonesia aja ya, mestinya diluruskan dulu. Sebenarnya terapi non farmakologi itu ada memang yang di cardiovascular disease, tapi bukan dengan yang ramuan itu ya. Yang kita mengerti dengan non farmakologi itu misalnya perubahan gaya hidup, itu penting. Misalnya yang sebelumnya dietnya tidak sehat, banyak makan lemak dan sebagainya, berubah menjadi diet yang lebih sehat, atau yang diabetes mengurangi yang banyak gula-gula dan seterusnya, yang hipertensi mengurangi garam-garaman, kemudian berolahraga, itu yang disebut intervensi non farmakologis. Dan itu berhasil dan banyak, tapi hanya pada satu level tertentu. Jadi untuk yang sudah risikonya sangat tinggi, di atas 10-20%, terapi farmakologis itu penting. Jadi tidak bisa hanya dengan yang perubahan gaya hidup atau lifestyle modification, itu istilahnya gitu. Nah, sekarang ke yang kedua tadi, yang dimaksud Ibu tadi, terapi dengan menggunakan bahan-bahan tradisional dan seterusnya. Nah, ini di area abu-abu ini menurut saya, karena kalau pakai bahan ramuan tradisional kita nggak tahu apa zat aktif di situ. Itu sebenarnya farmakologis juga menurut saya ya, karena memasukkan bahan-bahan yang aktif secara kimiawi untuk dimasukkan ke tubuh. Bedanya bahan-bahan yang tradisional tadi, pengobatan itu tidak ada bukti ilmiahnya atau hanya disebut sebagai empiris saja, karena dibilang oh ini sudah pernah memakai, sudah untuk katakanlah menurunkan tekanan darah bisa, tapi tidak pernah ada yang tradisional itu uji klinis yang benar-benar bisa kita andalkan. Angka-angkanya, statistiknya itu biasanya tidak sekuat dengan obat-obatan yang medis, yang farmakologis yang sudah ada yang biasanya diresepkan oleh dokter itu. Jadi biasanya kalau empiris itu hanya cerita dari bukti-bukti apa itu istilahnya itu dari omongan dari mulut ke mulut saja, dan tidak ada hitungannya. Yang gagal nggak pernah cerita gitu. Jadi testimoni istilahnya, testimoni based medicine, bukan evidence based medicine, bukan berdasarkan bukti ilmiah, tapi berdasarkan testimoni. Saya tidak mengatakan bahwa semua obat tradisional itu tidak manjur atau apa, tapi kalau tidak ada bukti ilmiahnya, biasanya kita yang dari ilmiah tentu nggak bisa merekomendasikan secara ilmiah. Jadi saya kira itu jawabannya.
Thank you for the professor from the answer. And we next to the last question. The question is, with the all various problem encountered, in your opinion, do you think this method can be applied on a larger scale with a lot more rural areas in Indonesia
Okay.
to prevent CVD risks or hypothetically TB risks in general? Would it be worth an effort?
Yes. So, sorry, I missed the first part. So the question is about the smart health intervention, isn't it?
About the
Oh,
question.
yes. Okay, good. Yep. So yes, the answer is yes. Of course, with the success of the first smart health implementation or intervention in Malang in 2016, 2018, that is a big success. The first part is only 4 villages per 4 and 4 controls, and now it's implemented in a bigger area. So at the moment we implemented in 100 villages in Malang, and that's together with the Dinas Kesehatan, health authority, local health authority in Kabupaten Malang, with also support from Australian government. So we are waiting for the results in the medium scale, or maybe it's large scale already with 100 villages. The Malang district chief or Bupati Malang wants to implement to the whole kabupaten, the whole district, about 400 villages, but at the moment probably because of the limit in the resources that we have, then we start with 100, and this one is already recognized by the Ministry of Health. I think the Kabupaten has got the award from the Minister of Health a few years ago regarding this innovation. And of course, as a scientist who works and initiate this study, if the question is whether this will be successful in the wider context, I would like to say yes, 100% yes, or maybe 99.9% yes. But of course, there are a lot of factors. For example, as I said before, communication, participation, monitoring is really important, and that's a lot of factors contributing to that, and also the characteristic of the people in the area, whether they can accept that or reject the idea. This is really important. So if in Malang is successful for 4 villages, I believe that in 100 villages, it will be in around Malang, it will be there. But in other area, if you put this system in a different, really different community characteristic, of course, the answer is still, I don't know. It depends on how you implement, how to communicate, how to implement, how to monitor, and so on. So for example, in people with different characteristics, in maybe in Manado, in Sulawesi, they different than people in Java. That's probably different outcome, and we never know before we try it. That's the mantra of a scientist. We need to try it, see the data, and then we will know whether it will be successful or not. Because in India, it's not very good results. In Bangladesh, probably not very good, but in Malang, it's very successful. Okay.
Okay, thank you for the answer. That answer marks the end of the session. We apologize for the question that cannot be answered due to the limited time. And for the professor, we apologize because the delay of our schedule. And after the end of this conference, the committee will share the handout, all the topic in the conference. And now, the Honorable for Professor, we will give an appreciation in the form of an online certificate. Okay, before we end this session, we will take a documentation. So for all the participants, turn on the camera. Start from slide 1. Next to the slide 2. Next to the slide 3. And next for the last slide. Big thank you for Honorable Professor Dr. Delphak Oshendi, MD PhD, as our speakers today. And thank you for all the participants. I give the session next to the Master of Ceremony.
Oke, terima kasih. Saya izin leave ya. Selamat sore semuanya. Terima kasih.
Selamat sore, terima kasih.
Thank you, Suirat and Professor Dr. Delphak Ushandi, and all the speakers and moderators in charge.
And now, I would like to greet our friends who are joined in the Zoom meeting. Or maybe, if you don't mind, maybe you can greet and say hello in the comment section below.
Okay, we will end the series of activities today with prayer, and the prayer which will be delivered by Miss Nadila Mokodongan.
Good evening. Because we arrived at the end of our international conference, we'll end with prayer. Let me get the prayer with my religion is Muslim. Pray begin. Auzubillahiminasyaitonirrajim. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin. Ar-Rahmanirrahim Maliki yaumiddin. Iyyaka na'budu wa iyyaka nasta'in. Ihdina siratal mustaqim. Siratal ladzina an'amta 'alaihim ghairil maghdubi 'alaihim waladdallin. Bismillahirrahmanirrahim. Asyhadu alla ilaha illa wahdahu la syarikalah wa asyhadu anna Muhammadan abduhu wa rasuluhu la nabiyya ba'da amma ba'du. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina azabannar. Subhanaka rabbil izzati amma yasifun. Wassalamu alal mursalin walhamdulillahi rabbil alamin. Amin.
Thank you to Miss Nadila Mokodongan. And it's been a pleasure for being with all of us today.
Once again, we would like to thank all the attendees, both local and foreign, especially to our extraordinary speakers, and also to the director who had the opportunity to attend our conference today.
And once again, I will remind to all the participants to don't forget to fill the attendance in the comment section. And hopefully the conference today can benefit for all of us. I'm Mikhail Mefit Kumiang.
And I, Jennifer Margaret Pontolawaka, say goodbye and apologize if there are any mistake in word or action.
And see you tomorrow in the same Zoom meeting with
oral presentation
and poster presentation.
See ya!
Pada bulan Juli tahun 2019, SK Menteri Riset Teknologi dan Pendidikan Tinggi Republik Indonesia nomor 596/KPT-1/2019 mengubah nomenklatur program studi D3 Analis Kesehatan menjadi program studi D3 Teknologi Laboratorium Medis atau TLM. Seiring dengan beralihnya nomenklatur, gelar untuk lulusan prodi D3 Teknologi Laboratorium Medis juga beralih dari yang sebelumnya ahli madya analis kesehatan menjadi ahli madya kesehatan atau AMDKes. Untuk menjamin mutu dan keberlangsungan pendidikan, prodi D3 Teknologi Laboratorium Medis sudah terakreditasi unggul oleh Lembaga Akreditasi Mandiri Perguruan Tinggi Kesehatan atau LAM-PTKes dengan nomor SK 0350 tanggal 27 Agustus 2021. Selaras dengan visi untuk menjadikan prodi D3 Teknologi Laboratorium Medis sebagai kampus yang mampu bersaing secara global pada tahun 2024 serta unggul, mandiri dan berbudaya dalam pelayanan diagnostik tuberkulosis paru dan penyakit penyerta, para lulusan prodi D3 Teknologi Laboratorium Medis Poltekkes Kemenkes Manado telah berhasil tersebar di wilayah Indonesia, diantaranya pada instansi dinas kesehatan, rumah sakit, puskesmas, laboratorium klinik, Badan Pengawas Obat dan Makanan atau Badan POM, Balai Teknik Kesehatan Lingkungan atau BTKL, Balai Penunjang Pelayanan Kesehatan atau BPPK, KKP Udara atau KKP Laut, Nusantara Sehat atau NS, serta di berbagai macam instansi pemerintah atau swasta lainnya. Jumlah mahasiswa yang menempuh studi pada prodi D3 Teknologi Laboratorium Medis tercatat sebanyak 953 orang, dengan jumlah lulusan sebanyak 626 lulusan. Program studi D3 Teknologi Laboratorium Medis Politeknik Kesehatan Kemenkes Manado juga memiliki tenaga pengajar dengan kualifikasi pendidikan magister dan doktor yang merupakan lulusan dari berbagai universitas ternama di seluruh Indonesia. Kesempatan belajar pada prodi D3 Teknologi Laboratorium Medis juga terbuka luas hingga skala internasional. Beberapa mahasiswa pernah mengikuti berbagai macam kegiatan bertaraf internasional, diantaranya mengikuti short course program di Dongseo University, Busan, Korea Selatan pada tahun 2017 dan menjadi tutor ASEAN Science Camp pada tahun 2019. Sesuai dengan Tridharma Perguruan Tinggi, melalui kegiatan pengabdian pada masyarakat, prodi D3 Teknologi Laboratorium Medis Poltekkes Kemenkes Manado tak hanya mengabdi di beberapa daerah di Sulawesi Utara, tetapi juga berhasil dengan baik mengabdi di berbagai daerah di luar Sulawesi Utara. Dengan tujuan menghasilkan tenaga kerja yang kompeten, prodi D3 Teknologi Laboratorium Medis menyediakan sarana dan prasarana berupa gedung 4 lantai dengan fasilitas diantaranya ruang kelas yang kondusif, laboratorium yang terdiri dari laboratorium bakteriologi virologi, laboratorium parasitologi mikologi, laboratorium imunoserologi sitohistologi biomo, laboratorium hematologi, laboratorium kimia klinik, laboratorium kimia terapan, laboratorium toksikologi, ruang lobi, ruang himaju, ruang meeting, ruang klinik P3K, serta berbagai macam fasilitas lainnya.
Program Studi Diploma 3 Teknologi Laboratorium Medis atau TLM Politeknik Kesehatan Kemenkes Manado secara resmi berdiri tahun 2010, sekaligus mulai menerima mahasiswa baru perdana tahun akademik 2010-2011. Teknologi Laboratorium Medis merupakan program studi satu-satunya di Provinsi Sulawesi Utara sampai dengan sekarang.
Mari bergabung bersama Prodi D3 Teknologi Laboratorium Medis Poltekkes Kemenkes Manado dan bersama wujudkan Poltekkes Kemenkes Manado sebagai institusi pendidikan kesehatan vokasi yang unggul, mandiri, dan berbudaya. Pada bulan Juli tahun 2019, SK Menteri Riset Teknologi dan Pendidikan Tinggi Republik Indonesia nomor 596/KPT-1/2019 mengubah nomenklatur program studi D3 Analis Kesehatan menjadi program studi D3 Teknologi Laboratorium Medis atau TLM. Seiring dengan beralihnya nomenklatur, gelar untuk lulusan Prodi D3 Teknologi Laboratorium Medis juga beralih dari yang sebelumnya Ahli Madya Analis Kesehatan menjadi Ahli Madya Kesehatan atau AMDKes. Untuk menjamin mutu dan keberlangsungan pendidikan, Prodi D3 Teknologi Laboratorium Medis sudah terakreditasi unggul oleh Lembaga Akreditasi Mandiri Perguruan Tinggi Kesehatan atau LAM-PTKes dengan nomor SK 0350 tanggal 27 Agustus 2021. Selaras dengan visi untuk menjadikan Prodi D3 Teknologi Laboratorium Medis sebagai kampus yang mampu bersaing secara global pada tahun 2024, serta unggul, mandiri, dan berbudaya dalam pelayanan diagnostik tuberkulosis paru dan penyakit penyerta, para lulusan Prodi D3 Teknologi Laboratorium Medis Poltekkes Kemenkes Manado telah berhasil tersebar di wilayah Indonesia, diantaranya pada instansi dinas kesehatan, rumah sakit, puskesmas, laboratorium klinik, Badan Pengawas Obat dan Makanan atau Badan POM, Balai Teknik Kesehatan Lingkungan atau BTKL, Balai Penunjang Pelayanan Kesehatan atau BPPK, KKP Udara atau KKP Laut, Nusantara Sehat atau NS, serta di berbagai macam instansi pemerintah atau swasta lainnya. Jumlah mahasiswa yang menempuh studi pada Prodi D3 Teknologi Laboratorium Medis tercatat sebanyak 953 orang, dengan jumlah lulusan sebanyak 626 lulusan. Program studi D3 Teknologi Laboratorium Medis Politeknik Kesehatan Kemenkes Manado juga memiliki tenaga pengajar dengan kualifikasi pendidikan magister dan doktor yang merupakan lulusan dari berbagai universitas ternama di seluruh Indonesia. Kesempatan belajar pada Prodi D3 Teknologi Laboratorium Medis juga terbuka luas hingga skala internasional. Beberapa mahasiswa pernah mengikuti berbagai macam kegiatan bertaraf internasional, diantaranya mengikuti short course program di Dongseo University, Busan, Korea Selatan pada tahun 2017 dan menjadi tutor ASEAN Science Camp pada tahun 2019. Sesuai dengan Tridharma Perguruan Tinggi, melalui kegiatan pengabdian pada masyarakat, Prodi D3 Teknologi Laboratorium Medis Poltekkes Kemenkes Manado tak hanya mengabdi di beberapa daerah di Sulawesi Utara, tetapi juga berhasil dengan baik mengabdi di berbagai daerah di luar Sulawesi Utara. Dengan tujuan menghasilkan tenaga kerja yang kompeten, Prodi D3 Teknologi Laboratorium Medis menyediakan sarana dan prasarana berupa gedung 4 lantai dengan fasilitas diantaranya ruang kelas yang kondusif, laboratorium yang terdiri dari laboratorium bakteriologi virologi, laboratorium parasitologi mikologi, laboratorium imunoserologi sitohistologi biomo, laboratorium hematologi, laboratorium kimia klinik, laboratorium kimia terapan, laboratorium toksikologi, ruang lobi, ruang himaju, ruang meeting, ruang klinik P3K, serta berbagai macam fasilitas lainnya.
Program Studi Diploma 3 Teknologi Laboratorium Medis atau TLM Politeknik Kesehatan Kemenkes Manado secara resmi berdiri tahun 2010, sekaligus mulai menerima mahasiswa baru perdana tahun akademik 2010-2011. Teknologi Laboratorium Medis merupakan program studi satu-satunya di Provinsi Sulawesi Utara sampai dengan sekarang.
Mari bergabung bersama Prodi D3 Teknologi Laboratorium Medis Poltekkes Kemenkes Manado dan bersama wujudkan Poltekkes Kemenkes Manado sebagai institusi pendidikan kesehatan vokasi yang unggul, mandiri, dan berbudaya. Pada bulan Juli tahun 2019, SK Menteri Riset Teknologi dan Pendidikan Tinggi Republik Indonesia nomor 596/KPT/1/2019 mengubah nomenklatur program studi D3 Analis Kesehatan menjadi program studi D3 Teknologi Laboratorium Medis atau TLM. Seiring dengan beralihnya nomenklatur, gelar untuk lulusan prodi D3 Teknologi Laboratorium Medis juga beralih dari yang sebelumnya Ahli Madya Analis Kesehatan menjadi Ahli Madya Kesehatan atau AMDKes. Untuk menjamin mutu dan keberlangsungan pendidikan, prodi D3 Teknologi Laboratorium Medis sudah terakreditasi unggul oleh Lembaga Akreditasi Mandiri Perguruan Tinggi Kesehatan atau LAM-PTKes dengan nomor SK 0350 tanggal 27 Agustus 2021. Selaras dengan visi untuk menjadikan prodi D3 Teknologi Laboratorium Medis sebagai kampus yang mampu bersaing secara global pada tahun 2024 serta unggul, mandiri dan berbudaya dalam pelayanan diagnostik tuberkulosis paru dan penyakit penyerta, para lulusan prodi D3 Teknologi Laboratorium Medis Poltekkes Kemenkes Manado telah berhasil tersebar di wilayah Indonesia, diantaranya pada instansi dinas kesehatan, rumah sakit, puskesmas, laboratorium klinik, Badan Pengawas Obat dan Makanan atau Badan POM, Balai Teknik Kesehatan Lingkungan atau BTKL, Balai Penunjang Pelayanan Kesehatan atau BPPK, KKP Udara atau KKP Laut, Nusantara Sehat atau NS, serta di berbagai macam instansi pemerintah atau swasta lainnya. Jumlah mahasiswa yang menempuh studi pada prodi D3 Teknologi Laboratorium Medis tercatat sebanyak 953 orang, dengan jumlah lulusan sebanyak 626 lulusan. Program studi D3 Teknologi Laboratorium Medis Politeknik Kesehatan Kemenkes Manado juga memiliki tenaga pengajar dengan kualifikasi pendidikan magister dan doktor yang merupakan lulusan dari berbagai universitas ternama di seluruh Indonesia. Kesempatan belajar pada prodi D3 Teknologi Laboratorium Medis juga terbuka luas hingga skala internasional. Beberapa mahasiswa pernah mengikuti berbagai macam kegiatan bertaraf internasional, diantaranya mengikuti short course program di Dongseo University, Busan, Korea Selatan pada tahun 2017 dan menjadi tutor ASEAN Science Camp pada tahun 2019. Sesuai dengan Tridharma Perguruan Tinggi, melalui kegiatan pengabdian pada masyarakat, prodi D3 Teknologi Laboratorium Medis Poltekkes Kemenkes Manado tak hanya mengabdi di beberapa daerah di Sulawesi Utara, tetapi juga berhasil dengan baik mengabdi di berbagai daerah di luar Sulawesi Utara. Dengan tujuan menghasilkan tenaga kerja yang kompeten, prodi D3 Teknologi Laboratorium Medis menyediakan sarana dan prasarana berupa gedung 4 lantai dengan fasilitas diantaranya ruang kelas yang kondusif, laboratorium yang terdiri dari laboratorium bakteriologi virologi, laboratorium parasitologi mikologi, laboratorium imunoserologi sitohistologi biomo, laboratorium hematologi, laboratorium kimia klinik, laboratorium kimia terapan, laboratorium toksikologi, ruang lobi, ruang himaju, ruang meeting, ruang klinik P3K, serta berbagai macam fasilitas lainnya.
Program Studi Diploma 3 Teknologi Laboratorium Medis atau TLM Politeknik Kesehatan Kemenkes Manado secara resmi berdiri tahun 2010, sekaligus mulai menerima mahasiswa baru perdana tahun akademik 2010-2011. Teknologi Laboratorium Medis merupakan program studi satu-satunya di Provinsi Sulawesi Utara sampai dengan sekarang.
Mari bergabung bersama Prodi D3 Teknologi Laboratorium Medis Poltekkes Kemenkes Manado dan bersama wujudkan Poltekkes Kemenkes Manado sebagai institusi pendidikan kesehatan vokasi yang unggul, mandiri, dan berbudaya.